Everyone, respected teachers, distinguished speakers, colleagues, and dear friends. I am Dr. Kritika Singh, and along with Dr. Amol and Dr. Geetika, senior residents in the Department of Pediatric Surgery, we will take you through today's CME. It gives us immense pleasure to welcome you all to today's CME program on multidisciplinary approach in management of spina bifida, from diagnosis to rehabilitation. Today's gathering is not just an academic exercise, but also a celebration of the 27th Foundation Day of Department of Pediatric Surgery at King George Medical University, Lucknow. As we all know, pediatric surgery is a constantly evolving specialty. From neonatal care to complex reconstructive procedures, advances in technology and research are shaping the way we approach the surgical care of children. A CME such as this gives us the perfect opportunity to take a break from our busy routines, come together and exchange knowledge that directly benefits our young patients. We are privileged to have with us today eminent faculty, surgeons, teachers, and researchers who will be sharing their insights and experiences with us today. Their contributions will not only enhance our understanding, but also inspire us to carry forward this legacy of excellence in pediatric surgery. We extend a warm welcome to our distinguished guest speakers whose presence has elevated this CME. We also welcome all the delegates who have joined us, traveling from far and near, to be a part of this academic feast. Let us make this day one of active learning and rich discussion, where questions are encouraged, ideas are exchanged, and collaborations are born. I am confident that by the end of today's program, we will all return to our patients with renewed enthusiasm and deeper knowledge. So with those words, I once again welcome all of you and wish today's CME a great success. I would like to call upon the chairpersons for the first two sessions, Professor S.N. Singh, Dr. Namrata Kumar, and Dr. Om Purbe. Sir and ma'am, kindly come onto the stage, please. Our first speaker for today is Professor Smriti Agrawal. Ma'am is a professor in the Department of Obstetrics and Gynecology at King George Medical University, Lucknow. She is former head of Department of Obstetrics and Gynecology at Dr. RML Lucknow, and she has accomplished multiple things, won multiple awards, and she has more than 65 publications.
Thank you so much. That's okay. Thank you. A very good morning, respected chairpersons, all the esteemed faculty and the dignitaries present here in this hall. Before I begin my talk, I would like to congratulate the Department of Pediatric Surgery on its 27th Foundation Day. I know the department has come very far, and this is a very important topic. From an obstetrician's perspective, I'm going to be talking about the neural tube defects, what are the advances in prenatal screening, what is the role of ultrasound and fetal MRI, and comprehensive fetal assessment we undertake before we decide what exactly we need to do in the pregnancy. So we know that embryologically, the neural tube closure occurs in the 3rd and the 4th week of gestation. This is the time when a woman actually does not know that she is pregnant. The closure of the neural tube begins at the cervical region and it extends cranially and caudally. The neural tube defects are not so uncommon. The incidence is 0.5 to 2 per 1,000 live births worldwide. And we see a rise in the number of the patients who have neural tube defects. It increases to 2 to 3% if one pregnancy is affected and 10% if 2 or more pregnancies have been affected. Now, the problem is neural tube defects comes with its significant morbidity and mortality and long-term disability. It is a burden to the family as well as to the society. Public health concern is there because even though folic acid supplementation has been there for a very long time, even then we see a large number of women with neural tube defects. Neural tube defects are many, and of course we know that the commoner ones are anencephaly, the spina bifida which can be open or closed, encephalocele, craniorachisis, and anencephaly. So who are those women who can have neural tube defects? Obviously, folic acid deficiency tops the list. Along with that, maternal obesity and diabetes is a very important contributing factor. Anti-epileptic medications like valproate and carbamazepine also leads to neural tube defects. Genetic predisposition. Presence of hypothermia, the women who have febrile illness during that period when neural tube closure is happening usually can develop neural tube defects. And of course, environmental and teratogenic exposures. But what is important to know is that 90% of the children who are born with neural tube defects are born to women who do not have any identifiable risk factors. So that is where comes the role of prenatal screening. So folic acid, as I said, tops the list. So preconceptional, if a woman takes folic acid, it reduces the risk of NTDs by 50 to 70%. So it is recommended that all the women who are planning a pregnancy must take 400 microgram of folic acid at least 1 month prior to conception and should continue it for the entire first trimester. But obviously, because a woman does not know when she is going to become pregnant, so it is recommended that anybody who is planning a pregnancy must continue to take 400 microgram of folic acid daily till she conceives. And the women who are at high risk of neural tube defects, for example, if they're diabetic, they're on anti-epileptics, or they've had a previous neural tube defect, they must take 4 milligram of folic acid daily, at least 3 months prior to conception and for the entire first trimester. Residual cases will still happen due to non-folate causes. Now, as I said, that because the risk is so high, even in the non-risk population, it is important to do a universal biochemical screening. It is important to do a universal screening. How much biochemical screening actually helps, we will see that. For many years now, maternal serum alpha-fetoprotein has been used as a screening tool. But it is important to know that the women who have open neural tube defects, they will have a rise serum alpha-fetoprotein, but not the women who have a closed neural tube defect. And gestational age and the type of neural tube defect is also going to have a bearing on the levels of serum alpha-fetoprotein. For example, in the first trimester, if there is anencephaly, the detection rate is more than 90%, for encephalocele more than 80%, but in the first trimester alone, the detection of spina bifida by alpha-fetoprotein is only 44%. So even if alpha-fetoprotein is high, it is not a diagnostic test for neural tube defect because it can be high because of several other reasons also. First and foremost is the inaccurate gestational dating. A patient may be having a multiple pregnancy. She may be having fetal abdominal wall defects like omphilocele, fetal nephrosis, even in intrauterine fetal deaths, alpha-fetoprotein levels will rise, and certain placental conditions as well. So we have quadruple test and we have cell-free fetal DNA, but they do not have any well-defined role in diagnosis or screening of neural tube defects. So then comes the role of scanning. Second trimester scanning improves the detection of spina bifida, typically to 92 to 95%, which is pretty high. In diagnosing NTD, it is important not just look at the brain and the spine, but look at the entire detailed fetal anatomy because there can be associated malformations to the tune of around 20%. So now when we say ultrasound, the first and foremost thing is we look at the cranium. If a patient has anencephaly, it will show a typical picture of Mickey Mouse bilobular face. It will show cystic formations, elongation, and the head shape will also be pretty irregular. It is also important that in the mid-trimester scans, we do a thorough evaluation of fetal head shape, size of the ventricles, subarachnoid space, posterior fossa size, and cerebellar contour, to name a few. Now next comes the spine, the spina bifida. Now spina bifida is usually present with a bony defect, from where there is a protrusion of either the meninges alone, which is meningocele, or meninges along with the neural tissue, which is called as meningomyelocele. Now, all these lesions, they arise from dysraphism, which is a defect of closure. And depending upon whether there is an intact overlying skin, it is called as open or closed. Now, closed lesions definitely have a more favorable prognosis, which includes lipomas, teratomas, hematomas, and myelocystocele. Now, ultrasound is extremely important, and when we look at the spine, we must look at all the three sections, which is axial plane, sagittal plane, and coronal plane. We can easily identify the bony defect by splaying of the posterior lamina ossification centers. Along with that, in Arnold-Chiari malformations, we see Lemon sign, which we know is the concavity of the fetal skull bone. Then we have banana sign, where the cerebellum is pulled into the pons and it appears like a banana. Chiari-2 malformation association, look at the size of the ventricles, and if it is more than 10 milliliter, it can be an indicative of a neural tube defect. And spinal dysraphism, as I just mentioned. As we can see here, the ventricles are enlarged and the spinal dysraphism is evident on ultrasound. Now, of course, ultrasound also, we have 3D and 4D technology available, and it definitely comes in hand whenever we have to diagnose a case of neural tube defect and inform the parents about what exactly the lesion is and what is the prognosis of it. It also helps us in better surgical planning. What is important to understand is all the fetus who have a lesion at L4 or below, usually they do well because they have good mobilities. So it is important to understand what exactly the site of the lesion is, and there must be good efforts to classify whether the lesion is L3, L4, or L5. But ultrasound is not everything because it is operator dependent and it has its own limitations, especially a woman who is obese, and we have seen that maternal obesity is a very important risk factor. Then, of course, if the liquor is minimal or reduced, then the vision becomes very poor, and these neural tube defects can be missed. Sometimes the spine is posterior, and it is very difficult to look at the spine clearly. So these are the limitations of ultrasound where neural tube defects can be missed. So then we move on to the fetal MRI. Whenever we think that there is some kind of a suspicion, we are not sure of what we are seeing, or there is a complex kind of an anomaly, fetal MRI is, of course, a very, very useful tool. It is also superior for CNS anatomy and associated brain malformations. Remember, we cannot be ordering fetal MRI straight away because it only complements the ultrasound and does not replace it. So it is used when there is some kind of confirmation is needed for equivocal ultrasonographic findings, or we need a detailed evaluation because we need to do a surgical planning, or we need to counsel the parents. So it helps definitely in better delineation, Chiari-2 malformation assessment, assessing the cortical development, looking at the contents of encephalocele. So MRI can be a very, very useful tool. Now, once we have done the screening with the help of biochemical as well as ultrasound, we need to do a comprehensive fetal assessment. And that is the theme of today's CME, where multidisciplinary approach has to be taken with fetal medicine specialists, radiologists, neonatologists, and of course the pediatric surgeons should be a part of the team looking after the patient. So for comprehensive assessment, we look at the site of the lesion, the extent of the lesion, whether there is associated Chiari-2 malformation or hydrocephalus, and other associated anomalies. So now the question which comes to our mind is, once we have diagnosed, should we do a karyotyping? Should it be offered to all the women who have neural tube defects? Well, we know that the chromosomal anomalies like trisomy 18, 13, and triploidy are the commonest. And usually when there are associated structural anomalies, the chromosomal anomaly rates approach 25%. But if there are no other associated structural anomalies, then the incidence of karyotyping abnormalities are lower, to the tune of 1.3% in anencephaly, cephalocele you have 9%, and meningomyelocele 2.6%. So karyotyping should be offered to those women where we find associated structural anomalies, because then you must also look at the other syndromes, especially I would like to mention here the autosomal recessive Meckel-Gruber syndrome. So now if a patient has a fetus with neural tube defect, there are 3 options which we can give her. Number 1, terminate the pregnancy well within the stipulated time. Number 2, do an expectant management of the pregnancy, take the pregnancy to term, deliver the baby, and offer the surgical repair in the neonatology period. Or number 3, which is a very advanced fetal therapy, not yet available in most of the places, is in utero fetal repair for appropriate candidates. But whenever we are offering to a woman to continue her pregnancy, we have to be very sure with what we are dealing with. We need to get her karyotyping done in order to be sure that there are no other associated chromosomal anomalies. We have to be sure that there are no other structural anomalies. Only then we can counsel the parents for regarding the prognosis. We can counsel her for pregnancy management and determine that if at all in utero fetal therapy is available, whether we should offer her that or not. So fetal parents are primarily involved in understanding whether fetal karyotyping should be offered and whether the pregnancy should be continued or terminated. And of course, the type of the lesion and the type of the neural tube defect will definitely guide us as to how to counsel the women. And severity will depend whether there is an associated motor sensory function involvement, hydrocephalus, and what is the level of spinal deformity. So whenever we have a pregnant woman, there are certain points which we need to counsel about. Number one is important mobility or ambulation, because anybody who is told that your fetus has a spinal problem, she is going to ask, is my child going to be well? Well, this is an important lead which we have, that normally when the lesion is L4 or below, they have better physical function. Sometimes scoliosis is also a part of the neural tube defects, but it can happen in half of the cases of spina bifida. But scoliosis is not always associated with reduced physical capability, and the prognosis is not always grim. The next question which she asks is my child going to be with normal intelligence? So intelligence is definitely related to the level of where the spine is disrupting and presence of hydrocephalus. A lot of times it is seen that even the patients who have myelomeningocele, they can have normal intelligence. However, cognitive defects are common, and they relate to the presence of anal-Chiari malformation or hydrocephalus, and also the status of midbrain cortex and corpus callosum. The next thing which comes as a very handy thing is when we are counseling women about the urinary and fecal incontinence. Most of the patients have lower urinary tract dysfunction, and all the babies who have voiding dysfunction may develop chronic kidney disease, and 30 to 40% of them develop some kind of renal dysfunction. So it is important, we will be hearing over the entire day how these babies are managed in order to prevent chronic renal disease affecting them. Now, of course, my talk would not be complete before I talk about the MOM study, where a randomized trial was undertaken for prenatal versus postnatal repair of myelomeningocele. Here, this study showed that prenatal surgery resulted in definitely better fetal and neonatal survival. It also reduced the need for shunting in the neonatal period and improved the mental development and motor outcomes at 30 months. So they included a strict criteria, which was that the lesion should be above S1, there should be presence of Chiari 2 malformation, singleton pregnancy, baby with normal karyotyping, and no significant fetal scoliosis. Normally, this in utero fetal therapy is offered between 20 and 26 weeks of gestation. So, of course, this study was in fact terminated in the interim period because the results were so good and they were realizing that the babies were faring much better. It was found that they definitely have better mental and motor outcomes. But there is a backside to this. The women who were undergoing this prenatal surgery, their pregnancy were developing a few complications in the form of higher incidence of PROM, preterm labor, placental abruption, and also the assessment of the hysterotomy site at the time of delivery revealed that there was thinning of the hysterotomy site. And so there are very high chances of uterine dehiscence, very high chances of scar rupture, and these mothers must have pregnancy delivered by C-section, elective C-sections before the onset of labors in order to prevent the scar dehiscence. So to conclude, I would like to say that early detection is definitely possible, and we all aim for that via ultrasound and biochemical screening. It is extremely crucial. Fetal ultrasound, of course, is extremely mainstay along with the 3D and 4D ultrasound technology. Fetal MRI will complement but will never be able to replace ultrasound. Comprehensive assessment should be done where we just look for structural anomalies associated. We also look for chromosomal anomalies, and we counsel the women accordingly. The advances in fetal therapy show promise, but obviously it requires specialized centers where they can be implemented. So thank you so much. These are my references.
Thank you, Dr. Smriti, for highlighting the importance of various tests, limitation of biochemical tests, especially in closed varieties, and role of ultrasound, which is most common screening tools, and then detailed study further can be done by MRIs and all. And this is very important for, as a pediatrician, I say that counseling is very important once you detect, okay? So many times if they are not ready to continue, so you can take decision depending on the severity of the problems, and especially in ulnar cherry. So thank you.
Thank you, sir.
Thank you, ma'am, for such a clear and crisp talk. So as of now, we realize that still we are having patients with neural tube defect, and every day for that mother, every day is a challenge who's taking care of a baby born with such disability. So as of now, we are almost 100% in diagnosing. We are almost 100% in terminating when we diagnose well in time. But what we have to look forward is to have a center. We have to specialize ourselves to provide more kind of a fetal therapy, because now we also receive patients who are precious pregnancies, IVF pregnancies, whom we really can't terminate always because it's a really precious pregnancy. For in such cases, we do have to like more specialize in things like, as ma'am said, mom's trial, which is already a very well-proven trial. So maybe that's the only area where we have to work together as a team, because obviously Department of Obs and Gynae and Department of Pediatric Surgery is both required to move ahead in that respect. Thank you.
Morning, everyone. The talk is very clear and everything is clearly explained in this talk. So thank you, ma'am.
Thank you.
And now the session is open for any questions from the audience.
What is your advice regarding the karyotyping and antenatal period?
So whenever we detect that there is a neural tube defect, and we also realize that there are associated structural anomalies. As I just mentioned, that if there are no other associated structural anomalies, then usually the karyotyping abnormalities are very, very rare. But if there are associated structural anomalies, then women should be offered karyotyping in the form of amniocentesis, because then only we'll be able to decide what exactly we are dealing with and counsel them accordingly. So if and all amniocentesis has to be done, it has to be done before 20 weeks, because we need to have time for the cell culture and the karyotyping report also to come, because our MTP law only permits us to terminate the pregnancies before 24 weeks.
So if it is isolated anomaly, and suppose it is associated with hydrocephalus only, and the period is around 16 weeks. So should we wait for the karyotyping report to come?
Hydrocephalus, there is nothing else. We can continue, we can follow this fetus at least till 22 weeks and understand what is happening. If just isolated hydrocephalus is there, ventriculomegaly is there, there are no other spinal deformities, we can do a thorough search. If there is nothing, we can continue the pregnancy. Not all hydrocephalus warrants that there is a presence of neural tube defect.
If the hydrocephalus is progressing?
Then of course we have to counsel the parents accordingly. What kind of risks are they willing to take? What are the things this has to be a shared decision making.
Is there any cutoff related that this is a severe?
Severe ventriculomegaly, yeah, we have mild,
so
moderate and severe
go for
ventriculomegaly.
termination?
So whenever there is severe ventriculomegaly, it alters the prognosis. But mild ventriculomegaly, the pregnancies can continue if there are no other associated anomalies.
Okay, thank you.
Excellent presentation, Dr.
Thank you.
Smriti. I really thank you for covering a nice talk on this antenatal diagnosis. And what is the ideal time for the ultrasound in a pregnancy to think and go for this sort of?
So first and foremost, there are certain neural tube defects which can be picked up in the first trimester in our 11 to 14 week scan which we do, especially anencephaly. So first ultrasound, we always do as a dating scan if the patient comes to us early, which is around 7 to 8 weeks. This is to ascertain the dating period. Then 11 to 14 weeks is an extremely important time because we can actually rule out major structural anomalies at this time. However, the repeat scan, which we call as TIFA scan, is done between 18 to 20 weeks. So that is the time where we should be able to detect at least 95% of any kind of a structural anomaly which is there.
Thank you.
And ventriculomegaly, sir, as you mentioned, it is a progressive. So when we follow up the patient and we do another repeat scan in the third trimester, we suspect something. So then we can do a follow-up scans at every 2 weekly interval to understand what is happening to the hydrocephalus.
Thank you.
Thank you.
About chromosomal anomalies, earliest you can do NIPT around 10 weeks or so.
Yes, sir.
And yeah, and if there is something, then you can confirm by amniocentesis or something. So 10 weeks you can do chromosomal if there is some even subtle anomalies are there.
So, for my information regarding, I want to know what is the status for the board for the termination of pregnancy. Is it there in the KGMU and it is taking the cases from outside? If I diagnose it and then I refer for the better management beyond the 24 weeks, then is there any board?
There is a board.
There is a
state
board,
There is
ma'am.
state
We
board.
have a gynecologist, we have a radiologist, we have a neurosurgeon, neurologist, everybody on board. So if there is a patient who is more than 24 weeks and who has an anomaly which is incompatible with life, then it is referred to the board examines, and then we give our report, and then the further decision is to be taken.
So I can refer. I am in the AIMS library and I sometimes encounter these types of cases.
Of course, ma'am. Yes, we do get a lot of patients.
Okay, thank you.
Thank you.
Thank you, ma'am, for sharing your knowledge with us. I would like to call upon our next speaker now, Dr. Saurabh Kumar. Sir will be talking to us on his topic, Diagnostic Approach to a Case of Neural Tube Defects, a Radiological Perspective. Sir is Associate Professor at the Department of Radiodiagnosis in KGMU, Lucknow.
Respected distinguished faculty on the dais and all the faculty members of the hall. So I'll be confined much of my talk in the imaging perspective only, not much of the theoretical part. So NTD include a diverse group of anomalies that usually occurs at the 2nd and 6th weeks gestational week. So it's the time which decides the most important part of the development of the fetal spine. So what's the need for imaging? Because it provides the early diagnosis, it gives you evidence, and along with that, it gives you option to offer the patient advanced procedures in the form of exit procedures, means extrauterine intrapartum therapies. So we have a different type of imaging modalities for diagnosing the neural tube defects. Along in that group, we have ultrasound, which is commonly available in all the departments, I think. And then we have a MRI and CT scan. So ultrasound is primarily used in the antenatal period because the spine and cord could be easily diagnosed, easily seen in ultrasound up to 2nd trimester of POG. But it has got a limited role in advanced age due to the ossification of posterior neural arches. And so the spinal cord and the rest of the soft tissue structures cannot be delineated clearly. So the ultrasound images of that cord, we need to assess, we need to know the anatomy. So the image first, it shows the posterior elements of the spine. Then we have a central canal. And in that central canal, we have got a spinal cord. And the central part, echogenic part is actually ependymal lining of the central canal. And going to the caudal section, we have got central canal with the nerve root fibers who are studded very closely to each other. And the sagittal ultrasound images, it shows a termination of the cord at the level of L1, L2. So the plain radiographs and CT scan, I would simply say avoid to ask for the X-ray and CT images of for the fetus because the risk of radiation exposure is there. So try to avoid the things if possible and if it could be done. Then coming to the MRI, MRI has got excellent contrast resolution and wide field of view. It helps you to detect the things which are not obviously visible in ultrasound and enables to see the hidden areas of ultrasound in making the clear diagnosis. So we have got a certain magnetic MRI protocols for the better fetal MRI. So we need to have a sagittal whole spine, axial and coronal T2 weighted images, sagittal whole axial and coronal T1 weighted images with 3D reconstruction. And then we have a T1 fat suppressed images as well. And then we have got some optional sequences. So this is a broad classification of the spinal dysraphism, including the open and the closed defects. So we have in open, so there are certain group of the diseases, and in closed spinal group, we have got two other broad categories, one with the subcutaneous masses and other without the subcutaneous masses. So open spinal dystrophism is actually there is exposure of the neural tissue or its covering managed to the external environment without overlying skin. And the exposed non-neurulated neural tissue, which is usually a common feature, is known as a placode. So coming to the ultrasound features of the myelomeningocele, so these are two different images of the same patient who have got the two different resolution. So the image one, it shows the spine, dorsolumbar spine with the cystic structure at the tail of the spine or the sacral region. And in the similar images were done at the better resolution, it clearly shows a large cystic lesion in the sacral region with the fibrous strands extending from there, which is actually a neural placode, which is not well visualized in the previous images. So you need to have a better ultrasound machine with a good resolution. And so these are the MR images of the patient, so the T1, T2 images. So we can have two cords, one on right side, one on the left side, which is well visible on the T2 images here. But along with that, you can have a defect in the neural arches in these images with herniation of the meningeal sac. And this small herniation of the neural placode here. But on the left, this left hemichord is still within the neural spine, within the spinal canal. So this is the right-sided hemimeningomyelocele. So coming to the closed spinal dystrophism, again this has got a lot of different diseases. So one with the subcutaneous mass and other without the subcutaneous masses. Coming to the disease with the subcutaneous masses category. So lipomyelocele, as the name suggests, the lipomyelocele means there should have been a fatty tissue as well. So the fatty tissue of the subcutaneous fatty tissue which has got herniated within the spinal canal through the defect in the posterior spinal processes. So this is a lipomyelocele. There is a T1 and T1 images, weighted images. The subcutaneous fat tissue which has got herniated into the spinal canal through the defect in the posterior spinal processes, and this is the corresponding ultrasound images as well. This is the another case which is having a T1 and T2 weighted images. Here you can see a cord which is extending posteriorly, and this is subcutaneous tissue which is herniating inside with the neural placode here. So coming to the another group is a T3rd cord. T3rd cord is a pathological fixation of the spinal cord in the abnormal caudal location, because normally the cord does not extend beyond the T1 lower border of T1. So if you see the ultrasound, it could be easily seen in the ultrasound the cord is extending beyond the T1 lower border, and the T3rd cord is not isolated phenomenon. It is most likely associated with the intraspinal lipoma or some pathology underlying. So you need to have a good ultrasound images, and along with that, if there is a suspicion, and if even you cannot see the things in ultrasound, you need to have a MR imaging in all the patients, because ultrasound is definitely operator dependent and cannot see all the things which MRI could see. So any patient which is having the symptoms of T3rd cord, and if the preliminary ultrasound doesn't give you the diagnosis of any intraspinal lesion, go for the MRI. So this is a patient who is having a T3rd cord syndrome, and the ultrasound images shows a bright lobulated lesion in the distal part of the cord, and the corresponding MRI images shows intraspinal lipoma over here, and with the T3rd nerve roots. And any patient who has got the renal failure as a first sign, there should be a T3rd cord syndrome suspicion as the first thing that should clinician think of. So how do we diagnose the T3rd cord syndrome? Obviously the low conus and below that is below the L2 level, and whenever we do a ultrasound, we see a diffuse restricted movement of the nerve cords, which could be easily seen in the normal cords whenever we are doing the ultrasound imaging in postnatal ages. Coming to the lipomeningomyelocele group, so this consists a large subcutaneous tissue, and which covers the lumbosacral region that contains fat, neural tissue, and CSF with herniating meninges. So you have got three components, including the subcutaneous fat, neural placode, and the herniating meninges with the expansion of subarachnoid spaces. So there is a small difference between the lipomyelocele and lipomeningomyelocele. Myelocele doesn't have a neural placode extending beyond the skin surface. However, the myelomeningocele have got the placode lipoma interface extending beyond the skin surface. These are the symmetric images which shows the neural placode which has got flushed with the skin surface. On the other hand, the neural placode has got extending beyond the skin surface with the expansion of subarachnoid spaces. So coming to the meningocele group, so meningocele has got only the herniation of the meninges through the defect in the posterior processes of the cord spine at that particular level with tenting of the dura. Obviously, you would be able to see the tenting of dura, but no cord tissue would be herniating from that. So the anterior sacral meningocele, sacral meningocele is not very commonly diagnosed because it has got so many differences like cystic sacrococcygeal teratoma and large ovarian cyst, and another is neuroenteric cyst. So you need to go for the MRI in all the cases of anterior sacral meningomyelocele. Another group is terminal myelocystocele. It has again got the three components: posterior spina bifida, skin covered posterior meningocele, and hydromelic terminal cord into the meningocele. So this is the symmetric representation of the case, terminal myelocystocele. The central canal of the terminal part has got dilated with the expansion of the subarachnoid space and obviously the posterior spinal defects. Coming to the closed spinal dysraphism without the subcutaneous masses. So we have got the entity, the intradural lipoma. The intradural lipoma is not isolated finding again. So intradural lipoma mostly would be associated with the T3 cord syndrome. So any patient coming with the T3 cord syndrome must have been screened with the MR images. So there would be a dorsal midline lipoma located in the groove of unopposed neural placode with intact dura. Coming to the filar lipoma or fatty phylum terminale. Fatty phylum terminale is the one which is very commonly seen in most of the cases, but the fatty phylum becomes symptomatic when the thickness of the fatty phylum becomes more. That is, it should be more than 2 mm thickness, because thickened fatty phylum more than 2 mm thickness is usually associated with the T3 cord syndrome. Otherwise, fatty phylum which are less than 2 mm thickness, they are usually asymptomatic. And if a random imaging if done in 100 of the patient, most of us would be having that fatty phylum. Coming to the low-lying cord at L4 phylum with thickened fatty phylum terminal, as I said that the fatty phylum is symptomatic only when it is more than 2 mm thickness and it is usually associated with the T3 cords. So this is the T1 and T2 fat sub images. We can see a bright lesion within the spinal canal with the cord roots which are adhered to this fatty lesion. So this is a fatty phylum terminal with low-lying T3 cord. Coming to the persistent terminal ventricle. So persistent terminal ventricle is again a common finding in most of the cases and usually asymptomatic. We can have a simple cystic dilatation of the terminal part of the that central canal. So another group is dorsal dermal sinus. The dorsal dermal sinus is again very asymptomatic, except occasional cheesy material coming out at the posterior of the posterior midline back. So all these patients should be screened with MRI images, and there is if good resolution ultrasound done, a simple sinus tract which is extending from the skin to the deep neural spinal canal could be also be seen, but it's better, always better to go for the MRI. So another group is complex dystrophic status. So neuroenteric cyst is one among them. So neuroenteric cyst is a localized form of dorsal enteric fistula. There is incomplete regression of the neuroenteric canal and is typically located in the cervicothoracic spine. So these are the T2 weighted MR images. You can have a bilobed cystic structure in the lower cervical region with CT images show the defect in the spinal spinal canal vertebra. So any patient who is having a cystic structure with the defect in the vertebra is mostly having a neuroenteric cyst. Coming to the diastematomyelia and split cord formation, so it is broadly classified into two groups, Pank type 1 and Pank type 2. So the Pank type 1 group has separate dura, separate two cords, and the bony or cartilaginous bar separating the two cords. So these are the ultrasound images. We can see the two separate cords over here, but we cannot see a bony bar or septum separating the two. But the same patient, the caudal images shows a defect in the posterior spine with the echogenic structure somewhere here, which would be probably a bony spur. And these are the corresponding MR images, who say two hemicords with the bony spur inside dividing the two cords separately with the two separate dura. Coming to the type 2 diastematomyelia, type 2 diastematomyelia doesn't have a separate dural sac lining. Rather, we can have an incomplete or complete bony spur, but the two dura cannot be there. There would be a single dura with two hemicords. Coming to the CRS, CRS is a cardinal feature of diabetic embryopathy. There is a partial or total agenesis of the spinal cord with absent coccyx is the common feature. So these are the typical type 1 caudal regression syndrome MR images. So there is an abrupt change in the caliber of the cord at the T2 level. With change in the abrupt cutoff at this T2 level, the cords which have been arising there, they had to travel a long distance before exiting at the neural foramina. So the corresponding axial T2 weighted images show a parallel appearance of the bundles. So this is a cardinal.
Professor Smriti Agrawal, ma'am. Certificate दीजिए. I would like to request Professor Rawat sir to please come on the stage and felicitate our chairpersons. Professor S.N. Singh sir. Dr. Namrata Kaur, ma'am. Sorry, Dr. Namrata Kumar, ma'am. Dr. Om Purbe, sir. Thank you, sirs and ma'am. Now I would like to call upon the next chairpersons for the event, Dr. Arisha Alam ma'am, Dr. Premraj Singh sir, and Dr. Shamendra Pratap Sharma sir. I would like to call upon Dr. Mohammad Fahim sir to present his views on the surgical management of hydrocephalus and neural tube defects. Dr. Mohammad Fahim sir is the Associate Professor in the Department of Neurosurgery, KGMU, Lucknow. He has multiple publications in reputed international and national journals. He is currently evaluating the role of 3D printed models in craniovertebral junction surgeries.
Good morning, everyone. At the outset, I would like to thank the Department of Pediatric Surgery for giving me the opportunity to speak here. And the topic which has been allotted to me is the management of hydrocephalus and neural tube defects, when and how. Actually, it is closely linked, related to both neurosurgery and as well as pediatric surgery. So, hydrocephalus and neural tube defect, they are also closely related to each other. Hydrocephalus may occur as an isolated entity also, and it is also associated with neural tube defect. It is, in case of meningomyelocele, it is almost associated in more than 80% of the cases. And it poses a significant burden to the society as the child remains dependent for their whole life. And awareness is required for the dietary supplementation, as already told by ma'am, that it is one of the single most important factor which is helpful in prevention of neural tube defects. And the clinical significance of diagnosis and early intervention is very important. Now coming on to the hydrocephalus, first of all, it is defined as the accumulation of CSF in the ventricles. It may be due to excessive production of CSF or may be due to obstruction anywhere within the ventricular system. And there are various types like communicating and non-communicating type of hydrocephalus. And now hydrocephalus is said to be communicating whenever there is a defect at the level of arachnoid granulation where the absorption of CSF occurs. And if the obstruction is proximal to the level of arachnoid granulation, then it is known as obstructive or non-communicating hydrocephalus. Other type of hydrocephalus includes arrested hydrocephalus, which I will talk in a short while, entrapped fourth ventricle, and normal pressure hydrocephalus. Actually, normal pressure hydrocephalus is not it is not common in pediatric age group. And the etiology includes congenital as well as acquired. It is closely related to neural tube defect, KRE1 and KRE2. In case of KRE1, it is due to obstruction of the fourth ventricle, and KRE2 is most commonly associated with meningomyelocele. Primary and secondary aqueductal stenosis. Primary aqueductal stenosis is the most common cause of congenital hydrocephalus in children, and secondary may be due to intrauterine infection or may be due to hemorrhage. Dandy-Walker malformation and X-linked hydrocephalus. Here the importance of genetic screening is very important. Acquired include infectious, which we commonly encounter in our practice as tubercular meningitis, which may lead to hydrocephalus. Others include hemorrhagic, neoplastic, and constitutional ventriculomegaly. Now we know that the sign and symptoms of hydrocephalus include enlargement of head size with bulging fontanelle, irritability and respiration in case of younger children, whereas the typical features of raised intracranial pressure like headache, nausea and vomiting in case of older children. We have several signs like sunset sign, frontal bossing and engorged scalp veins, and this mass event sign can also be elicited by tapping over the skull and listening with the help of a stethoscope. Here the sound is amplified, suggesting that there is raised intracranial pressure. Now imaging has already been discussed in great detail. It can be diagnosed in by USG and CT scan and or MRI. Now there are several criteria to diagnose the hydrocephalus. First of all, the size of temporal horn if more than 2 millimeter, because in case of normal brain the temporal horn they are barely visible. Other criteria include ratio of frontal horn to internal diameter, as can be shown in the second figure. If it is more than 0.5, Mickey Mouse appearance, or periventricular lucency, as can be seen in the third image. Periventricular lucency is said to be due to transependymal ooze, but actually it is not transependymal ooze, it is due to the stasis of fluid around the ventricles, because it is seen that transependymal ooze usually doesn't occur. And Evans ratio if more than 0.3 suggestive of hydrocephalus. Now there are certain differential diagnoses which we have to keep in mind to rule out any sort of other things like hydrocephalus ex vacuo. Actually it is hydrocephalus ex vacuo occur due to loss of cerebral tissue and not due to ventriculomegaly due to raised pressure. It may be due to certain diseases like in case of older adult like Alzheimer's or in case of traumatic brain injury. Several developmental anomalies are also come into the differential diagnosis of hydrocephalus, like agenesis of corpus callosum, as can be seen in the first figure. Here there is agenesis and the third ventricle is expanded, It has the appearance as shown in here. Here there is no hydrocephalus, and there are no such features suggestive of hydrocephalus. Now septo-optic dysplasia, here there is absence of septum pellucidum and hypoplasia of optic nerves and chiasm. It gives the appearance of rectangular or square shaped ventricles, but there is no feature of any periventricular lucency. Now third one is hydranencephaly. Here there is bilateral IC infarct, and we can see that here brain is barely visible. Other causes are external hydrocephalus or benign extracerebral fluid. It is also a common entity, as we can see here. There is enlarged subarachnoid space over the frontal poles, and it is usually seen in the first year of life. And it resolved by second year of age. There is a very important sign which is non-cortical vein sign, as can be seen by this yellow arrows. There is a vein which is clearly visible, and it is also a differentiating point between subdural hemorrhage, because in case of subdural hemorrhage, this cortical vein is compressed, whereas in case of external hydrocephalus, it is not compressed. And management, this type of patient should be closely assessed, and serial radiography is to be done, and if patient becomes symptomatic, then CSF diversion in the form of V-patient can be done. Now this is also a very common entity which is known as arrested hydrocephalus. It is a sort of compensated hydrocephalus. There is a equilibrium between CSF absorption and CSF production. It has nearly normal or slightly large ventricular size, and the head growth and psychomotor development remain normal in such kind of patients. But intervention may be required in such cases if patient decompensate. And here also we have options for CSF diversion in the form of ventriculoperitoneal shunt or ETV. Now the question arises when to intervene. It is very important question. Now in utero also there are some of the studies which are still in the experimental stage, but isolated congenital hydrocephalus can also be managed in utero, and the potential intervention which are not done nowadays because they are still in experimental stage includes ventriculoamniotic shunting is one of the potential intervention. Another include ventriculo-subgaleal shunt and possibly endoscopic third ventriculostomy. Termination of pregnancy may be considered in case of X-linked hydrocephalus. If it is seen that there is very less cortical mantle and it is not possible to have a viable baby. And in case of infancy and childhood, whenever we diagnose hydrocephalus, then it should be treated as soon as possible. Now the surgical goal of hydrocephalus is not to obtain the normal sized ventricle, because it may not be sometimes possible, and the goal is optimal neurological function and good cosmetic result. Good cosmetic result may be in the form of, because there may be a reduction in the size of skull, and the anterior fontana is also become depressed. Now the surgical options are endoscopic third ventriculostomy. It is commonly done procedure nowadays, and it is done in cases of hydrocephalus due to obstruction anywhere, like congenital hydrocephalus by aqueductal stenosis. And it is also very helpful in managing the shunt infection, because shunt is anywhere, it is a hardware. So if there is infection in the CSF, then it is very difficult to manage. So endoscopic third ventriculostomy is an option. There is another indication is slit ventricular syndrome, but it is not without complication. It may be a complication includes hypothalamic injury. There may be injury to pituitary stalk and injury to basilar artery leading to basilar artery aneurysm. And the success rate is around 56%, and it is much more in case of non-tumoral aqueductal stenosis. But the success rate in case of tubercular meningitis, as we see, is less than 56%. It is around 35 to 40%. And it can be calculated using ETV success score. And this endoscopic third ventriculostomy, it is not usually indicated for infants, because subarachnoid space is not that developed in infants. This is the figure which shows that endoscopic third ventriculostomy. In the first upper right, we can see that the foramen of Monro, and there is choroid plexus and anterior septal vein. And in the second, we can see two white colored structure. These are known as mammillary bodies. And the hole, it should be done in front of mammillary body and posterior to infundibular recess. And a hole is made. If it is an adequate opening, that we can see the basilar artery pulsation on opening the stoma. And now another intervention which can be done is shunt. It is the most common procedure which is done, like ventriculoperitoneal shunt, and the Chabda shunt is the most commonly done procedures here and in developing countries. Other options include programmable shunt, and the less common shunt which is not done routinely are ventriculoatrial shunt, or which is also known as vascular shunt, ventriculopleural, and LP shunt. And the other means to remove the obstruction are aqueductoplasty in case of congenital hydrocephalus and tumor removal. There are various shunt complications. We have also published one of the article on unusual complications of VB shunt surgery. As you can see, there are several complications. First of all, there may be hemorrhage while putting the shunt, and in the second CT scan, we have seen a very peculiar complication in which, after placing of the shunt, there are 4 EDH, 2 in frontal region and 2 in the parietal region. There may be per oral, per rectal, per urethral extrusion of the shunt, and also shunt extrusion from the anterior abdominal wall. Now coming on to the neural tube defects. It is a failure of neural tube closure during embryogenesis, and it is the second most common defect after congenital heart disease. And in India, the incidence is around 3.9 per 1,000 live birth, and is much more common in northern part of India. And as we can see, it appears to be some sort of endemic here in this area. And it require multifactorial, it require a long, and patient is experiencing a long-term impact on child and a family. The etiology has already been discussed. It has genetic predisposition as well as folate deficiency and exposure to teratogenic drugs. And now there are several classification of neural tube defects. One of them is Lemire classification. It classifies the defects into neurulation defect and post-neurulation defect. Neurulation includes this cranioracheschisis, in which there is incomplete closure of neural tube at both the cranial and the spinal end, and anencephaly. They both are incompatible to life, and this neural tissue, this is not covered by the skin. And the most common which we encounter is the meningomyelocele. Here both meninges and the neural tissue, it lies outside the spinal cord. Other post-neural neurulation defect or the closed defect, they are lipomeningomyelocele, spina bifida occulta, and meningoceles. This is one of the book chapter which I have published, which is neurulation and the possible etiologies of neural tube defect. And the neural tube defect, it can be closed, and this post-neurulation defect may be cranial and spinal. In spinal, there is split cord malformation and hydromelia or syringomelia. Now, the diagnosis of neural tube defect has already been covered in much detail. Like in prenatal, there may be elevated maternal serum alpha-fetoprotein, USG, MRI, and amniocentesis can also be done. Now, coming on to the spina bifida occulta. Here, there is a congenital absence of spinous process and variable lamina. There is no exposure of meninges or neural tissue, but it has got a lot of cutaneous manifestation in the form of hypertrichosis, subcutaneous lipoma, and skin discoloration. Patient may have gait difficulty, pain, and scoliosis, or there may be kyphosis. Now, coming on to the when to intervene. Sometimes it is of no clinical significance, so nothing to be done, but these type of defects, they are associated with split cord and T3 cord. So, the management of split cord should be done in such cases, and T3 cord, this teethering of the cord is to be untethered if any lipoma or anything is present. Now coming on to the meningomyelocele, the risk is increased to 2 to 3% if one of the previous births is affected, and 6 to 8% if 2 births are affected. And hydrocephalus occurs in more than 80% of the cases, and around 10% they are clinically overt. And majority of them, they are associated with carry 2 malformation, and the closure converts the latent into active hydrocephalus. Now the management includes intrauterine management, the very famous trial which has already been explained by ma'am, that is MOMS trial, which was published in 2011 in NEJM, and it compares the prenatal versus postnatal treatment of MMC, and they concluded that the surgical intervention, if it's done before 26 weeks, that it lead to reduction in the incidence of carry 2, hydrocephalus, and motor function at 30 months of age. But it has also got some problems, like teethering is more common in cases of if intrauterine repair is done. Now, postnatal, it depends upon the various things like size of the lesion and whether it is intact or ruptured, and AP and lateral radiograph should be done to look for any scoliosis, and it should be covered with a moist dressing like paraffin gauze dressing, then sponges soaked in normal saline, and patient to be nursed in lateral or the prone position. And these type of children may have another associated anomaly, so it should be screened by the help of neonatologist, and the orthopedics opinion is also needed in case of foot deformities. Now the timing of closure is very important. They should be closed within 24 to 36 hours, whether ruptured or not, because after 36 hours the back lesion is colonized, and it has been seen in numerous studies that there are chances of infection. Now the goal, the surgical goal is to free the cord from the dura to avoid teething. Watertight dural closure should be done. Skin closure should be done in layers, and it should be done under neuro monitoring to further increase the chances of motor power. And it will be further discussed by Dr. Brijesh. And V patient may be done simultaneously in case of clinically overt hydrocephalus. Now these are the surgical steps. In this first.
Dr. Fahim, we are just running out of the time.
Okay, sir. So, come, only 2 minutes. So, there is another, like a split cord malformation. There are type 1 and type 2. In case of type 1, the treatment includes de-teething of the cord, the removal of bony septum, and the dural reconstruction. And type 2, here also de-teething of the cord to be done. Now coming on to the encephalocele, it is a defect where intracranial structures are outside the confines. It has been classified by Soenvela and Soenvela. And the management includes MRI with MRB, and it should also be done as soon as possible. Now this is also one of the case report which we have published. There was a giant interfrontal encephalocele like this. It was a 25 centimeter size, and there was, as you can see, there was a herniation of CSF as well as frontal horn of the lateral ventricle, and there is a very big defect of on the skull. It is a type of interfrontal encephalocele. Now the prognosis is 85% of the MMC patients survive, and 3 to 10% have normal urinary continence. Now to conclude, prevention of developing the defects in future pregnancy is essential in the form of folic acid supplementation. Timely surgical intervention improves outcome, and multidisciplinary care is important and involve the concerned specialty, improve survival and outcome. And there is a need of support to the families to overcome social, emotional and economic burdens on the individual and families.
Thank you. Congratulations to you, Dr. Fahim. Very clear, concise and very informative talk. And you have covered all the topics, all the points of given talk. Thank you. Thank you so much.
So any questions from the audience?
Thank you, sir, for the brilliant walkthrough. A great surgeon requires great anesthesiologists to back them up. Hence, I call upon Dr. Brijesh Pratap Singh, sir, to talk about the intraoperative neurophysiological monitoring and anesthesia management. Sir is the assistant professor in Department of Anesthesiology and Critical Care. He has multiple publications in national and international journals. He is currently studying the feasibility and diagnostic accuracy of neurophysiological monitoring in children during surgeries. Thank you, sir.
Good morning. Good morning to everyone. First of all, thank you to the Department of Pediatric Surgery that they have given me this opportunity. So my topic of presentation today is intraoperative neurophysiological monitoring and anesthesia management. So neural tube defects remain a significant cause of a pediatric morbidity globally, with the conditions like myelomeningocele, lipomyelomeningocele, and Tether cord syndromes requiring early surgical interventions. So intraoperative neurophysiological monitoring plays a vital role in minimizing neurological injuries during delicate spinal cord and nerve root manipulations. So in the current era, it's not ionum, it's a multimodal ionum, including SSEP, MEP, and electromyography, EMG, as is increasingly being integrated into the standard neurosurgical protocols for the safer outcome. So in the recently last 10 to 15 years, this IONM technique has been already used in the adult population in spine surgeries or in cranial surgeries. But then recently, in the last 10 to 15 years, there is a large number of studies has been published in a great literature in the form of retrospective and prospective studies. So why IONM is crucial in pediatric neural tube defect surgery? Because the developing nervous system is more susceptible to injury, so we need more delicate care during handling. Neural tube defects often involve abnormal neural organization. Functional structures may not follow the normal anatomical patterns. So what you are seeing, what is supplying, so dermatomal and level and myotome levels may not coincide with what you are seeing during the surgical field. Children may not show immediate post-operative defects. Intraoperative monitoring detects subclinical changes. So these surgeries is used to be done in that period of time where the assessment of the muscle power cannot be done so efficiently as of adults. So it helps to prevent the long-term disability such as bladder and bowel dysfunction and lower limb paralysis. So why it is challenging for an anesthesiologist because it is an immature nervous system physiology. So pediatrics should not be treated as a miniature of adult. It have a different physiology rather than adult people because of the smaller anatomical structures, and there is a greater anesthetic sensitivity which has been proven by various literatures. So what is intraoperative neurophysiology monitoring? It is the real-time assessment of the functional integrity of neural structures such as the brain, brainstem, spinal cord, cranial nerves, and peripheral nerves. Using electrophysiological techniques during surgical procedures that place this structure at a risk, it serves as an early warning system to detect impending neurological injuries, allowing for immediate intraoperative intervention to prevent permanent deficits. So what is the impending neurological deficits? This impending neurological deficit is mostly iatrogenic. It is done by other surgical causes or anesthetic or systemic causes or because of the positioning of the patient. So in the surgical factors, distraction, compression, or blunt trauma during the surgery, ischemia of the neural structures, and the thrombotic or thrombotic events can cause this neurological injury. In anesthesia, with anesthesia perspectives, ischemia, hypoxia, hypothermia, cervical extension during intubation, and hypotension can cause this impending neurological injuries, and the positioning during direct compression, compromised blood supply, neck and shoulder positioning can cause such issues. So what are the common IONM modalities which are being used in this neurotube defects? These are the somatosensory evoked potentials, transcranial motor evoked potentials, electromyography, which is in two types, spontaneous or continuous EMGs, triggered EMGs, bulbocavernous reflexes, urodynamic pressure monitorings, and for the muscle relaxations adequacy, 10 of 4, and for the adequate depth of anesthesia, BIS or EEG monitoring. So first, somatosensory evoked potential, that is known as SSEPs. What it monitors? It monitors the dorsal column medial lemniscal sensory pathway. So the stimulation starts from the peripheral nerves, and it goes to the dorsal column, and then decussation happens over the lower part of the medulla, and it reaches up to the thalamus, and from thalamus it reaches to the cerebral cortex. So recording can be done from the cortical side or subcortical sides. So what role does it play? It plays detects the compromisation of spinal cord perfusion or dorsal column injury. It is sensitive to ischemia or traction during spinal corrections. What are the challenges in pediatrics while performing these SSEPs? Smaller anatomy and immature myelination may reduce the amplitude and increase the latency. So it is really difficult to know that it is a physiologically normal or it is a pathological. And it requires the careful temperature and anesthesia management, which is very difficult during pediatric neurosurgeries or pediatric surgeries. So how will we see this? When there is an amplitude reduction of 50% or the latency increase in 10%, we presume it as a significant change. Smaller changes may indicate impending neurological ischemia. It may take 3 to 5 minutes to determine a significant change depending on the ambient noise level. So when you are going through such area where you feel that there is a chances of some injury, at least you have to give 3 to 5 minutes and then repeat the test of SSEP. So you can confirm and double check that there is no any neurological injuries. It has a high sensitivity and low sensitivity to injury, and it can be performed continuously. So in upper limb, radial nerve, medial nerve, and ulnar nerve can be used as places for where you can put stimulations. And for the lower extremities, you can use peroneal nerve, posterior tibial nerve, or saphenous nerve for the stimulation places. And for the recording of SSCP, at the cortical level, we can put the cork screw electrodes at the CPZ, CP3, and CP4, and frontal FPZ and CV at that area. So another modality is transcranial motor evoked potentials. It monitored the cortico-spinal motor pathway, and stimulation is being done here with at the motor cortex with the transcranial stimulations. And recording is done in the muscles in upper and lower extremities. What does it serve? It detects the anterior spinal cord injury or vascular compromise. And it is essential for the motor pathway integrity in the deformity correction. It is a gold standard for the detection of new postoperative motor deficit, has a sensitivity of 75 to 100% and a specificity of 84 to 100%. What is the importance in pediatrics? It is more sensitive to SSCP for anterior cord injuries, and it requires total intravenous anesthesia without muscle relaxation for optimal readings. So where are the electrodes we used to put for the transcranial motor evoked potentials? It is CZ, C3, C4, T3, and T4. These are the motor areas where you can stimulate the motor cortex of hand and upper extremity and lower extremities. And what are the muscles which can be used for the recording of such that's motor evoked potentials is the Apponens pollicis brevis, adductor digiti minimi, external carpi, radialis, brachioradialis, biceps brachii, and deltoid in upper extremities. And in lower extremities, quadriceps, adductors, hamstrings, anterior tibialis, gastrocnemius, soleus, and external hallucis longus and abductor hallucis. These can be the muscles where you can take the reading for the muscle evoked potentials during MEP monitoring. So there is a criteria for interpretation of MEP. So there is 3 criteria: amplitude criteria, all or nothing criteria, and modified all or nothing criteria. So what currently the modified all or nothing criteria is the more comprehensive and more informative. It combines the qualitative and quantitative assessments. So when there is a decrease of more than 80% amplitude from the baseline in more than one of 6 muscle groups, then we presume there is a significant neurological injury happened during the procedure. So it provides a better balance of sensitivity and specificity, more reliable for predicting true functional motor changes. So this is one journal, spine journal, in which in 2010, I think, 2014, which has given the how to make the best use of intraoperative motor evoked potential monitoring. And it shows the motor evoked potentials can have a sensitivity and specificity of nearly 100% to 99.7%. So other modalities, D wave or direct wave or spinal MEPs. What are the D waves? D waves are the direct recordings of descending corticospinal tracts activity obtained via epidural electrodes placed over the spinal cord. Unlike compound muscle action potential, which is generated by the MEPs, D wave reflects the true spinal cord conductions. So it tells about the conduction through the columns. Independent of peripheral neuromuscular functions, recording is more resistant to anesthetic effects, including volatile anesthetic agents. So what is the interpretation criteria? More than 20% decrease in amplitude from the baseline considered as an early warning of possible spinal cord compromise. And more than 50% decrease in amplitude from the baseline indicate the significant reverse of irreversible motor injury. So these are the good things which can be done during the cord manipulations. What are its clinical applications? Highly valuable in intramedullary spinal cord tumors, resections, where preservation of lung motor function is critical. So it is superior to compound muscle action potentials, which is MEPs, for predicting long-term motor changes, recognized as the gold standard for intraoperative monitoring in corticospinal tracts manipulations. So what are the limitations of D-wave monitoring? It has a high false positive rates in spinal deformity surgeries due to the non-card-related signal fluctuations. And it has a delay in detecting vascular insults, making it is less suitable for rapid response interventions. And it requires an invasive procedure, requires the placement of epidural over the exposed spinal cords. So what are the complications of using MEP monitoring in pediatric patients? It can be in tongue or lip injuries. It can cause seizures, movement-induced injuries, hemodynamic instability, dental traumas, electrode-related issues, anesthetic challenges to manage such movements, and electric shocks. So another modality is known as electromyography, EMG. Electromyography detects the electrical activity in muscles, assess the nerve root integrity. It is of two types, spontaneous, continuous or free EMGs or triggered EMGs. So what is spontaneous? It is a passive monitoring of muscle activity, detects the mechanical irritation, stretch or compression of the nerve roots. The sudden burst in the activity of that, in this graph, it shows the possible nerve root contact or injury, while triggered EMG is known as electrical stimulation of pedicle screws or hardwares, assess the proximity of nerve roots during the stimulation. So low threshold responses is possible medial wall breach of during the pedicle screw placement. So this is a free EMG and this is a stimulated EMG graphs. So how you interpret triggered EMG? So what is the threshold current? The threshold current during the triggered EMG, doing triggered EMG, if there is a low threshold, less than 2 to 5 milliampere, nerve is very close or in a direct contact with your probe, that's monopolar probe. And what is the high threshold? More than 10 milliampere, likely no nerve nearby, safer zone. So during pedicle screw placement, this can also be used. If less than 5 milliampere, possible breach of pedicle wall on medial side. So screw is so too close to nerve, but if the threshold is more than 10 to 20 milliampere, it is a safer approach for pedicle screw placement. So latency can, prolonged latency can dictate the nerve dysfunction or stretching, and absence or drop in amplitude can indicate nerve damage or disconnections. So another modality is bulbocavernous reflex, BCR. BCR is a sacral spinal cord reflex, S2 to S4, that involves the somatic afferent and efferents. It is an essential marker of functional integrity of sacral reflex arc, particularly important in surgery where the conus medullaris and sacral roots are at risk. So stimulation, where the stimulation we do, electrical stimulation on the dorsal penile or clitoral nerve using percutaneous or surface electrodes. And recording is done by the needle or surface electrode placed in the external anal sphincter. So it serves as a real-time monitor for the S2 to S4 spinal segments. So any loss, delay or asymmetry in BCR may indicate sacral root injury, sacral cord ischemia or surgical manipulation induced neuropraxia. And doing BCR correlates with the better post-operative bladder and bowel functions. This is another article which has shown about the lost and remained criteria of breast BCR amplitude as a predictor of post-operative urinary function. So another monitoring is intraoperative pressure urometry or urodynamic monitoring, a technique to measure real-time bladder pressures, detrusor pressure, intraoperatively reflecting autonomic interventions of bladder through S2 to S4 routes. So technique, insert a Foley catheter connected to a pressure transducer, as like arterial. Pressure recorded continuously or during. Nerve stimulation, surgical, you can do it during the stimulation or surgical manipulations. It predicts the risk of neurogenic bladders or detrusor sphincter dyssynergia, directly assess the integrity of the sacral autonomic pathway, and it complements the BCR or an EMG in multimodal IONM. So anesthetic management of such neural tube defects patients, the basic pediatric anesthesia management is almost similar. What is the tailoring has been done during the anesthetic management in such patients or in such surgical patients is we should use the felicitation of the basically neuromonitoring. So what are the basic concerns during anesthesia management?
Dr. Brajesh,
Yes.
sorry to interrupt you.
Okay, sir. Just 2 minutes, sir. So So impact of anesthetic agents on IONM modalities. So we have inhalational agents, we have intravenous agents, and we have muscle relaxant. So different modalities of IONMs gets almost fully suppressed by use of muscle relaxants. So the use of muscle relaxants has been widely criticized during the IONM monitoring. So inhalational agents also has been criticized when there is a MAC up to 1 MAC. And IV agents, the propofol is the agent which has been widely used for IONM monitoring. Along with propofol, ketamine and dexmedetomidine, remifentanil and fentanyl is widely used in IONM modalities. So there are various papers which has shown the anesthetic effects of agents over the IONM modalities and their thresholds. So there are some physiological factors we should also consider during IONM monitoring. These are the temperature, blood pressure and perfusions, oxygenation, CO2 concentration, that's a partial pressure of carbon dioxide, hematocrit or anemia, glucose, electrolyte imbalance, positioning, blood loss, ischemia or intracranial pressures. So while you are conducting this IONM modalities in your OR, we must have one checklist for the person who is doing surgery and for the anesthesiologist and the person who is doing for IONM. So this checklist will give a guide to how to proceed during the surgery, and this is the one alert what to do when some threshold monitoring you are seeing and it reduces from the baseline. So this is the one chart which has given me. You have to go by a tier 1, tier 2 and tier 3 and tier 4 approaches. Like first you have to check the physiology, second you have to go for the pharmacology, then third you have to go for the surgical field and all these things. And in the finally, if you feel that there is a complete loss of yoke potentials, you can go for the wake-up test. Thank you.
Thank you, Dr. Brijesh, for such a wonderful talk on the intraoperative monitoring physiologically. You have explained all the potentials very nicely, although maybe it was a very new topic for many people, but you explained it very beautifully. I have a question that when there's so many electrodes are placed simultaneously,
yeah.
So how do you eradicate the artifacts which may arise because of that?
Actually, this is the hardware part of that machine actually. I could have taken this, but because of that limitation of time. We have now very good softwares in which bandwidth, stimulation, frequency and artifacts you can nullify during that programming. It's a totally software program. It is beyond our understanding. But it is a very good. Medtronic makes anemia clips, and Cadwell is another company which are making. They are very prudent. Nowadays, Dynamed and Inomeds are the companies which are also coming in the picture, which has a very good software doing this, removing this problem. Because definitely in pediatric age group, assessment and the placement of glutes are very near, but definitely it has been taken care because we are doing it routinely. Thank you.
Yes, sir. One question from my side, sir.
Yes, sir.
In meningocele or meningomyelocele, most of the nerves which are exposed earlier are dystrophic.
Yeah.
So, how can the neurophysiological monitoring helps in this case?
So basically, we are here. We go for the first. If such things happens, you have to go by segment to segment during you, and when you open this place, and you have to go by segment to segment, and the free EMG and triggered EMG. So from the triggered EMG, you can have the sensation to which part up to which part their nerves are sending a signals or not, and after that, if you are not getting, then you can say, okay, we are not getting that. Earlier, actually, it was the rule that if you are having the power less than 3/5, we should not go for IONM. It was a dictum that if the muscle power is less than 3/5, but now many studies have arisen which have shown that even 1/5 power or flickering is, even though you have to go for monitoring because you don't know the subtle changes which happened over the spinal cord during the compression or the long period of time. So we should not disheart our things. you should keep on doing INM.
Okay. Thank you, Dr. Brajesh, for a wonderful talk.
Thank you, sir.
Now, house is open for
Thank you.
any question. Any question?
Thank you so much, sir. Now, I would like to request our chairpersons, Dr. Arisha Alam ma'am, Dr. Prem Raj Singh sir, and Dr. Shamendra Pratap Sharma sir to come on stage for felicitating our speakers. I would like to welcome Dr. Mohammed Fahim sir for felicitation. Dr. Brijesh Pratap Singh sir. Dr. Brijesh Pratap Singh sir. Now, I would like to invite Professor Archika Gupta ma'am to felicitate our chairpersons of the session. Dr. Arisha Alam ma'am. Dr. Prem Raj Singh sir. Dr. Shamendra Pratap Sharma sir. Thank you so much, sir and ma'am. Now I would like to invite on stage Dr. Akhilesh Kumar Roy sir, Dr. Abhishek Kumar Singh sir, and Dr. Reenu Kushwaha ma'am on stage to felicitate our next two sessions. For chairing the sessions, sorry. Welcome, sir. Welcome, ma'am. It's my honor and privilege to now invite our esteemed speaker, Honorable Professor Ajay Singh, sir, Vice Chancellor, Uttar Pradesh University of Medical Sciences, CEFI, on stage and share his thoughts on the topic of orthopedic problems in children with neural tube defects and management, providing us insight and guidance drawn from their extensive experience in their surgical care. Over to you, sir.
Thank you very much for your kind introduction. At the outset, I'm grateful to the organizer for inviting me and giving me this opportunity to speak on the orthopedic problem in the children with the neural tube defects. We all know that these defects are due to failure in the closure of the neural tubes, and one of the most debilitating condition is myelomeningocele. And we all know, because the theme of today's conference is it is a multisystemic disease in which we need neurosurgeon, urological intervention, orthopedic surgeon, psychology, and rehabilitation. So as an orthopedic surgeon, our role is to minimize the deformity, to maximize the mobility and the function, to ensure that the braces can be applied and to prevent complication most important is the skin breakdown. So there can be multiple associated congenital anomalies along with these tubes defects. One is a congenital associated kyphosis, DDH, clubfoot, vertical talus. Some are the progressive developmental deformities such as contractures, rotational deformities, foot and ankle deformities such as cavovarus and calcaneus. But there are most important is the iatrogenic complications such as post-operative tethered cord, prolonged immobilization fractures, and the arthrodesis related stiffness. So I am starting with the hip problems. The paralytic dislocation with or without soft tissue contracture is most common hip problem associated with or without pelvic obliquity, which may lead to scoliosis, which may increase if we are not treating it properly. So we have to understand that the ambulatory potential of such children is not determined by the type of the hip reduction or the radiological feature, but it is at the which level this is defect is occurring and what is the neurological level and muscle strength. Radiographic hip reduction does not is prognostically valuable. The management of hip problem is to avoid aggressive open reduction or reconstruction of the hip joint to avoid the stiffness of the hip and the recurrence of the problem as well as the complications. The main goal is to preserve the range of the movement, contracture prevention, or if there, then the release of the contracture to maintain the pelvic level so the obliquity can be avoided. And if there are contracture, then we may go for selective release of the contractures. This is a case in which 3 years old, I have taken this X-ray from my friend Dr. Suresh, and 3 years old paralytic dislocation of one of such boy, which has been corrected by open reduction and osteotomy with acetabulum because the acetabulum was not well formed. And this is at 6 month follow-up and 1 year follow-up. You can see at 1 year follow-up, the hip position is very good and as well as the acetabulum is very well maintained. So hip management, what we should do is preserve the range of movement, correct the contractures if any, and maintain the pelvic balance and focus on the function rather than on X-ray. We should not do aggressive open reduction or corrective osteotomies, and we should not compromise ambulation with stiff hip or recurrent surgeries. Next comes the knee problems. The flexion contracture is most common knee complication. That is because of maybe hamstring contracture, gastrocnemius contracture, or the weakness of the quadricep. Any knee flexion deformity more than 20 degree is very difficult to manage because it compromises the bracing or ambulation. So the management of the knee problem is soft tissue release such as hamstring, gastrocnemius, posterior capsule with long-term functional improvement with the help of the bracing. If there is extension contracture, which are very rare, but sometime the quadricep weakness is there, it is initially corrected by serial casting and we get good results. But if there is no such results are there, then we have to go for quadricepplasty or patellar tendon tenotomy. Then comes the rotational defects of the bone. One is at knee joint is the valgus knee, in which the tibia is going out from the center, and it is secondary to the tibial torsion and the hip weaknesses, which has to be treated. And if child is smaller, then we can go for the guided growth restriction by the figure of 8 plates. Or if child is bigger, then derotational osteotomy with the help of orthosis. Then the rotational deformities occur not only in the tibia but also in the femur. that is the femoral anteversion and tibial torsion are the common one, and which may lead to foot scissoring gait as well as the knee valgus deformities. The management of these rotational deformities, if child is smaller, then we have the ankle foot orthosis with cables, and if the child is bigger, more than 8 years, then derotational osteotomy are preferred. Most common deformity is seen as far as the orthopedic surgeon is concerned is the foot ankle deformities, and almost universal in spina bifida we get some of these complications, and it is very difficult if they are there to treat the patient and to ambulate the patient. Some of the important such deformities are that we have club foot in spina bifida, which is associated in 30 to 50% of cases. It is important to understand these are the complex club foot which are not usually treated by Ponseti technique, which is one of the most acceptable method of treatment of any club foot. These are very rigid, very severe, high recurrence chances are there. So we need either soft tissue surgery or the bony surgery, but our aim is to make the foot plantigrade so that we can put the brace in the child. And vertical talus is one more important bony defect in which talus is not aligning with the navicular, but it is dropping down in the sole, so that the sole is convex, and other is the calcaneus or calcaneovarus. These two are also treated in initial phase, can be treated, or we can try the conservative treatment, but the treatment of choice is soft tissue release with or without tendon transfer. Then the hind foot valgus is very common. Usually it can be varus, but if calcaneus is there, then it can be valgus also. If it is a mild valgus, then we need a rigid ankle foot orthosis with guided growth in children. If it is severe, then tibial osteotomy or calcaneal osteotomy is preferred. But we must understand that we should avoid arthrodesis, that is the fusion of the joints, because stiffness would be there, and there are high chances of the risk of the ulcer in such insensitive feet. Other is the sacral. If there is sacral region, in the morning we have find out that sacral regions are there, and if either there, they are cavovarus deformity, in which the arch, the foot is very much arched, and ankle is rotated inside, and after this is a deformity in which high chances of lateral callosity, skin breakdowns, ulcers, sores, and it is treated by osteotomies, tendon balancing transfers, so that muscle balance can be corrected, because it is a progressive disease and because of the muscle imbalance. But again, I would emphasize that the arthrodesis should be avoided, because it will lead to very devastating stiffness, which may increase the chances of skin breakdown. So this is the complication which is, I think everybody must be knowing, that the skin breakdown and skin complication, ulcer and sores are very much high there. Around 80% of patients may appear with these complications. It is common at the heel, malleoli, sacrum or trochanter. It may lead to osteomyelitis, fracture, and which may lead to amputation. So prevention is the best process, and if we can, it is a multi specialty intervention, in which if we are able to prevent these complications, then we can apply good orthosis, and daily skin check through the parents is very, very important, and patient education is a very key. So if there is I think in the evening we have PMR lecture, in which they will be able to tell you with different orthosis which can help the mobilization, because we have to mobilize such patient with plantigrade foot. so I will not speak on this. There are chances of subcutaneous sternotomies, so major surgeries should be avoided so that the chances of stiffness should be less. And most common site for the subcutaneous sternotomy is tendo-Achilles. So again, I would emphasize that the multidisciplinary care is the key, in which we must have a neurosurgeon, pediatric surgeon, pediatric orthopedic surgeon, and rehab team. And one more thing is the psychologist should be there, because it is having a psychological bearing on the parents as well as on the children. So ambulation is important key, and it can be through the wheelchair or the orthosis, and can be the arches, and so that we should mobilize the patient, so that the chances of disuse, atrophy as well as the osteoporosis should be avoided. In sacral lesions, most of the time it is a normal gait. So the principle of the management in summary is the goal is the braceable feet with maintain hip and knee range of movement, prevent pelvic obliquity and scoliosis. Orthopedic management algorithm is assess the neurological level and the muscle strength. It is very, very important. Then what is the ambulatory potential? It should be maintained. Identify the deformity, if any, whether it is due to muscle imbalance or it is due to the contracture, and the individualized treatment with the multidisciplinary team effort is very important. In conclusion, orthopedic challenges in neural tube defects are progressive and multifactorial. Ambulation predicted by neuro level and muscle strength. Orthopedic surgeons is to avoid the complication and the contracture, so that we can put the brace alignment, so that the joint should be pain-free and the skin should be integrated. And best result is through individualized treatment protocol. It is staged in form, and multidisciplinary continuous follow-up is important to get the maximum results. Thank you very much for your kind patience.
Thank you. Hello. Thank you, sir, for your illustrated lecture on this difficult topic. Now we can have questions.
Thank you, sir, for your beautiful presentation, sir. And I have got one question, sir. In my OPD, sir, I do get patients suffering from spina bifida who actually present to me in late age group, like 4 or 5 years. And many of these patients, sir, they also suffer from CTEV anomaly, sir. So, sir, what is your suggestion or take here? Which should be treated first?
What I have said, but the cause, the basic principle of any surgery, we have to treat the cause first. It is the muscle imbalance, and which is because of the neural tube defect. We have to go for neural tube defect correction. After that, whatever has occurred, maybe due to the original defect as well as due to iatrogenic defect, whatever is the ultimate defect is there, we have to treat, because that is something like muscle imbalance. So muscle imbalance has to be, so first treatment is naturally the defect has to be treated first. After that, we should go for the foot treatment. If it is due to some reason we are not able to operate the spine of the child, then we should start the correction of the foot, but that should not be continued for indefinite period, because it is not going to help unless until we are not going to treat the spine.
We have a patient with chronic ulcer in the foot, and almost half of the calcaneum was lost in the X-ray and MRI films. So, and still the discharge is there. So what can be the Option for these.
Ma'am, you have to excise the osteomyelitis bone. If it is calcaneus, you have to excise that part of the calcaneum, and you have to go for different orthodesis are there in which you have to compromise with the ankle joint. But that is not the good treatment of choice, where orthodesis should be avoided. But if it is infection which is not being controlled by conservative treatment, of course we have to remove it.
Any rule for any cement, bone cement? Or
No, ma'am. Infection is there, then you have to excise the infected bone. After excise, ma'am, weight bearing bone should not be replaced by the bone cement. No. Thank you.
Thank you so much, sir, for this insightful lecture. Tea is being served for all the delegates. Please feel free. Proceeding further, we are delighted to have with us Dr. Sandhya Pandey, ma'am, who is going to give us a talk on the topic skin management after the neural tube defect repairs. Ma'am is currently serving as an associate professor in Department of Plastic Surgery, King George Medical College, University, Lucknow. She is associate editor of Clinical Journal of Plastic and Reconstructive Surgery. She has multiple publications in reputed international and national journals, and her area of interest are trauma reconstructive surgery, cleft lip and palate repair, breast augmentation and reduction, liposuction, rhinoplasty, and body contouring. Welcome, ma'am.
Thank you for kind introduction. Thank you, Department of Plastic Surgery and organizers for giving me this opportunity. Good morning to one and all present here. So now we have understood about the basics and the incidents, workup and everything. So now comes the management. As we have understood that main management regarding neural tube defect is the surgical management, because it is a defect. Once there is a defect, we need to cover it. So it is mainly the surgical management, and whenever the term surgery comes, there is skin aspect also comes. So whenever surgery is considered, the skin is also considered and should be given the importance. So these are the little bit basics which we have already discussed, that NTDs are most common congenital malformation of CNS and result from incomplete closure of neural tube during embryogenesis. Global incidence between 0.5 to 2 per 1,000 live birth, and most frequent forms include meningocele, meningomyelocele, spina bifida and encephalocele. Little bit about the diagnosis and workup. It includes thorough clinical examination, rule out other associated congenital anomalies, rule out other neurological anomalies, and thorough neurological examination and imaging tests including X-ray, CT scans, MRI, whatever is appropriate. So coming on to the surgical management, because I told that this defect should be managed surgically, and there is no role of medical management except for the symptomatic and palliative cases. All patients who are eligible for surgery, they should undergo surgery, and surgical management should be done. So our aim for the surgical management should be, surgery should be able to provide complete closure of the defect. Not only the complete closure, it should provide adequate seal, and there should not be any leakage, so that it can prevent the infection. Also, we should preserve the neurological function. Any surgery or any reconstruction should not hamper the neurological functions of the baby, and it should also facilitate the CSF dynamics. The reconstruction or surgery should not be done in a manner that it should hamper the CSF flow. There should not be any obstruction to the CSF while doing the surgical repair. So these things should be taken care, and they should be considered. So the principles of skin management is basically in the plastic surgery, we follow a reconstructive ladder pattern. What is a reconstructive ladder? Like when we go on the ladder, we have to move step by step. first lower step, then higher step. So ladder means first we have to go simpler procedure, then we can go for the complex procedure, because the child is small and also is mostly babies are infant, so we cannot directly jump onto the complicated procedures even if we have the facilities. So simple procedures are always choice procedures, and the key is simple procedure should be the first choice during surgery. This is the reconstructive ladder which is followed during the reconstruction. The first choice is secondary intention healing, which is not applicable here in meningomyelocele because it is a surgically created wound. However, the primary intention healing, that is primary closure, should be attempted in each and every case. Other options are skin graft and then followed by local tissue transfer, that is local flap, or free tissue transfer, that is free flaps. So depending on the complexity, first we should try to do primary closure. If it is not possible, try to do flap. In flap also try to do simple flaps, local, regional flap, and if that also is not possible, then go for the free tissue transfer. However, few new modalities like tissue expansions are also there, which I will be discussing later. So the new concept is ladder versus escalator. If ladder is there, because we are in the advancing era, so if ladder is there, escalator also has to be there. So what is the escalator of the reconstruction? In escalator is a principle where we do complex procedure first rather than doing the simple procedures, if we have the facilities and expertise. That again depends on the case choice, case selection, indications and contraindications of that particular surgery. So a golden rule should be followed during the reconstruction is like should be reconstructed with like. What is mean? That if skin is lost, give a cover to the skin. If muscle is lost, muscle should be replaced. If bone is lost, bone should be replaced. Compromise should not be there. If skin is lost, we cannot cover it only with muscle. Or if bone is lost, we cannot get away by covering with skin and leaving the bone defect behind. So each and every defect should be covered, and like thing should be replaced with the like tissues. And also the donor site morbidity should be very less or apparently no minimum donor site morbidity. Patient should not undergo surgery in any surgery that can cause a donor site morbidity. In order to treat the defect, we should not give any other deformity to the patient. So various critical components for the skin cover are skin cover. Good morning, Honorable VC ma'am. So I would like to continue. The critical component includes adequate skin, and skin should not only be adequate, it should be appropriate. That is, it should match the color, consistency and texture of the defect skin, and underlying support should be given if required. However, there are certain unfavorable conditions, like if skin is inadequate or inappropriate, then it can cause various complications like wound dehiscence, meningitis, and in cases of persistent CSF leak or even it can cause the mortality. So our aim is to provide adequate and appropriate skin. Why this skin quality is so important while dealing this kind of defect? Because these are infant and skin is already very fragile and diseased. So we have to focus on the quality of the skin, because it is not that we have done the surgery and we have covered the defect. The skin is very prone for the infections. So there will be risk of exposed neural tissue, threatened viability of the available skin, and since the child is growing, so we should consider our surgery that it should not hamper the growth. Growth restriction should not be there due to the surgical steps. And also in cases where it is unfavorably located, like dorsolumbar regions, there can be stretching effect. When child crawls or sits, then there can be stretching effect. So these things should be considered. And also if complication happens, it is very difficult to manage and it is sometimes life-threatening. So during surgery itself, we should plan carefully to avoid these complications. As I told that if skin is compromised, it can lead to unstable scarring, and child will be prone to trauma, and there will be prone to desiccation, and following to the exposure of the all the contents. So the aim of surgery is early closure with good skin, and that too within 24 to 72 hours of the life. So what is the ideal conditions for the skin cover? That it should be tension free, skin should be well vascularized, skin should be durable, it should be non-fragile, and also it should not lead to any residual donor site morbidity while closure. So what are the various challenges during the skin management? First and foremost is defect size and location. As we all know that if it is a small defect and located at lax skin, then it will be easy to close. But if the defect is large and located at the area where skin laxity is less, then it will be difficult to close. So giant defect, thoracolumbar defects, and occipital defect or cranial wall defects are difficult to close. However, other challenges are fragile skin, limited elasticity, associated hydrocephalus, risk of CSF leak, meningitis, etc. So technique for skin management includes, first is primary closure. As I told, in the reconstructive ladder, primary closure comes first. So first all attempts should be given to primary close the defect. However, only small defect can be closed which are less than 5 centimeter. Like this is a child having defect after excision and of the sac, then the skin is closed primarily. However, there is little bit tension, but there is no wound dehiscence. So this is the primary closure of the defect. Next are, after primary closure, then we go to the flaps. In flaps also, first local and then regional and then distant. So what are the various local flap options? Are VY advancement flap. These flap are also from the surrounding tissue. Indications are good to moderate size of defect, and advantage is that it preserves the vascularity and allows the robust cover. Here you can see it is not a primary defect, it is basically dehisced wound, and here this is a VY advancement where both side V flaps are taken and advance into the defect. Other flaps are the rotational flap. It can be either single rotation flap or double rotation flap, and it can also cover the larger defect. Here you can see it's a double rotation flap. One is superiorly based rotation flap, another one is inferiorly based rotation flap, and this is also a combination of rotation flap involving the lumbar arteries. Another one is rhomboid flap. It is also a kind of local flap. It is named rhomboid because of its shape. This is a rhomboid, and this is purely mathematical, but also anatomical considerations are important to choose the line of tensions and line of closure. And it is a very good flap when planned meticulously. It allows good skin and donor side closure. Even the defect is big, flap is big, but we are able to close the donor side if calculations are accurate. Here you can see it's a big defect with the skin defect, and this is the rhomboid flap which is taken from the superiorly. It also includes the perforator, so the quality is good and better vascularity. And this the flap is being transposed to the defect and donor site is closed primarily. Here is the final result. So coming on to the perforator flap, these are also new flaps which are local flap, and what is the advantage that it is based on the perforator so that vascularity is increased. Here these are the perforator flaps where lumbar artery perforators are included in the flap. Next are myocutaneous or muscle flap. Sometimes the defect is very big and skin only is not sufficient and it cannot give the robust cover. So we need to give the muscle support also. So best muscle is latissimus dorsi muscle, gluteus maximus muscle or paraspinous muscle flaps. Here you can see it's a gluteus maximus muscle flap based on the artery, and this is used for the larger defect. Next is the another newer flap, that is perforator plus advancement flap. It is a combination flap. Here we include the perforator. We first mark the perforator with the Doppler and then we proceed with the dissection, and also the advancement flap is done. So this is the, here you can see this is the defect, and in the vicinity a perforator is marked. Because of this shape it is known as keystone flap, and it is having perforators. So the flap is finally advanced into the defect and defect is closed like this. Another one is skin grafting. Skin grafting is rarely used in such kind of defect because it is not a durable cover and it is prone to break. Advanced technique, as I told, is our tissue expansion, but again it is not useful in acute setting because we don't have much time. Tissue expansion needs at least 6 to 7 months and the child does not give us so much time. So it is also not it's a rare possibility. However, in secondary cases, when defect is closed and scar is remaining, for the management of scar, we can do tissue expansion like here. This is the scar following the previous surgery, and then tissue is expanded, and which is used for scar moderation. Last is free tissue transfer or microsurgical transfer. It is very rare in kids because of age of the child, prolonged surgery, and we have other options. So the complication procedures are better avoided in infant if safer and smaller options are available. And options are free LD muscle transfer or free ALT muscle transfer. However, multiple or combination flaps are also done. Here we can see two VY advancement flap on the left side, right side, and left side is a keystone flap, that is perforator and advancement flap. Specific consideration should be taken in the cranial bone defect. If any bone defect is there, we should attempt to fill the bony defect, whether with the autologous or implant reconstruction. In the infant or growing children, autologous reconstruction is always preferred as compared to the implant reconstruction because it can also cause the growth restriction. However, now new generation implants are there which are biodegradable, so we can consider for those implants if autologous tissues are less. Here you can see this is not a meningomyelocele, this was done by us, it was a encephalocele where the defect was there and frontal bone defect was there. So from the cranial wall itself, we took the thin bone graft and we filled the defect. So bone graft options are always available. They can be taken monocortical graft from the parietal bone of the child. Post-operative care is very important. Prone positioning to reduce the pressure on the wound. It is dictum in the plastic surgery. We say that wound should lie on the patient and patient should never lie on the wound. Whatever is the reconstruction is done, whether it is on the back or hand or any surface of the body. Other consideration in the post-operative period are antibiotic and monitoring of hydrocephalus, and if needed, shunt can be or lumbar drain can be considered. Nutritional support for wound healing and regular dressings. So management of complications should always be there with the plastic surgeon, and we should be ready with the plan B, that if any complication comes, then what will be our plan. So options are healing by secondary intention, direct closure or second flap. The preferable option is last, that is second flap. Never try to attempt closure by secondary intention or direct closure because it can lead to again wound dehiscence. So second flap is always better and meticulous planning should be there. This is a dehiscence, wound dehiscence, and another second rotation flap is planned for this patient. Although it looks like primary closure is possible, but it can lead to complication. Other complications like CSF leak, infection, bleeding, and late issues like start.
Time is up.
Sir,
yes. We have the inauguration time.
Okay, it's finished, sir. Early closure reduces mortality and infection risk. However, long-term outcomes depend on the neurological deficit, hydrocephalus, and associated anomalies. Plastic surgery techniques have significantly improved wound healing and reduced the complication. Future directions are bioengineered skin substitute, where the skin quality is compromised and skin is less. 3D printing and regenerative scaffolds can also give a promising result. To conclude with, skin management is a cornerstone for successful neural tooth defect repair. Early, tension-free and well-vascularized skin cover prevents the devastating complications such as CSF leak and meningitis. However, future research on tissue engineering, biological scaffold, and refinement of surgical algorithm to further enhance the outcomes. Thank you. Thank you, sir.
Thank you, ma'am, for your wonderful presentation.
Thank you, ma'am.
Questions are welcome from the audience. Thank you, ma'am.
Thank you.
Thank you so much, ma'am, for such an informative lecture. Now, I would like to invite our chairpersons, Dr. Akhilesh Kumar Roy, sir, Dr. Abhishek Kumar Singh, sir, and Dr. Renu Kushwaha, ma'am, on stage to felicitate our speakers. Professor Ajay Singh, sir. Dr. Sandhya Pandey, ma'am. As we are running late in our program, we will be continuing the felicitation post the inauguration ceremony. Thank you, sir.
आदिश भैया ये चेयर बीच में लेके जाइए वाइट वाला उधर से वाइट वाले बीच में आएंगे सभी को समझा ये हट जाएगा भी ना मुझे स्क्रिप्ट नहीं दिखेगी ना फिर
Good morning, ladies and gentlemen, respected dignitaries, honorable guests, faculty members, beloved alumni, and dear students. आज का दिन सच में बहुत खास है because we are not just celebrating a foundation day, we are celebrating 27 years of excellence, commitment, and service of the Department of Pediatric Surgery of KGMU. आज का ये occasion एक साथ लेकर आया है celebration, knowledge, and of course the memories. हम लोग यहाँ पर सब लोग मिले हैं और बहुत सारी मेमोरीज क्रिएट करने वाले हैं तो लेट मी इंट्रोड्यूस माई सेल्फ फर्स्ट आई एम अक्षता फ्रॉम रेडियो KGMU गूंज आई वर्क देयर एज एन RJ एंड हियर आई एम योर होस्ट फ्रेंड्स कैन यू इमेजिन वी आर सेलिब्रेटिंग 27 years I mean 27 years is not just a number it is a journey full of hard work, dedication and achievements. 27 साल का जो ये सफ़र है ना, इसमें बहुत सारी जिंदगियां को एक नई उम्मीद मिली है, बहुत सारी जिंदगियों को नई स्माइल दिया गया है. KGMU के पीडियाट्रिक सर्जरी डिपार्टमेंट ने सिर्फ ऑपरेशंस ही नहीं किए हैं, उन्होंने ड्रीम्स को हील किया है, फैमिली को रिलीफ दिया है और सोसाइटी को एक बेटर कल दिया है. So let's begin this celebration by inviting our respected dignitaries on the dais. I request Professor J.D. Rawat sir, HOD Pediatric Surgery Department, to present floral welcome to our chief guest, Padma Shri Professor Sonia. Okay. I request all the dignitaries to come on the dais. Our chief guest, Padma Shri Professor Sonia Nityanand, ma'am, Honorable Vice Chancellor, KGMU. Please come on the stage, ma'am. Now I would like to invite our guest of honor, Professor Ajay Singh sir, Vice Chancellor of UP University of Medical Science, SAFI. Please come on the stage, sir. I invite guest of honor, Professor Abjeet Kaur ma'am, Pro Vice Chancellor of KGMU. Please come on the stage, ma'am. Now I invite Professor Virendra Atam sir, Dean of KGMU Lucknow. Please come on the stage, sir. I invite Professor Sumitra Kumar Viswas, ma'am, President of President of IAPS. Now I would like to invite Professor Santosh Karmakar sir, Consultant Pediatric Surgeon, Leelavati Hospital Research Center, Mumbai se. Please come on the stage. Now I invite Professor R.K. Tandon sir, ex-HOD Pediatric Surgery of KGMU Lucknow. Please come on the stage, sir. Now I would like to invite Professor S.N. Kuril sir on the stage. Please come, sir. I would like to invite Professor J.D. Rawat sir, HOD Pediatric Surgery Department.
अच्छा ठीक है सर.
Thank you so much यहाँ पर आने के लिए. It is truly our honor to have you with us today. Now I request Professor J.D. Rawat sir, HOD Pediatric Department, to present floral welcome to our chief guest, Padma Shri Professor Sonia Nityanand ma'am, Honorable Vice Chancellor of KGMU Lucknow. I invite Professor S.N. Kuril sir for the floral welcome of our guest of honor, Professor Ajay Singh sir, Vice Chancellor of UP University of Medical Science. Now I invite Professor Achika Gupta ma'am for the floral welcome of guest of honor, Professor Abjeet Kaur ma'am, Pro Vice Chancellor of KGMU. I invite Professor Anand Pandey sir for the floral welcome of guest of honor, Professor Virendra Atam sir, Dean of KGMU. Now I invite Sudhir sir for the floral welcome of guest of honor, Professor Sumitra Kumar Viswas sir, President of IAPS. Now I invite Professor Nitin Pant sir for the floral welcome of distinguished guest, Professor Santosh Kamakar sir, Consultant Pediatric Surgeon, Leelavati Hospital, Research Center, Mumbai. Now I invite Professor Gurmeet Singh sir for the floral welcome of distinguished guest, Professor R.K. Tandon sir, ex-HOD Pediatric Surgery of Lucknow. लेडीज एंड जेंटलमैन, आज हम सब यहाँ इकट्ठा हुए हैं एक ऐसे टॉपिक पर अवेयरनेस के लिए जो एक बच्चे की जिंदगी को कंप्लीटली चेंज कर देता है, एंड इट्स कॉल्ड स्पाइना बाइफिडा. सोचिए जब एक क्या नाम है? रावत सर और कुलीन सर. रावत बोला था बेटा. कहाँ मैम ने आते आते बोला. कोई नहीं. के सिंह सर वो करो, ओझा सर को करो. जेडी रावत सर एचओडी. ओझा सर को बोलो ना. क्या ओझा बुलाना है ना? नहीं वहीं करो. वहीं कराएं. अच्छा ओके. प्रोफेसर बीके इनको पहले बीक करो. फ्लोरल वेलकम करो. बोलो ना. फ्लोरल वेलकम. Now I would like to invite Professor J.D. Rawat sir, HOD of Pediatric Surgery Department of KGMU.
Sorry for the interruption. I would like to welcome our distinguished guests in the invitees also. So I would like to felicitate Professor V.K. Oja sir. Please, from our resident, one of our residents, please welcome Professor V.K. Oja sir also. Correct, sir. तो देखा सर. Professor Sandeep Tiwari sir. अरे करो. अरे गुरमीत बताओ ना इनको. हाँ सर. सब बोल रहे हैं. प्रोफेसर अविनाश अग्रवाल सर. क्या रहे सर? डॉक्टर प्रोफेसर के सिंह सर. प्रोफेसर आशीष कुमार सर. है याद है. प्रोफेसर अनिल कुमार गुप्ता सर. प्रोफेसर शैलेंद्र यादव सर. प्रोफेसर एच.एस. पावा सर. प्रोफेसर आशुतोष पांडे सर. प्रोफेसर वसंत कुमार सर. हाँ सर. Professor Naveen Chandra sir, Dr. Sunita Singh, अरे ये पता नहीं रेजिडेंट सर क्या कर अरे तो उसको निकाल लो. ठीक सर, हो गया सर. चलिए बाकी अपना.
आज हम सब यहाँ इकट्ठा हुए हैं एक ऐसे टॉपिक पर अवेयरनेस के लिए जो एक बच्चे की जिंदगी को कंप्लीटली चेंज कर देता है, एंड इट्स कॉल्ड स्पाइना बाइफिडा. सोचिए, जब एक न्यूबॉर्न बेबी इस कंडीशन के साथ लाइफ की शुरुआत करता है तो उसकी जर्नी, उसकी लाइफ कितनी ज़्यादा डिफिकल्ट और चैलेंजिंग होती होगी. बट थैंक्स टू आवर डॉक्टर्स, जिनकी वजह से एक बच्चे को नया जीवन मिलता है. और वही बात है हमारी आज की CME का एसेंस, फ्रॉम डायग्नोसिस टू रिहैबिलिटेशन, अ मल्टी-डिसिप्लिनरी जर्नी. और दोस्तों, एक और ख़ास एलिमेंट है आज का प्रोग्राम का, एलुमनाई मीट. वो जो कभी इस कैंपस के कॉरिडोर्स में घूमना करते थे, यहाँ की कैंटीन्स में दोस्त बनाया करते थे, यहाँ की क्लासरूम्स में अपने सपने देखते थे, आज वही एलुमनाई अपनी मेमोरीज़ को लेकर हमारे साथ अपने साथ बैठे हुए हैं. उनका सफ़र हमें याद दिलाता है कि KGMU इज़ नॉट जस्ट एन इंस्टीट्यूशन, इट इज़ अ लेगेसी, इट इज़ अ फैमिली. So please give them a big round of applause. तो कहते हैं ना कि जो भी इंडियन ट्रेडिशन है उसमें कहते हैं कि जब भी कोई शुभ काम करने जाते हैं तो हम लोग दीप प्रज्वलित करते हैं और माँ सरस्वती की वंदना करते हैं. तो अब मैं रिक्वेस्ट करना चाहूँगी हमारे चीफ गेस्ट और ऑल द डिग्निटरीज से कि स्टेज पर जो है लैम्प लाइटिंग सेरेमनी को स्टार्ट करें. हाँ हाँ ठीक है, केवल जो प्रोग्राम है बस इसी पर फोकस करो. ठीक है. अभी मैं हट जाऊँगी. अनाउंस कर दें.
तब बोलना. अभी वीसी मैडम बाहर गई हैं, आ रही हैं.
अच्छा अरे खड़े रहो, कहाँ जा रही हो? यहीं खड़े रहो.
अब तुम सुनो बेटा.
कंफर्म कर ले, वंदना जो है मतलब कब तक करनी है, जब तक दीप प्रज्वलित हो रहा हो तब तक, या फिर मतलब 2 मिनट का
don't interrupt your program.
तो दोस्तों चलिए अब लाइट लैम्पनिंग की सेरेमनी को शुरू करते हैं. लैम्प लाइटनिंग कहाँ है? वही तो मुझे समझ में नहीं. दीपक की रोशनी सिंबल है विजडम का, पॉजिटिविटी का और एक नई बिगनिंग का. और साथ ही आई वुड लाइक टू इनवाइट नर्सिंग स्टूडेंट ऑफ 2022 बैच स्टूडेंट अनुज्ञा, मोनिका एंड बबली दास ऑन स्टेज टू परफॉर्म द सरस्वती वंदना. Ladies and gentlemen, let's join our hands and pray for knowledge, wisdom, and progress for all.
जय जय हे भगवती सुर भारती तव चरणों प्रणमामः. जय जय हे भगवती सुर भारती तव चरणों प्रणमामः. नाद ब्रह्ममयी जय वागेश्वरी, नाद ब्रह्ममयी जय वागेश्वरी. शरणं ते गच्छामः, शरणं ते गच्छामः. जय जय हे भगवती सुर भारती तव चरणों प्रणमामः. त्वमसि शरण्या त्रिभुवन धन्या, त्वमसि शरण्या त्रिभुवन धन्या. सुर मुनि वंदित चरणा, नवरस मधुरा कविता मुखरा, नवरस मधुरा कविता मुखरा. स्मृति रुचि रुचिरा भरणा. जय जय हे भगवती सुर भारती तव चरणों प्रणमामः.
Thank you so much, ma'am and sir, for gracing this occasion. And thank you guys for the beautiful Saraswati Vandana. Now, I would like to invite respected Dr. S.N. Kuril sir, professor and ex-HOD of the Department of Pediatric Surgery of KGMU, to kindly deliver the welcome message. Sir, please come on the stage. Mic is yours.
Honorable Vice Chancellor Dr. Sonia Nityanand, Vice Chancellor FI Dr. Ajay, Pro Vice Chancellor Dr. Abhijit Kaur, our Dean Dr. Virendra Atam, our ex-Head of the Department Dr. R.K. Tandon, and our main person behind the show Dr. Santosh Karmarkar, our President Dr. S.K. Vishwas, Dr. J.D. Rawat, and all other distinguished guests and alumni. Today I extend a very warm welcome, heartfelt welcome to all of you, because it is a very special occasion. And you have come together to a place where the dreams are nurtured and talents are honed and bonds are formed. And today all our alumni is together. It is the biggest testament to the bonds we have, and it is the testament to strength we have. So let us explore our unlimited potential to address this problem, which is called spina bifida, for which Dr. Santosh Karmakar has come all the way from Mumbai. And it is not only an event, it is the formation of our strength in pursuit of unexplored possibilities, so that the benefit is extended to these patients of spina bifida. And I'll finish my welcome with a note for Dr. Karmarkar and with a note for Dr. Sonia Atyanan. For Karmarkar, I will say, since we are in Lucknow, so we will express in शेर और शायरी. For Karmarkar, I will say, डालकर रंग वो नए पुरानी तस्वीर बदल देते हैं. डालकर रंग नए वो पुरानी तस्वीर बदल देते हैं. That's what you have done in spina bifida. And कुछ लोग खुदा की लिखी तकदीर बदल देते हैं. हिम्मत हो रवां तो हर बात है मुमकिन. हिम्मत हो रवां तो हर बात है मुमकिन. कुछ लोग तो कमान से निकले तीर बदल देते हैं. So this is what you have done for spina bifida. This is what you have done. And for Dr. Sonia Atyanan, I'll say, सूरत के साथ साथ सीरत भी कमाल की. सूरत के साथ साथ सीरत भी कमाल की. खुदा ने ऐसे लोग कम ही बनाए हैं और जिनको बनाया है वो देखिए आज हमारी मीटिंग में आए हैं. So I'll stop here because the time is short and we'll thank you all.
थैंक यू सो मच सर. अब मैं इनवाइट करना चाहूँगी प्रोफेसर एंड हेड ऑफ द डिपार्टमेंट ऑफ पीडियाट्रिक सर्जरी ऑफ KGMU एंड द ऑर्गेनाइजिंग सेक्रेटरी ऑफ दिस फाउंडेशन डे, डॉक्टर JD रावत सर, टू प्रेजेंट द डिपार्टमेंटल रिपोर्ट.
Good morning, everyone. Honorable Vice Chancellor, Madam. Honorable Vice Chancellor of Dr. Ajay from Safai, and Pro Vice Chancellor, Madam. Dean Dr. Birendra Atam, sir. Dr. S.K. Vishwas, President of Indian Association. Dr. Santosh Karmakar, Consultant Pediatric Surgeon from Lilavati Hospital, and Dr. Professor R.K. Tandon, my mentor, Dr. Kuril, and the esteemed faculty members, invited faculty, delegates, employee of the department, resident, media person, all the NGO who is helping our patient. Very warm welcome from the Department of Pediatric Surgery. I am brief about the annual report of the Department of Pediatric Surgery. The Pediatric Surgery Department was created in 1998 from the Department of Surgery. Before that, it was a unit of general surgery, and it was created by late Professor A.K. Baklu in 1977, along with Professor R.K. Tandon. The first head of department was Professor A.K. Baklu, followed by R.K. Tandon, then Dr. S.N. Kuril. Now Dr. J.D. Rawat is looking the department. Currently, department have 9 faculty with 6 professor, 2 associate professor, and 1 assistant professor who recently joined the department. Dr. J.D. Rawat and Dr. Kuril is professor. Dr. Archika Gupta, Dr. Anand Pandey, Dr. Sudhir Singh, and Dr. Nitin Pant is professor. Dr. Gurmeet Singh and Dr. Piyush Kumar is associate professor, and Dr. Rahul Kumar Rai is assistant professor. Department have 97 employee permanent as well as outsourcing. They are posted in different places in the ward, OPD, OT, and other services. Department is offering MCH course, which was started from 2004 with 2 seat. Now it is 2 seat has been further increased in 2023. And we have a 1 fellowship in pediatric urology that was started in 2004 with 1 seat capacity. And 32 students has been passed from our department, and they are 100% placed in the government and private sector. The department is also offering elective course for MBBS student on anorectal malformation. This was started in 2021 with 8 seat capacity. The department have 2 units with 71 bed. The NICU, well-equipped NICU with 10 bedded, post-operative 13, emergency 12, and elective 36 bedded. 2 operation theater, 1 elective and 1 emergency, and 1 seminar room, and other facility 1 each. These are the faculty in different unit. Beside general pediatric surgery, we are also looking the specialty clinic of pediatric urology, pediatric neurosurgery, and pediatric hepatobiliary, and pediatric oncosurgery. Department is running 3 days OPD in a week, Monday, Wednesday, and Friday, with average 150 patient per OPD, and emergency services 24/7 with 1 CUG number which is running 24 hours. So any patient can come with this number and get admission in emergency. This is the data of total patient of IPD, OPD, and total surgery year-wise. You can see in last 5 years the number of patient and number of admission and number of cases in OT is increasing. You can better appreciate in this bar chart OPD attendance. This is our admission, both emergency and elective. This is major and minor surgery. The department have published 15 articles in various national and international journals with an impact factor of 1 to 3. Currently, 6 research projects is going in the department. 1 is extramural and another 5 is intramural. There are 4 patents has been done in the department over a year, and the most notable is portable muscle stimulator for anorectal malformation as well as for identifying the sphincter in cases of any injury into the perineum. The department have contributed 3 book chapters in different national and international books. The achievement and award and conferences attended by the faculty. The faculty have attended several conferences, national and international, over a 1-year period, and also chaired the session and paper presented. Me have attended 5, Dr. Kuril have attended 3, Dr. Archika 5, and Dr. Anand Pandey 4, so on. This is the faculty award received over 1 year in 24, and me have received 5, Dr. Kuril have received 4, Dr. Archika 5, and Dr. Gurmeet have received 5. This is the fellowship which faculty have received over 1 year. Me have received 3 fellowship, including a FACIS from Edinburgh. Dr. Kuril have received 1, Dr. Archika have received 4, Dr. Gurmeet and Dr. Pube have received 2. Our resident have also received various awards in the various national and international conferences. Dr. Sobha, senior resident 2nd year, have received 5 awards last 1 year. Dr. Preeti Kumari have received 2 awards, and Dr. Manish Rajput have received 1 award. New facility added in the department. Regarding manpower, the 1 assistant professor have joined the department, and 7 MCH students, 4 MCH last year and 3 MCH this year have joined the department. 37 nursing staff have joined the department. So there is a big chunk of the nursing staff which are helping to our patient, and 2 OT technicians have joined. And regarding equipment, upper and lower GI endoscopy, 3rd ventriculostomy endoscopy for hydrocephalus, OT light, OT table, 1 CR machine, 1 portable ultrasound, and patient warmer machine with blanket 4 cases. And infrastructure, renovation of post-operative ward, and separate room for male and female resident, and 1 minor OT. These are some of the picture of a new facility in the department: endoscopy system, OT light, portable ultrasound machine, patient warmer, CR machine, and this is the separate washroom for male and female resident in the department. This year we have also started formative assessment of the MCH student, and this was according to NMC norm. This is the inauguration of our renovated post-operative ward by Honorable Vice Chancellor. And 26th Foundation Day and CME was organized last year with the theme of colorectal malformation, and more than 150 delegates were attended. We are also inviting the guest lecture from KGMU faculty, especially from the pediatrics, for the fluid electrolyte imbalance in children, for the enhancement of knowledge of the faculty as well as for the resident. This is the neonatal resuscitation by the Department of Pediatrics. And then there is a renal diseases for the Department of Pediatric Surgery, Pediatrics. We have also invited the guest faculty from outside the KGMU, and Dr. Sandeep Kumar Sinha is our alumni. Is very good in the minimal invasive surgery in pediatric laparoscopic cases. So he took the classes, and it was very informative to our faculty as well as to the resident. Various social activity has been done in the department. National Birth Defect Awareness Program with collaboration with the Department of Pediatric and Pediatric Orthopedy was organized. And then Nursing Day celebration was also celebrated. Then International Pediatric Cancer Day was celebrated along with the Department of Pediatrics. This is the blanket distribution by various NGO in the department. This is the Children Day celebration in the department. The chief guest was Madam Professor Abhijit Kaur. And this is the Pediatric Surgery Day. National Pediatric Surgery Day was celebrated with theme of promotion of knowledge about the congenital birth defect into the population, and this was done in the OPD. This is Teacher Day celebration in the department. This is the donation of 1 computer set by the Barsa Foundation to our office for the day-to-day work, and thank you the team Barsa for giving this computer for the department. We have also celebrated the Christmas Day. International Pediatric Cancer Day was celebrated, and awareness was done, and the chief guest was our Vice Chancellor, Professor Sonia Nityan ma'am. Various social activity has been time to time published in the print and electronic media and the KGMU Guj. The deficiency in the department, regarding the manpower, we have 5 seats vacant of faculty in the department, 6 senior resident, non-MCH. We have a deficiency of the nursing staff because many of the nursing staff, they have promoted, they have left the department. So there is a need of more nursing staff. Class 3, Class 4 employee as well as the ventilatory technician we need in the department. The equipment which is long pending, that is the laparoscopic instrument, although we have laparoscopic set in the elective OT, but we need additional for the emergency OT. Urodynamic is the need of NMC, so this is our long demand for this also, and we need our OT to be undergo modular OT. And the most important is that space constraint in the department. This is the area where we cannot able to understand how we can expand our department for the faculty chamber, for the NICU, PICU, and for the space for the mother, baby, and patient waiting area. So in this stage, I would like to request administration that once the general surgery department shift to their new building, kindly that area should be given to the Department of Pediatric Surgery. So for this, I will request, madam. And the one more thing is that our seminar room, there is no audio-visual system. So this is also need of teaching and training point of views. So vision of the department is, most important is that infrastructures that we need, and clinical research and innovation, 6-year MCH course in pediatric surgery. We want to start fellowship in other specialty like minimal SS surgery, pediatric gastrosurgery and pediatric oncosurgery, robotic surgery, NABH certification, promotion to the faculty as well as resident for research and innovation, organize and attend conferences and workshops. Forthcoming conference of National Pediatric Surgery we are conducting in 2026. So I will request all of you, please join this conference. And we also want to start certification course to the nurses for pediatric stomach care, pediatric surgical nursing care, and pediatric minimal access surgery. With this, we have end up the presentation. Thank you everyone for coming and joining this program. Thank you once again.
Thank you so much, sir, for highlighting the remarkable journey and achievements of the department. Now it's time to hear from the respected Professor Dr. R.K. Tandon, sir, ex-HOD of Pediatric Surgery of KGMU, to kindly share his thoughts. Sir, mic आपका है.
Honorable Vice Chancellor, Lucknow. Honorable Vice Chancellor, Honorable Vice Chancellor, Lucknow. Honorable Vice Chancellor, Safai, and dear, dear Sonia Nityanand, and dear Ajay, Priya, Mrs. Chawla, प्रिय डॉक्टर आतम और प्रिय साथियों, हम लोगों ने डॉक्टर वाकलू के साथ मिल करके सन 70 के करीब बीज बोया था और इस समय अच्छी तरीके से फल फूल रहा है। ये सब वाइस चांसलर और ख़ास तौर से प्रेजेंट वाइस चांसलर की दया है और अपार मेहनत हमारे बाद जो दोनों हेड ऑफ द डिपार्टमेंट हुए हैं उन्होंने की है। उसमें डॉक्टर जलीदार और ऑफ कोर्स डॉक्टर कुरील जो इनके पहले वाइस हेड ऑफ द डिपार्टमेंट थे, इन लोगों ने बहुत साम दाम दंड भेद सामान लेके शुरुआत करी और अब तो इस समय बहुत ही अच्छा डिपार्टमेंट हमारा बन गया है। हमको देख के बहुत खुशी है और हमारे इतने पोस्ट ग्रेजुएट जो हमने 2004 में शुरू किए थे वो भी ज़्यादातर सब सेटल हो गए हैं। ये बहुत भी गर्व की बात है और हम इस बात पर यहीं पर अपनी बात ख़त्म करते हैं क्योंकि ज़्यादातर सारा ज्ञान आपको जलीदार रावत दे चुके हैं। धन्यवाद।
Thank you so much, sir, for your valuable words. Now I request consultant pediatric surgeon of Leelavati Hospital of Mumbai, Professor Santosh Karmakar, sir, to address the gathering. And he is also the orator today.
Sure, I won't take much time. Honorable Vice Chancellor Padma Shri Sonia Nityanand ji, Honorable Vice Chancellor of Sci-Fi, Professor Ajay Singh ji, and all the other eminent dignitaries on the dais, including eminent pediatric surgeons from all over the country. And I must make a mention of Professor Sumitra Biswas, who is the president of the IAPS currently, who's also with us today, and of course, Professor Tandon. At the outset, let me congratulate on behalf of myself as well as the Spina Bifida Foundation, the Department of Pediatric Surgery for doing great service for 27 long years. On a personal note, I've seen Professor Kuril, Professor Rawat really offering day and night effort to make this department into what it is today. And I had a short glimpse of the working of this department day before yesterday when we saw 26 patients of spina bifida. So you have such a big workload, but with your entire dedicated team, and I also saw the great cohesion of the team of pediatric surgery, led very competently by Dr. Rawat. So it was quite impressive day before yesterday. Lastly, I would just say that the topic that you have chosen for today's theme, spina bifida, in a way it has been a little neglected area because it requires multidisciplinary care. So it's like too many cooks. And these children tend to get a little forgotten. So you have brought them and made them visible by way of this meeting is really extremely necessary. And I have to acknowledge the wonderful shero shairi of Professor Kuril. I would just end by saying, हमने कुछ नए रंग उसमें नहीं डाले हैं, जो उनमें ही जो रंग थे, उसको बाहर निकाले हैं. Thank you so much.
Thank you so much, sir. Now I would like to invite our guest of honor, President of IAPS, Dr. Sumitra Kumar Biswas, sir.
I have very little to say, and I am not a good orator also. So my talk will be on of thanksgiving to the Department of Pediatric Surgery, KGMU, to invite me to this occasion of their 27th Foundation Day. The Department of Pediatric Surgery, KGMU, has long cherished history of contribution to academics in pediatric surgery. The anterior sagittal anorexopexy by Dr. Waklu, then the ectopia vesicis repair for Dr. Kuril, and probably many more will also is coming to our folder as academic thing. And one thing I must congratulate and acknowledge Dr. Kormorkar. Dr. Kormorkar was our Secretary General long back in IAPS. But after that, I thought he had gone to hibernation. But now I can see that hibernation was a preparation for established Spine Foundation of India. He is the prime force behind it. And what he has told that this portion, these children we operate, but then we forgot. These children should be followed up till their adulthood or lifelong to know actually what is happening to them. And that is not a job of a single specialty. That is job of a multiple specialty. So I again thank KGMU Pediatric Surgery Department for inviting me. Thank you all.
Thank you so much, sir. Now I would like to invite respected Professor Virendra Atam, sir, Dean of KGMU, to kindly address the gathering.
Dignitaries on dais and off dais, my senior colleagues, residents and students. Today I feel very proud to be a part of 27th Foundation Day and a CME on spina bifida. Spina bifida is one of the important conditions that should be diagnosed as early as possible, must be intervened, and one of the special thing is that physiotherapy. Our few departments like PMR, head of department PR is there, and he must be seeing a lot of patients. And it's very important backbone of the this disease. And now I congratulate the head of department, Dr. Rawat, and his full team to make such a program on spina bifida, and such CMEs are very important for exchanging our thoughts and to help the patients. And also congratulate all the team members to make this event very successful. Thank you very much.
Thank you so much, sir. हर एकेडमिक्स गैदरिंग में गाइडेंस और मोटिवेशन का बहुत बड़ा महत्व होता है. तो अब मैं इनवाइट करना चाहूँगी रिस्पेक्टेड प्रोफेसर अभिजीत कौर मैम को, हु इज़ द प्रो वाइस चांसलर ऑफ KGMU, टू डिलीवर द वर्ड ऑफ विजडम. मैम.
Good afternoon.
in this hall, I actually feel humbled because I have my senior teachers here. I have my colleagues occupying important chairs. I have friends in the hall, and I see a single defense personnel, a senior officer. I congratulate the department on this occasion, and I just add one small thought. You talk of a multidisciplinary management, but you forgot the ophthalmologist. Spina bifida is associated in many syndromes, the golden hour syndrome. That's the commonest. And spina bifida in serious cases has a lot of optic atrophy. So Dr. Rawat, my humble request, don't forget the eyes that see spina bifida. Thank you.
Thank you so much, ma'am. Now, I would like to invite Professor Ajay Singh Sir, Vice Chancellor of UP University of Medical Sciences, CFI, to kindly address us.
बहुत बहुत धन्यवाद। सबसे पहले मैं डॉक्टर रावत का धन्यवाद देना चाहता हूं कि आपने मुझे याद किया और मुझे मौका दिया कि मैं आपके बीच में आ सकूं और अपने सभी बहुत सारे मित्र जो मेरे यहाँ बैठे हैं उनसे मैं रूबरू हो सकूं। मैं प्रोफेसर सोनिया, ऑनरेबल वाइस चांसलर KGMU, प्रोफेसर RK टंडन, माय टीचर, प्रोफेसर अभिजीत, प्रोफेसर कुरील, प्रोफेसर रावत और सभी एस्टीम्ड गेस्ट स्पीकर्स ऑन द डायस, ऑफ द डायस, मैं आप सब लोगों को अपनी तरफ से बहुत ज़्यादा धन्यवाद देता हूँ। सबसे पहले विद द परमिशन ऑफ आवर चीफ गेस्ट, आई वुड लाइक टू कॉन्ग्रेचुलेट प्रोफेसर सोनिया बिकॉज Professor Sonia, this is your birthday today. So, हम सब लोगों की तरफ से आपको बहुत बहुत शुभकामनाएं और मुझे उम्मीद है कि ऐसे ही आप इंस्टीट्यूट की सेवा करते रहेंगे और हमेशा हेल्दी रहेंगे। इसी के साथ मैं अपनी तरफ से सभी जॉर्जियन की तरफ से आपके और आपकी टीम जिसने अभी NIRF में 8th पोजीशन ली है और NAC A++ आपको मिला है, मुझे मौका नहीं मिला तो मैं पर्सनली मैंने आपको विश किया था, बट फॉर्मली मैं सबकी तरफ से आपको एक बार फिर धन्यवाद देता हूँ आपके सारे एफर्ट्स के लिए। ये जो प्रोग्राम है पूरी ऑर्गेनाइजिंग साइंटिफिक कमेटी आप लोगों ने बहुत ही अच्छा ये प्रोग्राम बनाया है, डिटेल्ड प्रोग्राम, और मुझे खुशी है कि इसमें आपने ऑलमोस्ट सारे सेक्शंस को इन्वॉल्व किया और ये एक ऐसा प्रॉब्लम है जो बहुत ज़्यादा समझा हुआ नहीं है और क्लिनिशियंस के लिए एक प्रॉब्लमेटिक है और मल्टीडिसिप्लिनरी होने की वजह से हम लोग इसको बहुत ज़्यादा समझ नहीं पाते हैं। तो मुझे ऐसा लगता है कि ये एक ऐसा मौका है जिसमें डॉक्टर रावत एक मल्टीडिसिप्लिनरी क्लिनिक शुरू करने की ज़रूरत है OPD में, जिसमें एक ही छत के नीचे सारे लोग जो भी आपके स्टेक होल्डर्स हैं वो एक जगह बैठ सकें और सब लोग एक साथ इनको देख सकें, जिससे छोटे बच्चों को इधर उधर भागने की ज़रूरत ना पड़े, एक ही जगह से काम चल जाए। आपने जो अपने डिपार्टमेंट का प्रेजेंटेशन किया बहुत ही इम्प्रेसिव है और मुझे उम्मीद है कि नेक्स्ट ईयर आप लोग आउटरीच एक्टिविटी को भी अपने इस प्रोग्राम में इंक्लूड करेंगे, क्योंकि मेरा अपना मानना है कोई भी डिपार्टमेंट, कोई भी इंस्टीट्यूट अपने कैंपस से बाहर निकल के जब तक कि सोसाइटी के बीच में नहीं जाता है तब तक उसका पूरा जो मैंडेट है वो पूरा नहीं हो पाता। तो मैं आपके डिपार्टमेंट इस इंस्टीट्यूट का एलुमनाई होने की वजह से इस पूरे इंस्टीट्यूट के ब्राइट फ्यूचर के लिए प्रे करता हूं और हमें उम्मीद है कि जो भी जहां हमको पहुंचना चाहिए एज ए टीम मेंबर हम लोग वहां पे पहुंच पाएंगे। आपने एक बार फिर मुझे यहां बुलाया, उसके लिए बहुत बहुत धन्यवाद।
Thank you so much, sir. We now move to the release of souvenir and the launch of 24/7 helpline number of pediatric surgery. I humbly request all our dignitaries to release of souvenir and 24/7 helpline number of pediatric surgery. Ladies and gentlemen, this helpline number has been created with the vision of providing round-the-clock guidance, support, and emergency assistance to parents and families in need. It is a step forward in making healthcare more accessible and more responsive. Thank you so much, respected dignitaries. Let's take a special moment to honor and felicitate the people who have made remarkable contributions. सबसे पहले हम अपने respected dignitaries का felicitation करेंगे. यह सिर्फ सम्मान नहीं है बल्कि gratitude है उनकी leadership, guidance और inspiration के लिए. So I request Professor J.D. Rawat sir, HOD Pediatric Surgery Department of KGMU, to felicitate our chief guest Padma Shri Professor Sonia Nityanand ma'am, Honorable Vice Chancellor of KGMU. Now I request Professor S.N. Kuril sir to felicitate our guest of honor, Professor Ajay Singh, Vice Chancellor of UP University of Medical Science, SAFI. Now I request Professor Achika Gupta ma'am to felicitate our guest of honor, Professor Abjeet Kaur ma'am, Pro Vice Chancellor of KGMU. Now I request Professor Anand Pandey to felicitate our guest of honor, Professor Virendra Atam sir, Dean of KGMU. Now I request Professor Sudhir Singh sir to felicitate our guest of honor, Professor Sumitra Kumar Viswas sir, President of IAPS. Now I request Professor Nitin Pant sir to felicitate distinguished guest Professor Santosh Karmakar sir, Consultant Pediatric Surgeon, Leelavati Hospital, Research Center, Mumbai से. Now I request Professor Gurmeet Singh sir to felicitate our distinguished guest, Professor R.K. Tandon sir, ex-HOD Pediatric Surgery of KGMU. Thank you so much all. Your presence means a lot to us today. Please be seated. Awardees प्रेसिडेंट और एम्प्लॉयज आपको बोलना
On behalf of the Spina Bifida Foundation, we just want to acknowledge a few pediatric surgeons who have helped in organizing this program and to acknowledge their support for spina bifida. So may I request Sneha to please come ahead with the memento. Sneha. Where is Sneha? Okay. There's a memento for Professor Ojha from neurosurgery. Is he there? Okay. May I request Professor Rawat? To Dr. Puri, it was his desire to have such a CME many years back, but it's coming to fruition.
And one more, Professor.
Done. It's all.
हर इंस्टीट्यूशन का असली स्ट्रेंथ होता है उसके लोग हु वर्क डे एंड नाइट विद डेडिकेशन एंड सिंसियरिटी. आज हम उन सभी रेसिडेंट्स और एम्प्लॉयज़ का सम्मान करेंगे जिन्होंने अपने हार्ड वर्क, ऑनेस्टी और कमिटमेंट से डिपार्टमेंट और इंस्टीट्यूशन को प्राउड फील करा है. So as I call out the names, I request each awardee to kindly come forward and receive the honor. I request Honorable Vice Chancellor to present the award for CME. Dr. Shobha, MCS Senior Residence. Non-PG Junior Resident, Dr. Ashwani Kumar. OT Staff, Assistant Nursing Superintendent, Mrs. Anju Verma. Non-PG Junior Resident, Dr. Ashwani Kumar. OT Staff Assistant Nursing Superintendent, Mrs. Anju Verma. Nursing Officer, Mr. Sanjay Singh. Nursing Officer, Mr. Sanjay Singh. Sick Attendant, Mr. Jitendra Kumar. Sanitary Attendant, Mr. Adarsh Kumar. भाई मैं क्या करूं, सर ने बोला है जल्दी जल्दी बोला है, मैम ऐसे ऐसे कर रही है मुझे, मैं क्या करूं. अच्छा चलो चलो. Mr. Jitendra Kumar, Sick Attendant. Mr. Adarsh Kumar, Sanitary Attendant. Ward Staff, Assistant Nursing Superintendent, Miss Rupali Anand. Nursing Officer, Mrs. Kismatun Nisha. Sick Attendant, Mr. Sachin Kashyap. Sanitary Attendant, Mr. Lucky Valmiki. Office Staff, Junior Administrative Officer, Mr. Satish Chandra Yadav. Junior Administrative Officer Mr. Syed Salim Sadiq. I kindly request all awardees after receiving your award to please remain on stage towards the side so that we can have a group photograph at the end. जो भी अवॉर्डीज हैं प्लीज साइड में खड़े हो जाएं स्टेज के ताकि हम लोग अंत में एक ग्रुप फोटोग्राफ ले सकें. मिस्टर अजय पाल वर्मा, कंप्यूटर ऑपरेटर. कंप्यूटर ऑपरेटर मिसेस ममता यादव. कंप्यूटर ऑपरेटर मिस कुमारी रजिया. सिक अटेंडेंट मिस्टर अनुज भटनागर. सिक अटेंडेंट मिस्टर विश्राम मौर्य. सिक अटेंडेंट मिस्टर महेंद्र सिंह. सिक अटेंडेंट मिस्टर सुभाष. लिफ्ट ऑपरेटर मिस्टर आदिल रजा. Congratulations to each one of you. अब मैं चाहूंगी कि जितने भी लोगों को अवार्ड मिला है प्लीज कम ऑन द स्टेज फॉर द ग्रुप फोटोग्राफ. प्लीज कम ऑन द स्टेज ऑल द अवॉर्डीज. थैंक यू सो मच ऑल. अब समय आ गया है कि आज की चीफ गेस्ट को सुना जाए जिनकी लीडरशिप और विजन से केजीएमयू ने एक नई ऊंचाई प्राप्त की है. I feel deeply honored to invite our Honorable Vice Chancellor of KGMU, Professor Dr. Sonia Nityanand Ma'am, to kindly address the gathering.
Thank you. Dr. Ajay Singh, who's the Honorable Vice Chancellor of the UP-UMS CEFI. Dr. Abjeet Kaur, the Pro Vice Chancellor of King George's Medical University. Dean KGMU, Professor Virendra Atam. Our guest of honor, Professor Sumitra Kumar Bishwas, who is also the president of IAPS. Professor Santosh Karmarkar, who is a consultant pediatric surgeon in the Lilavati Hospital Research Center, and I think the president of the Spina Bifida Foundation. Dr. J.D. Rawat, head of the department, Dr. S.N. Kuril, ex-head of the department and one of the founder members, founder heads of the department, and my dear Professor R.K. Tandon. Can you hear me, sir? So the ex-head of the Department of Pediatric Surgery. You know, while I was sitting, he said, I'll address you as dear Sonia. I said, I'll be very happy because he's been one of my esteemed teachers in pediatric surgery. All the other distinguished guests, the eminent faculty members from within KGMU and from outside KGMU. I can see some people from RML Institute and from the Armed Forces. So, and all the staff of, all the residents of the department and all the staff of the department, each and every staff. So first of all, many congratulations on this 27th Foundation Day of the department. And as highlighted by the anchor of this program, she very beautifully highlighted that this shows 27 years of a glorious journey of dedication, commitment, hard work, leading to the department to come up to this stage. A department which started with Dr. Vaklu, late Dr. Vaklu, my respects, my remembrances to his honorable soul, then Dr. R.K. Tandon, then Dr. Kuril, and now, of course, Dr. G.D. Rawat. A very, very beautiful journey that this department has had over 27 years. All the staff, I would like to congratulate you who are working in the department. It's your day of celebration today, that you all have worked hard, dedicatedly, and brought the department here. At the outset, I would also really like to congratulate all the awardees of today, starting from the MCH students to the staff who have been recognized for their work and commitment. Please keep it up, and it shows how you have contributed not just to the growth and development of the department, but to the whole university as a whole. You know, Dr. Ajay Singh very generously highlighted about the A2 plus of, awarded by NAC to the university and to our, to the NIRF ranking, which shows that KGMU is in the first 10 medical institutes of the country, and it's the hard work of each and every person that contributes to bringing the university to this level. And I take this opportunity to congratulate the pediatric surgery staff. The journey, Dr. G.D. Rawat, you presented a very heartening report of the annual report of the department with so many awards to the faculty. It's very endearing to see that. And so much of, patient care services that have been rendered by the department. So many congratulations. I can see a lot of publications. I can see research projects. Of course, more extramural research projects to follow. And it's been a good contribution of the department. While I was sitting below on the sofa, Dr. Kuril was highlighting to me, I think Dr. Archika has recently received 4 or 3 awards in Pune. So it gave me a feel that this department is very well decorated. The faculty is very well decorated with awards. The department has grown. I can see that it has now started advanced procedures like GI endoscopy, esophago bronchoscopy, minimally invasive neurological procedures, including endoscopic third ventriculostomy for congenital hydrocephalus. So congratulations to the department. This, the CME today, which is a multidisciplinary approach to the management of spina bifida itself, is a very good, it's a kind of speaks well of the department, because this is the era for multidisciplinary approach to difficult problems. Everyone is so specialized in their own area that one needs to come together and for the optimal management of patients to have a multidisciplinary approach. So this is a very good sign that the department is showing to invite. I was just, when I entered, I was hearing the faculty from plastic surgery talking about skin wounds and skin flaps. And this is the kind of approach we need. And Dr. Abhijit also highlighted that there is a significant involvement of the eye. So for the optimal management of this difficult situation, this is the need of the hour. And I quite appreciate the remark made by Dr. Ajay Singh for starting a multidisciplinary clinic for the management of these patients, because in one go, you'll get together, even if they come for half an hour, people from different specialities who contribute towards the management of spina bifida will come together for the optimal management of these patients. Dr. Rawat, you highlighted some needs of the department. Be assured, it's a pediatric surgery department. Bachcho ke liye we have a special feeling, special corner, and you made the department grow so beautifully. Your needs will definitely be fulfilled. The administration is with you, you know. So many congratulations again to all the faculty members of the department, to the residents, to the staff for this very heartening one-year annual report. And I hope in the year to come, the department will grow further. Thank you. Jai Hind.
Thank you so much, ma'am, for your precious word, and we are truly grateful, ma'am. So now move ahead. Every successful event is the result of hard work and supporting of many people. तो अब मैं इनवाइट करना चाहूँगी वोट ऑफ थैंक्स के लिए प्रोफेसर अर्चिका गुप्ता मैम को. प्लीज कम ऑन द स्टेज मैम. ओके.
Now we come to end, so I would like take this opportunity to thank our chief guest, Honorable Vice Chancellor Ma'am, to bless us with her words and encouraging us, and whose support our university took new heights. And I hope that with her support, our department will also grow further. Thank you, ma'am. Now I would like to thank our guest of honors, Professor Abhijit Kaur ma'am, and Professor R.K. Tandon sir, and all the guests of honor and distinguished guests. And now I just give my thanks all the guests who come in this inauguration ceremony and make this inauguration ceremony successful. And lastly, I just thank all my residents, staffs, with whose hard work this department is growing faster and giving services to patients, so that patient is going, taking the successful treatment and going home. And lastly, I just like to thank IT cell and media persons and for making this program successful. Thank you all.
थैंक यू सो मच मैम. अब वो समय आ गया है जब हम सब खड़े होंगे और राष्ट्रीय गान गाएंगे, द नेशनल एंथम.
जनगण मन अधिनायक जय हे भारत भाग्य विधाता. पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा. विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा. तव शुभ नामे जागे, तव शुभ आशीष मांगे. गाहे तव जय गाथा. जन गण मंगलदायक जय हे भारत भाग्य विधाता. जय हे जय हे जय हे जय 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 हे.
Thank you everyone. Please be seated.
Now I request all the guests to proceed for the lunch, and I am just beg my pardon that oration is just because it is getting late and everyone has to just go, I guess. So please just join us for lunch. हाँ बोलते हैं सर.
सर लंच के बाद कराते हैं क्योंकि वो ना टाइम हो गया, फैकल्टी हमारी भाग जाएगी। हाँ
सॉरी सर, वो लंच के बाद कराते
भाग सकती है लेकिन रुकेगी ना।
नहीं, लंच के बाद यहाँ वाली तो रहेगी सर, लेकिन वो
थैंक यू मैडम,
आपके नीड्स आप फुलफिल करेंगे.
भाई साहब ये देखो देखो नहीं
मत देखिए, कहीं से भी खींचते कह रहा है भाई, चल पीछे जा। हाँ क्या बोलो, नहीं यार वो सब वो हो जाएगा। इधर से खींचना। ठीक है क्या, इधर से खींचना। ओह काला आ रहा है। इधर से ज़्यादा अच्छा आएगा, ऐसे ले ले ऐसे। ऐसे खड़े रहो। हो गया। ऐसे सामने से खींचे जैसे लगे कि मैं इधर से खींचना थोड़ा सा। अब दिख रही हो, सामने देखो, सामने आई है, दिखाइए। कैसे आ रहा है, ऐसे खींचे ऐसे। हाँ मैम खींचते हैं। मैम एक मिनट, यार मैं उधर देखती हूँ। आ जाओ मैम।
ऐसे पकड़े। अच्छा दिखेंगे, एक मिनट बैठो, बैठे कहाँ हैं? ओह ये अच्छी आई है। चलो चलो खींचो। नहीं भाई,
अंजलि अच्छा फोटो आना चाहिए मैम के साथ।
दीदी पास में आइए।
सब लोग पास में गाना गा रहे हैं।
एक मेरी अकेले, एक मेरी अकेले। तुम्हारी तो मैं बहुत पढ़ाई करूंगी, तुम्हारी बीच में जो है। अंजलि अंजलि
अब सही है। सही है। रीटा मैम आओ, फोटो खिंचवाएंगे। मैम खींचना हमारी। इधर आ जाओ, इधर इसके आगे नहीं, माइक के आगे। इधर मैम, इधर से। मैम के फोन में खींचते भैया। मैम
नहीं, वो उसके फोन में।
अच्छा,
आइए दीदी, कोई बात नहीं।
आ जाओ।
हाँ,
एक इन तीनों
रिंकेश आओ।
एक इन तीनों की आ जाओ।
हाँ, तीनों लोग को
बीच में आओ।
ठीक है।
आओ जल्दी आओ। इधर आओ।
इस लड़के के बीच में खड़ा करो, दो लोग उधर करो। अकेले दो लोग ना।
मैं ग्रुप में हुई नहीं बेटा, मैं डिलीट हो गई हूँ।
ये कोई बात कब हुई? कब हुई?
पर्सनल
ऐड करूँगा। नहीं ऐसे दूसरे की चीजें छूते नहीं है मैडम, ऐसे पाप लगता है। नहीं नहीं पाप लगता है, वहीं चलते हैं।
चलो
जलाएंगे।
अब लाए हैं तो लगाई दे, लाए तो फाड़े को। माइक के सामने कीजिएगा। अबे हेलो, अबे इधर खींचो, इधर खींचो, इधर खींचो।
इधर घूम जाए ठीक है।
बैक में कोई ना आए।
मेरा फोन किसके पास है?
पोर्ट्रेट के लो, पोर्ट्रेट।
मेरा फोन किसके पास है?
हाफ ही है तो हाफ ही ले लो, कोई दिक्कत नहीं। और पास में आके हाफ ले लो, इतने से आ जाए।
राजू मेरा फोन तुम्हारे पास है?
नहीं,
किसके पास है?
हमको नहीं पता, अभी तो दिया था किसी को।
मेरा फोन किसके पास है भैया? चलो ठीक है।
अरे कोई बात नहीं, आ रही ना बराबर से।
ए खींचो 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 यार अवार्ड मिला ना अकेले अवार्ड वाला फोटो खिंचा लेते ग्रुप पर लगा हुआ खातिर
सिंगल सिंगल खींचो।
हाँ सिंगल सिंगल माइक पकड़ के हम कुछ बोल रहे हैं आप खींचो हाँ
बगैर बगैर ऑडियंस के
संजय भैया हंसा दी नहीं हमें तुम हमारा रुकिए
ठीक है।
ये कह दीजिए उसके क्या क्या है।
बोला
तुम सुभाष बुलाओ,
फोन कर रहे सर। हाँ बोला
फटाफट जैसे सिस्टम था वैसे सिस्टम
अनुज को मैं फ़ोन करता हूँ।
केंद्र कीजिए।
हाँ एक आदमी एक 3 लोग 3 जिनको फ़ोन करो।
किसको फोन कर
मैं अनुज को फ़ोन कर रहा हूँ। आप जितेंद्र को किसी और के काम जानते उसको कर दीजिए। हाँ घर के है तो मेरा।
तो अकेले कैसे करेंगे? अच्छा आपका प्राइस लेके जाइए ना, कहाँ से आप दे दीजिए
अरे भैया आपने बुलाया नहीं, मतलब कैसे?
लाइए हम फोटो खींच रहे हैं, क्योंकि बस आपको दे रहे हैं। गड़बड़ हो गया ना, किसी को बुलाया ही नहीं ना, वो
आज का मैंने तुरंत बोला।
कोई बात नहीं सुभाष भैया, हम दे देते हैं आपको।
बिल्कुल
दे दें, यहीं पे स्टेज पे दे दें।
शेर भी दे जो वो सब बैठे सीधे लोग कहीं सारे बहुत खराब है।
अरे भैया जाओ अंदर, कोई नहीं है।
आ गए इधर आ गए।
खाना खा के अंदर आ जाओ, टेबल वोबल इधर करना है, राउत सर बुला रहे हैं।
भैया जल्दी से अंदर आओ, टेबल सही कराना, जल्दी आओ। हाँ हाँ आइए आइए, ओके।
आया ही नहीं है अभी कोई। फोन किए उसको, किसको फोन? सुभाष भैया ये पेपर भी उठा लीजिएगा ये सारा। अरे यार मैं किसको कॉल कर दी? अरे पेपर ये वाली उधर कॉर्नर में थी, बीच वाली उधर। ये रख लीजिए ना, अब बार-बार चले जा रहे हैं। यहाँ रखिए जैसे था। टेबल एक यहाँ लगाइए, 2 टेबल उधर लगा दीजिए, 1 टेबल ऐसे तो था।
जैसे पहले लगा था
2 टेबल उधर था, 2 टेबल वहाँ, 2 टेबल लगा दीजिए उस तरफ।
3 इधर लगेगी ना?
हाँ हाँ 3 वहीं लगेगी।
ये फूल
एक और चेयर लेके आइए वहाँ से, चेयर एक और लेके आइए। हाँ एक और यहाँ लगी थी और 2 चेयर और उधर थी।
हो गया होगा।
नहीं ये
3 तो उधर लग गई ना।
कुरेल सर तो अभी बैठे ही नहीं, बैठे हुए कुरेल सर।
सुधीर सर को बुलाना है ना।
बोल के आए उनको डाल दीजिए डस्टबिन में। हाँ डालिए हमारे
इनका जो सुनो इनका साफ है। अरे साफ है, इसमें रखो, पहले तो बताएं। इसमें रखो, साफ है। क्या कहते हैं, साइटेशन देना है और साल निकाल दो। साइटेशन और कुछ है वहाँ पे दिया है। ठीक है बस। हाँ
काउंटिंग होता है, पता लगा था।
भैया वो सब उनको याद है कि वो भूल गए अपना उनको याद है कि वो भूल गए अपना
सुधीर सर को बता दिया कृतिका
चल नहीं रहा Welcome back, everyone. I would like to invite Professor S.N. Kuril sir on stage to felicitate our chairperson of the previous session. I would like to invite Dr. Akhilesh Kumar Roy sir, Dr. Abhishek Kumar Singh sir, and Dr. Renu Kushwaha ma'am. Dr. Akhilesh Kumar Roy sir. Sir. Dr. Abhishek Kumar Singh, sir. Dr. Reenu Kushwaha, ma'am.
Thank you, everyone. Okay. Now we'll start with the highly anticipated session for the day, the Vaklu Tandon oration. I would like to invite Professor Sudhir Singh, Professor, Department of Pediatric Surgery, King George Medical University, to call our orator for the session. I would like to request Dr. Rawat sir to come onto the stage, please.
वो स्लाइड खोल दो सुनो जो क्या नाम है उनका कर्माकर सर का स्लाइड है एक
स्लाइड वो चला देगा सर अभी
एक कर्माकर सर का इंट्रोडक्शन का स्लाइड
हाँ सर आ रहा है प्रीति स्लाइड चला दी स्लाइड ओरेशन सीवी की स्लाइड वहीं से मैनेज कर
Respected esteemed member, it's my profound honor to introduce today oration, Vaklu Tandon oration, orator Dr. Santosh J. Karmakar sir. He is a pioneer in field of pediatric surgery in India. He is a graduate of the prestigious GS Medical College and KGMU Hospital, Mumbai. Dr. Karmakar holds an MBBS, MS and MCH in pediatric surgery and has dedicated over 3 decades to the care of children with complex surgical problems. From his early year as a lecturer at Sion Hospital to a leading unit at Wadia Children's Hospital, now sir serving as a senior consultant at Lilavati Hospital. His contribution to teaching, research and clinical excellence has shaped the future of pediatric surgery in India and abroad. With more than 50 scientific publications, multiple fellowships at world-renowned institutes like Children's Hospital Philadelphia and King College London, and at present, sir is a founder of Spina Bifida Foundation of India. Dr. Karmakar has championed his holistic care of birth defect and inspired a generation of surgeons. In 2024, sir has elected to be the board of International Federation of Hydrocephalus and Spina Bifida, a reflection to his global impact. As we await his insight today, let us remember, वो हाथ बहुत मुकद्दस होते हैं, वो हाथ बहुत मुकद्दस होते हैं जो औरों के दर्द की दवा बनते हैं. Dr. Karmakar is one such guiding star, lightning path, not just for his patient, but for the entire medical faculty. Let's welcome Dr. Karmakar. Thank you, sir.
सर आओ
is our honor to present citation to Dr. Santosh Karmakar. The Department of Pediatric Surgery wish to put on record their appreciation with fondness and gratitude for the Vaklu Tandon oration to Dr. Santosh Karmakar, Consultant Pediatric Surgeon, Lilavati Hospital, Mumbai, on the 6th day of September 2025 for his exceptional contribution to the surgical care of children and for his effort in enhancing the field of pediatric surgery. Over to Dr. Santosh Karmakar. Thank you, sir.
Sorry. Forward. Good afternoon to all of you. Firstly, I must say, I am deeply humbled by the honor that you have bestowed on me today, and it is absolute privilege and pleasure to be giving this oration at the 27th Foundation Day of your department. So respected chairpersons, and again, absolute delight to have Dr. Tandon with us today, who's one of the persons in whose honor this oration is titled. So thank you very much, sir, for remaining here in spite of the fact that the oration got a bit delayed, but still I'm deeply humbled that you are with us today. Same to Dr. Kuril and Dr. Rawat for inviting me to be a part of the proceedings today. The topic that I chose for the talk was, of course, not unexpected, because I've been dealing and working towards enhancing the lives of children with spina bifida for more than 2 or 3 decades. And therefore, it was probably anticipated that I will speak on holistic and ethical care of spina bifida. The talk will not be a very technically detailed talk about operative techniques and results, but I hope it may change the attitude of some of the people who are here towards the care of children with spina bifida. I must pay my respects to Dr. Vaklu, who unfortunately is not with us today, and he left for his heavenly abode some months ago this year. So my deep respects to Dr. Vaklu, with whom I had the great pleasure to interact on so many occasions, because Dr. Vaklu was very close to my teachers, Dr. R.K. Gandhi and Dr. Snehalata Deshmukh. And so he kept coming to Mumbai and kept coming to KEM. And every time he came, we made it a point to spend some time together and chat about things. And that time I was the IAPS secretary. So Dr. Vaklu and me used to discuss about the department, about the Pediatric Surgery Association. And as you may know, you must have interacted with him also, an extremely joyous, extremely friendly person, and who would really give you unbiased practical advice. And of course, we both that time, he used to be a smoker, I also smoked, and we enjoyed sharing our wills together. Of course, his alma mater of this institution went on to become a fellow of the Royal College. Then he was one of the few, maybe 8, 10 surgeons to come back to India and try and establish pediatric surgery departments in the country. Dr. R.K. Gandhi was one, Dr. M.S. Ramakrishnan, Subir Chatterjee, they all chose not to stay in England, but come back to the shores of this country. And of course, you see a whole list of awards and orations. So again, I pay my respects to Dr. Waklu. Dr. Waklu was very amply complimented by Dr. Tandon, and he and Dr. Tandon together established the roots of pediatric surgery in this prestigious KGMU. And it is really a great honor to be speaking in front of another doyen of pediatric surgery in India, Dr. R.K. Tandon. So coming to the topic of the oration, so as you have heard in the morning, NTDs is also a very, very important topic for which we need to give a little more dedicated care because of the sheer numbers. India has the highest prevalence rates, and a conservative estimate would be about 40,000 cases of neural tube defects happening in India each year. So it's a problem of epidemic proportions and therefore requires epidemic attention. It also causes huge socio-economic impact, as we can imagine, on individuals, on society, and on the nation as a whole. Unfortunately, a child born with neural tube defect has to face a lot of hurdles today, considering the fact that the healthcare scenario in India is very fragmented and very disorganized, as opposed to some of the European countries where there's a nationalized healthcare system. And of course, prevention is better than cure, but there's very little awareness about prevention of neural tube defects. And as all of us have been mentioning since morning, that this requires multidisciplinary care. So you have a lot of doctors from different specialties who treat spina bifida. But the question still remains is that, is this care which we all are giving from our various specialties, is it ethical? Are we giving proper ethical care? And are we giving complete care? Are we treating them completely? Are we treating them holistically? These questions are not just relevant to our country, but to many parts of the world where similar situation exists. So are we treating them completely as patients? And if we are we treating them as human beings? So these are questions for food for thought, and we will deal with a few of them today. So the ethical issues that arise with respect to spina bifida are the ethics of antenatal detection, the ethics of counseling after detecting a fetus with NTD, or after seeing a child born with a MMC. How do we counsel them? Is it ethical? Then, of course, treatment and its issues. Euthanasia is sometimes mentioned in this context. And then we have rehabilitation, the rights of the disabled people. and who makes decisions, so on and so forth. I am currently one of the directors of the International Federation, and we realize that there is no universal ethical and holistic care guideline for spina bifida. And hopefully, in the coming year or two, we will form a universal draft for universal guidelines. Talking about antenatal detection, in 1980s, NTDs were primarily detected by maternal serum AFP, not very accurate always, but there was nothing else available. In the 1990s, antenatal ultrasound became the mainstay of antenatal diagnosis. However, in those days, in 1990s, they did pick up NTDs antenatally, but surgery, anesthesia, antibiotics, etc., what was not so much advanced, and people were not sure about the outcomes. So 90% of cases landed up being terminated. And this created an international ethical debate where it was questioned that should you detect something only to terminate. So if you think that's a very important ethical issue, do you want to detect something in a fetus just because you know that you would terminate it? Okay? So this was a big ethical question which arose at that time. However, today, we all know that a majority of NTDs have to be detected antenatally. And so when you have a fetus which is diagnosed with a neural tube defect, what are the possibilities that can happen? One, as we said, you may collude with the family and the fetus may be terminated. Secondly, wherever available, you may opt for fetal surgery for the meningomyelocele, and this is becoming increasingly available all over the world as a primary clinical option. Thirdly, the child may be born as a stillbirth, and there are a lot of stillbirths who are now detected to happen because they have an NTD. So that's the third possibility. And lastly, of course, as we all know, the child may be born alive with a meningomyelocele. So then we come to the most important question. Either you have a fetus with an NTD or you have a child born with MMC. How do you counsel? What do you tell them? Should you have a pessimistic attitude? Should you have an optimistic attitude? Should you think that the glass is half full, or should you think that the glass is half empty? Because entirely I feel it depends on what the counseling doctor, the primary doctor who sees these patients and family, to a large extent, it is what you think at the back of your mind which is going to affect what you counsel. You may say that it's a team and we talk to parents, we tell them everything, and then they decide. So, but the way you tell them, the way your facial expressions, that will subconsciously communicate that the glass is half full or half empty. So it is the attitudes of the counseling person or specialist. It may be an obstetrician, it may be a pediatric surgeon, it may be an ultrasonologist. So it is their attitude which will determine what is counseled. So let's think of how our attitudes are shaped towards a condition like NTD. In some places, it's not difficult to understand. There are religious objections to abortion. So if you are in Poland or if you are in Ireland, then your Catholic religion does not permit abortion. So you can't counsel for termination of pregnancy. On the other hand, a country like Netherlands, in many cases with severely affected newborns, allows active euthanasia. So there's a whole spectrum of these moral and religious beliefs which may shape the attitude of the doctor, but then those things are a bit easy or different. In India, I think we are not religiously against abortion, but majority of cases. But I think what affects our attitude, and I'm hoping after this talk that attitude may slightly change, is then what is our view about the quality of life that these children will lead? Do we believe that they can lead happy, productive, independent lives, irrespective of socioeconomic strata? Do we feel so? Then, that belief which lurks at the back of your mind may determine how you counsel. Also, what determines counseling is that you have to be sure that they get the proper medical care after birth and for a few more years later. And of course, there should be some possibility of social rehabilitation. And we as doctors can play a role in most of these things. So it is these things which determine our attitude and our subconsciously how we talk when we counsel these patients. Another very important thing to mention and to realize, anybody who's treating a spina bifida like deformity or anomaly must realize that the silver lining to this so-called dark cloud, I say so-called because today I don't think it's a dark cloud, and if I could have more children or would have more children, I'll very happily say I don't mind a spina bifida child. The silver lining is that they have to be mentally completely normal. Have to be in the sense they are. If they get all the proper treatment on time, if hydrocephalus is diagnosed, which it should be, and a shunt is put and not delayed for 6 years, then there's no issue about the mind. So this anomaly is a pure physical locomotor issue with, of course, some incontinence and other minor issues, but not a mental abnormality like cerebral palsy. Many times the spina bifida group of children are lumped with cerebral palsy kids, and they are sometimes told that take admissions in special schools. And I have so many instances where the child has gone to a special school and I had to remove them, get them removed and put in a normal school. So it's not a mental disability. So that, we all know that, but I think that realization has to sink in when we counsel. And here are examples of, children we have treated from birth, and out of the examples I'm going to show, most of them are from poor socioeconomic strata, not wealthy families or, who could probably get everything they need. Parth is a boy born with spina bifida, unable to walk, but completed all the treatment, underwent several major operations. Today he works in a bank and he can't walk, but he's a great swimmer and has won Paralympic medals in swimming. And apart from the bank job, he wants to also become a swimming coach. So, and here he is being given an award, sports award by our ex-chief minister. Khushi is another great star, wheelchair user, spina bifida person, underwent all the operations, and is a great motivational speaker, comes from a poor family, a small one-room house, you can imagine, in Mumbai. The father divorced the mother because she gave birth to a handicapped child, raised by a single mother against all odds. But today, she is called on reality shows to give motivational talk, and she runs her own NGO. So, two pretty ladies born with spina bifida need some support while walking, not wheelchair users, but need some support, had incontinence, got the incontinence operations done, did do the CIC, the MACE. Both of them got married during COVID and have two healthy children. One is a Mehndi artist, the one on the right, from a small town, from Aurangabad in Maharashtra, and the other one works as an executive in a company. Margot was the ex-president of our international federation. She's a pediatric geneticist from Glasgow, wheelchair user, born with spina bifida, has a VP shunt, and she is one of the most fashionable ladies I have ever met, because for each dress that she stitches, she makes a matching wheelchair cover. So if it's a pink purple dress, there's a purple cover for the wheelchair. And on the other side, it's a black and white striped cover. So it's all in the mind. But when I show that previous slide, people may think that, oh, you are talking of Glasgow and that's different. We are talking of, smaller villages and cities. So this girl, Divya, who is now an IT executive in Chennai, was born to a farmer in a village near Chennai. They got her educated somehow, poor farmer, and then she became a B.Tech, got employed, she's a wheelchair user, she has incontinence, married a colleague from the company, and go back. Yep. So, and she now has two healthy daughters. This is the first one, but from a low background. This lady was the first HOD of neurosurgery, first female HOD of neurosurgery in US. Okay, born with spina bifida, has a shunt. Only difference is Dr. Oja operates standing while she operates sitting on a wheelchair. Here are a group of our patients, all wheelchair users, who recently formed a band of the Spina Bifida Foundation. They gave it its name, Elixir. One of them designed the logo of this band, and they are called for performances in different parts of India as a band of wheelchair users. Some more pictures of, people from poor, humble background. The one on the right, the girl in blue dress, she is the daughter of a construction worker, migrated from West Bengal to Mumbai, has undergone all the surgeries possible, and the foundation is helping her in her rehabilitation. So we have all that, and these are a few examples which I have showed you. There are such examples from across the country now. And if you see that this is the outcome that is possible, maybe you will tend to look at counseling some of these babies born with neural tube defects a bit differently. So what do you counsel? when you see a fetus with a NTD? Will you say MTP, or will you maybe say you could carry on? It's not easy because, you don't know what the future holds. But then let me narrate my experience a bit. I am the same person, maybe albeit with less hair and some gray hairs. But 25 years ago, I used to say the same possibilities that may happen in a fetus with NTD. There'll be paralysis, there'll be incontinence, there'll be hydrocephalus, you'll need 5 major operations in the first 5 years, so on and so forth. And I used to tell the family, okay, go, think about it, and come back and tell me what you want to do. And they would, 90%, 70% or more, would come and tell me they want to abort. Today, I am the same person. I say the same possibilities, same things that this child may have, but 90% want to continue. And why do you think this is so? There's only one small difference that I do. I tell them, before you decide, please go and meet Tanishta Singh and her family from Lucknow, if they are from Lucknow. If they are from Meghalaya, it's different. Calcutta is different. We have now families across the country. And I say, please go and meet them, then take a call what you want to do. Or if they are from a remote village, and some girl rang me up last year from some remote village in Punjab. And so we said, no problem. You do a Zoom with these 2-3 families and girls who are similar to you. And after they have met the family, or they have done a Zoom and interacted with the family, the same people come back and say they want to continue. So it is what they are able to see that they believe. The same prognosis, same explanation, same possibilities, but when they go and see that a child who had all these things is in college and is bright and brilliant, they will come and tell you, don't abort. So that was about how my journey in counseling has, and my job actually has become easy, because I don't have to really discuss too much with them. I have to tell them, just go meet this family, interact with them, and come and tell me. Let's come to one more possibility which does improve the outlook and prognosis in neural tube defect, and that is the possibility of fetal surgery. So in large part of the world, entire Europe, entire Americas, South, North, whatever, and a lot of Southeast Asia, Singapore, Hong Kong, Taiwan, fetal surgery is given as the first primary clinical option if a fetus has a neural tube defect. There are a few flip sides that the incidence of prematurity may be more, the mother will require closer monitoring, etc. But it's the established primary option and may be available in India sometime soon. In 2019, just before the pandemic, I spent some time in a place where the largest number of fetal MMC repairs are done, and this is a place called Katowice in Poland. And Agnieszka, who leads the team there, has come to Mumbai and India a few times, and we hope to collaborate with her to start fetal surgery for MMC at our center soon. So that's again going to be a possibility. And these are some pictures of the fetal surgery. The uterus this is open fetal surgery. There are centers now doing fetoscopic fetal surgery. But even in them, it is done with the uterus delivered. Hysterotomy is done. The uterus is opened. And then the back of the fetus and the MMC is delivered through the uterine wound. And it is repaired exactly like we would repair it postnatally. However, Of course, the tissues are a bit delicate and different in their feel and consistency, so it may require a bit of practice. But it's eminently doable, not costly, completely possible, and we may be embarking at least some centers. I know in Dr. Mohan Abraham Center or some other place, they may be able to do fetal surgery for MMC. So, antedating fetus, you decide, you counsel, or you may do fetal surgery. But what happens if you see a child who's born with MMC? There are some issues which arise, and there have been in the past some approaches to this. Should you treat everyone? Should you not treat anyone? In Netherlands, as I say, they decide whether to do active euthanasia passive, which is crazy. But Netherlands is a crazy country. Okay, you can buy marijuana on the vending machine on a street. So let's not talk about Netherlands. I think they're in some different world. In 1970s, a pediatrician, which you may know the name, Lorber, proposed selective treatment. So he had a ward full of neural tube defects, and he would go with his unit, take a round, and go from patient to patient, saying, treat this, don't treat this, treat this. So, in short, he was playing God with birth defects. And he came under great criticism all over the world, because they said, you cannot go around saying, isko treat karo, isko mat treat karo, isko अच्छे से treat karo, isko छोड़ दो. That is not a role of a doctor, because then you are acting as if you are God. And on the other hand, there is this person from Netherlands who I think is still there, he's alive, not like Lorber. If Lorber was acting like God, this person, Verhagen, is acting like demon, because he is the one instrumental in the formulating the Groningen protocol, which allows active euthanasia for some severe conditions up to the age of now 12. Can you imagine a mother and father allowing active euthanasia for a child which they have raised for 11 years? I think it's cruelty. So here was one pediatrician playing God, and here was another person playing demon. In India, we are mixed, okay? There are patients who come to us, fall at our feet and say, Aap Bhagwan ho. We don't want to be God. At the same time, all over the country, there are bunches of relatives who come and hammer and attack doctors thinking they are demons. We want to be human beings as doctors. So again, this just summarizes what I said as far as the ethical questions in some of these countries. But another couple of important points before we end is that the outcomes not only depend on your attitude, but you may have a great positive attitude, but you should be able to offer complete, prompt medical care to these children. So medical care of spina bifida, I feel it's like an orchestra. It is an orchestra where you have many players. And it's a symphony, they have to play well. Then only you can get good music out of the treatment for spina bifida. And you have all these players who play in this orchestra, in the symphony of spina bifida. So, in an oration, you can't ask me questions, but I can ask you questions for sure. So I'm going to ask a few people to tell me which player is the most important out of this. Would somebody like to answer? Yes, doctor. Who do you think is the most important player? Okay, he says fetal surgery. Would the chairpersons want to answer? Who is the most important person in this orchestra?
I think most important player would be SB support group.
Is the support group, okay. Anyone from the back, the residents? Dr. Shobha, is it? Yes. Who is the most important player? Support group. So a lot of, Dr. Sunita, who do you think is the most important out of this? Okay, lot of support for the support group, but when I showed this slide, I think, was it Patna or somewhere else, and one bright person in the audience, she got up and said, "Sir, none of these, it is the mother." So I said, oh, maybe I should include parents and mother also in this slide. But no, it is not none of these. It is not the mother, it's not the father. Any guesses? Pardon? Primary. So one of these is always the primary doctor. Maybe obstetrician you could add. But no, let me show you. Okay, this person is missing in that group. Okay, and this is the story of all the major centers in India. They have excellent neurosurgeon, excellent pediatric surgeon, excellent urosurgeon, but no conductor. None of these specialists wants to assume additional role of being the conductor, okay, which I have assumed. I'm a pediatric surgeon, pediatric urologist, but I think I do far more service to the community of spina bifida by being the conductor, okay. So, to all the departments treating spina bifida, I think you have to choose and elect or select, or somebody has to voluntarily decide that if I have to get good music out of all the players in this symphony, I will become, apart from being I play my own instrument well, but I also want to be conductor. And that's an important message I would like to give to departments who want to improve the care of spina bifida in their institutions. And then, I don't want to elaborate on all the types of operations, but these are the various things, and you heard all the specialists talk about it since morning, so let's not discuss about hydrocephalus, all is required. So here is a girl who's doing her BA in psychology in Mumbai. She's doing it in the same college where I did my interscience, and these are her pictures when she was born with this large back lesion, and which we repaired with great difficulty. We put a Duragraft and some sealant material to prevent CSF leak. But she is now rehabilitated, her incontinence surgery has been done, she does CIC to Mitrofenov, MACE, and she goes to college on her own, and she is pursuing her degree now. Let's skip these slides, some slides of augmentation. This is not a urology meeting, so I will not elaborate. We do use extensively rectus fascia slings, appendix for Mitrofenov. If appendix is short, then a Monty channel with small bowel, and so on and so forth. Lastly, outcomes will also depend on social rehabilitation. Every 6-7 months, there's a child from a family. We have done the augmentation, incontinence management. Child is socially continent, but they have not sent her or him to school. So what is the use of spending 8 hours and the foundation helping them with financial assistance if the child is not going to go to school? And so as a part of our foundation, we do home visits, we follow them up, and we have got so many of these children admitted now to proper and normal schools. So schooling, ambulation. Last year we held a closed door meeting with about 30 spina bifida adults who are, about 18, 19, into their 20s on psychosexual counseling. And believe me, they are from small towns, villages. And I thought, what will this group answer and talk about this question? But all of them had absolutely excellent practical questions related to their sexual issues. Don't think that a spina bifida child who's 21, 22 cannot maybe walk properly, so they don't think of these issues. So this is what we mean by holistic care. And I was totally surprised, and these were a closed-door meeting without parents, without anyone. They were interacting with each other with a lot of issues related to what will happen, can they marry, fertility, etc. Okay, so let's end by a couple of slides. So after this short talk, I mean, I know attitudes can't change so quickly, but how many of you in the audience are in favor of abortion for a fetus with spina bifida? If you are, please raise your hand. One person says that he is in favor for abortion for spina bifida. How many are in favor of treating all patients who are born with spina bifida and not refusing treatment? Yes, so I think a majority believes that we shouldn't refuse treatment, we should encourage treatment of all patients with spina bifida. Lastly, how many of you believe in active or passive euthanasia? Thankfully, nobody. Great. So all this and our results outcome firstly depended on a change of attitude. My mindset 30 years back is different from what it is today. And only because of that shift of attitude, I think, and of course, with support from various quarters. Leelavati Hospital subsidizes or makes 50% totally free for non-affording patients. So some role of a social worker we all need to play. But if you do that, I think it can be dramatic. What the quality of lives that you can improve. And of course, I need to acknowledge the role of the Spina Bifida Foundation in supporting this journey to enhance lives of spina bifida children and adults now. The last 2-3 augmentations that I have done were 34, 35 years old. So that's possible in India. And we have one session in Spokane now, which Dr. Sunita is coordinating on transitional care for spina bifida. But having said all this, prevention is better than cure. So I think instead of treating, we need to prevent. And the awareness for prevention in India as it stands today is almost zero. So I think we are, on behalf of the foundation, we met Mandavia, the health minister, 1 year ago, and now this month, next month, we may be meeting JP Nadda to try and tell them how important this awareness campaign is to prevent this birth defect. I think some of you have noted this number. If you haven't, then maybe you would like to take a picture. If you call us on this helpline, the foundation will be more than happy to help all your patients for their treatment, for their education, for their social needs in whatever form it is needed. Luckily today we are confident to say that anybody who reaches out to us, we'll try and see that they get their entire medical treatment and rehabilitation irrespective of how deep their pockets are. Of course, if we are bombarded with hundreds and hundreds of calls on this helpline, I don't know if I can confidently say that, but let's hope. India, as I say, is a lot of money. There's no dearth of money. But so if you work 70% as an expert medical doctor and 30% as an expert social worker. No patient needs to go away for lack of money. Unfortunately, most of our specialists only want to do our medical expert part of the work and not our social worker part of the work, which I believe India drastically needs. If you are in NHS, you don't have to be a social worker. You can have your weekends by your lakeside farmhouse and enjoy. But doctors in Mumbai feel they are in UK. They want a farmhouse, they want a weekend golf, but they don't want to be social workers. I don't know whether they're happy. I think I'll end with that. Thank you very much.
Thank you, Dr. Karmakar. We are enthralled by your altogether different elaboration on spina bifida and throwing a new light from a new perspective. So we have enjoyed our talk, and since it is customary that we don't have questions at the end of oration, so I will pass in the mic to Professor R.K. Tandon.
Thank you very much for giving a lecture on the very difficult subject. Although I had a different attitude towards this, just because we have seen so many bad or worst circumstances in which I don't know what they did with their children.
Yeah.
But we had a bad time at that time. That was 1974, 75.
Correct.
So that must have been a difference between the antibiotics and, of course, availability of the pediatric surgeons and everything.
Yes.
But only cases were available. Myelomeningocele and hydrocephalus. That is why we were bound to treat them.
Yeah.
Okay, we had a good result and bad result and worst result. We had a chance to assist Dr. Jack Ray. He was, when I was doing my MCH at AIMS, he operated on a case of myelomeningocele with minimum defect in the foot. Unfortunately, post-operatively, that child lost all the power. He left India on that very day.
Oh.
And told to my Professor Upadhyay, sir, I am so sorry for that particular child. You can't help it.
Yeah.
It's a surgery.
Yes, I mean, even I had 30 years back a similar kind of attitude towards, but I think things have changed, treatments have improved, support is better, resources are more. So I have taken a complete 180-degree turn in my attitude towards these cases. And I sometimes start my counseling by saying, your child is not moving his lower limbs, but you don't need legs to become a pediatric surgeon. You need mind and hands, not legs. That completely changes the tone of the counseling. Thank you very much.
Thank you, sir, for sharing your deep insight on spina bifida and neural tube defects. I hope we all can incorporate the knowledge and wisdom imparted by you in our practice. Now I would like to invite Dr. Ankur Mandelia, Dr. Ganesh Kumar Yadav, sir, and Dr. Ajay Kumar Verma, sir, to please come and chair the next session. I would like to ask Ms. Sneha Sawant ma'am to convey to us the various awareness action and support for neural tube defects undertaken by the Spina Bifida organization.
Good afternoon, everyone. Today, I'm going to talk about awareness, action, and support for the child, adults with spina bifida. So we don't call them patient every time because they are grown up now. Till they are doing the treatment and all, they are patients. But apart from that, they are individuals. So we call them individuals. So India has one of the highest burden of neural tube defect cases worldwide. So as per Anita Kar and others, and already sir has mentioned, 4 to 5 per 1,000 births. That means as per Godfrey Oakley, and they are the experts in spina bifida, 1,20,000 births every year of neural tube defects, out of which 50% are anencephalies and 50% are spina bifida. Anencephalies usually does not survive, so the 50,000 are the cases of spina bifida. And India is the leading cause for stillbirths and under 5 mortalities for neural tube defects. So for us, this is not only a public health concern, but also a call for clinical and policy interventions. Folic acid is a known cause for folic acid deficiency is a main cause for neural tube defect, but there are other causes as well, like temperature, radiation, diabetes, alcohol, and smoking, which is now common, and some pills like anticonvulsant pills, which also can cause neural tube defects. It is proved that folic acid can prevent 75% of cases, as you all know, taken with prior pregnancies. And if taken with vitamin B12, it can prevent 85% cases of neural tube defect. But unfortunately, many women are unaware about this. So what is needed for awareness and prevention in India? Awareness campaign, like Pulse Polio, this awareness campaign is needed. Awareness about spina bifida and its condition. Nobody knows about what is spina bifida. Abhi parsoi we had outreach program, so that parents also didn't know what is spina bifida. Gola, Pete Pigat, they describe like this. So the parents themselves don't know what it is. So awareness about spina bifida and its condition is also important. And prevention actions like supplementation program, fortification programs are also needed. So this was about prevention and awareness. So if we talk about spina bifida, when spina bifida child is born, what happens? Emotional impact on parents, shock and grief, guilt and burden, because there are many disputes. Mere wajah se hua, tumhare wajah se hua. Usually women are the targeted in that family. Anxiety and fear. And some parents and some families comes out, they treat that child, they come out, they get they are strengthened and resilience for that child. And there's a financial burden. Even they are strength, resilience, sometimes there's no proper guidance, no proper treatment available, no support is there. So then if we will discuss about issues, challenges for child, if child is born with spina bifida. So medical, as you all know, hydrocephalus, mobility, I will not describe much about it. But emotional, social, educational, and employment barriers. So emotional, feeling isolated is very common in spina bifida because they are different. So urinary incontinence, that can cause, mobility can cause isolation, low self-esteem because they are not exposed, less awareness, and also depends upon family and doctors how they treat that child. Social, there's a stigma and misconception, limited access in public, so that also contributes in low esteem and mental health. Education and employment barriers, because many, we get calls for school that my child is not getting admission in their school, there's no lift, the teachers are not behaving well, my child stinks, so nobody wants to sit beside that child. So this all issues are also there. So there should be an awareness in schools as well. Limited access in schools and also public areas. Limited inclusion in school and workplaces. So सब बच्चे खेलने जाते हैं and this child is made to sit inside that class. So that child is isolated. So there's no game which that child has been included or involved. And workplaces, opportunities and accessibilities are very less. 1 second, that's mine. So mapping as India, if we have to work for spina bifida, if we have to work, sorry, that's my alarm for taking some pills. So if we have to work for spina bifida in India, so we should work in awareness, prevention, treatment, rehabilitation, and birth defect registry, because birth defect registry, we don't have proper records about how many cases are born. Then if we have proper records, then we can act, how can we can plan what to do. So awareness campaign, as I mentioned, awareness about spina bifida and this. So treatment, good centers are needed. We should develop good centers. We should have financial support, and foundation is also supporting for treatment of children. So rehabilitation, support for mobility aids and physiotherapy and other therapies. School and further education, psychological support, employment and livelihood program. Marriages is an main issue. Parenthood, my child, whether that child can marry is the first question when they come for urine and stool issues. They Baki sab theek hoga na? So this is the question. So we also have to address that child can marry, they can have relation. Parenthood is possible, as sir has already shown, the 2 beautiful girls who delivered, also that wheelchair girl. And we know many others who have their own kids. Also, not only that, they are into relationships. So we also have to address that. And birth defect registry, there should be a population-based study to know how many cases are born, and hospital-based studies are required. Support, as I said, support for this, all things are required for treatment and rehabilitation. So about the foundation, the vision of the foundation is to enable all spina bifida individuals in India to lead productive and happy lives, is the main vision of our foundation. We want all children to lead happy and they should be productive, to prevent all preventable neural tube cases in India. So for that we are doing various other campaigns, advocacy regarding this. So treatment, we do connect with individuals and children born with spina bifida through outreach programs, through helpline number, to doctors and well-wishers. Assessment, identification, then we assess them and then plan for their further rehabilitation. Then treatment and rehabilitation occurs. So these are some pictures that day also. On 4th, we had an outreach program over here in this hospital. And these are some patients to whom we have treated. These are very few Of course, I cannot put all the pictures. This is our helpline number, as sir has already mentioned. So awareness and prevention, we lobby with government. We spread awareness amongst doctors and medical students, and also we take lectures in colleges to make aware, especially to young women. So when I talk about awareness and all, so in 1992, immediately after it was it was said that folic acid can prevent neural tube defect. So in US, it was mandatory to do fortification, as well as they started the campaign. So, and now we are in 2025, still nothing has happened, and we are the leading, we have more numbers than all those countries. So this meeting was for birth defects prevalence and the stillbirths in India. So we were called, and we were a part of that meeting of WHO. So as sir has already told that we met Mandavia sir to appraise him about spina bifida and its prevention and fortification. This is our previous health minister to whom we met, and unfortunately he was changed. So this was advocacy meeting which we had in AIMS on 3rd March, which is World Birth Defect Day on 2023, where resolutions was passed for having a public health awareness campaign should be taken in India. So yeah, so these are the advocacies which we do, and we strongly believe that if we should have a campaign on the lines of pulse polio, how Ek Bund Zindagi Ke Naam everybody knows. Similarly, everybody should also know about prevention of neural tube defect. And if you see others country, they have spent 1 rupee and they save 12 rupees. Similarly, if we spend 1 rupee, we can save 38 rupees. So there's a future food, or superfood we can say. So we talk about supplementation, some medicines to take and prevent spina bifida. There's a superfood. Don't see my picture, but see this tree. Can you guess which tree is this? And yes. So moringa is, there are few researches going on, and which has proved that it has enough folate and folic acid to prevent neural tube defect. So maybe some more researches should come up, and this will be a good source for preventing neural tube defect. So this was, we got some powders, and we made, one of my colleagues made this laddus, which is the easiest way to eat moringa powder. So lastly, I would say spina bifida is preventable, treatable, and manageable. What its need is awareness and action. Thank you. And thank you, Dr. Rawat sir and his team for organizing this and giving this opportunity over here to share my knowledge. Thank you.
Thank you very much, Ms. Neha, for sharing the challenges of the children of spina bifida. I think you very correctly highlighted the simple solution of fortifying food with folic acid to bring down the prevalence. Also, I think one of the things which we can do is any child who comes with spina bifida, when we treat him or her, we should also ask them that when they have their next pregnancy, or others in their family or neighborhood who are pregnant should always go and get folic acid supplementation done. So that is, because in India a lot of thing is by word of mouth, in addition to the campaigns you talked about. I have one question, like what is a hurdle in India for the last 30 years in fortifying food? Maybe you or sir can put more comments on that.
So recent thing which we were part of that. So we had a meeting with FSSAI, but they are not agreeing for fortifying. Because it's a double masking and that, but it's not because we have enough evidence which we have proved that it's not harmful at all. But as some of the scientific committee are against it, so it's not happening. But also fortification also has pluses and minuses, because in various parts of India, the staple food or food is eaten which is different. In the sense, north they will be eating wheat, and south wheat, rice flour or rice things are eaten. And if you say at my place also, we don't purchase any flour. We get what we say, grains, and then we clean it and then send it to miller to grind it. So there's a challenge regarding that, because we don't have, means in other countries they just eat buy flour from the market. Or
So do you have to fortify cereal, or you can fortify like salt, like iodized salt?
so yes, there
is it
are
possible?
some,
I don't
yes,
know.
yes, there are some researches going on. Sooner or later it will happen, I think so.
Thank you.
Hope for the best. Yeah.
Thank you so much.
Thank you. Thank you.
Thank you so much for a good talk. Thank you.
How many multivitamin tonics or the fortification of food you take, the target level, it is defined, well defined in the RBC and the blood levels, and that is achieved in many well proven studies, that achieved only with the intake of folic acid. Yes, supplementation, as a supplementation.
Yeah, very nice talk. Yeah, definitely what Sunita is saying is right. But spina bifida is multifactorial. We know, and we must have to care about that. And according to that, fortification is difficult in practice, because it was given some target population, not to every person. So that's why cereal and fortification of salts, it is little bit tricky, and that's why I think that scientific committee is not recommending it now.
No, but just I have a doubt that if fortification is not going to work, then why are we pushing it? Like if it is not going to achieve that level, it's not clear. Dr. Sunita, like, can you?
So it is actually the target level that is especially for the high risk patient. For the high risk patient, definitely they have to take the tablets. And by the fortification, means in various countries, maize flour is actually the fortified one. And there, actually the motto is to get something. But it is, I'm 101% sure that it is well proven in studies. For the exact
So
dose
fortification
to
is
achieve,
for general
you have to
population, not
yes.
for the high risk.
Yes,
group.
not even for the Indian government recommend the folic acid and iron from the adolescent period, 12th beyond 14 years of age. They have to take the regular iron folic acid. There are many various these weekly folic acid program is there at the CSC level. Government is implying, but how many of Indian population used to attend that adolescent clinic? It is not proven. Otherwise, government has provided, has the provision to distribute free iron folic acid tablets and adolescent from the adolescent in India also. But approach and the means availability is not, cannot be assured by any way. So fortification, they have that, they will consume fortified food.
Okay.
So the thing is that see, supplementation in many countries failed. It has to be together. Awareness, supplementation, fortification has to be together. Reason behind this is 50% or more than that are unplanned pregnancies. So if it means if you're planning pregnancy, then you will be consuming it, right? But if you're not planning it, then it's like it cannot happen. So that's why in many countries fortification is mandatory. But the Indian anemia and the deficiency is so much that even fortifying at that much level is also not sufficient. But at least some initiatives can be taken along with supplementation program, along with awareness campaign and fortification.
Yeah, so over the years it will bring up the levels in the general population, and also the awareness will increase the supplements taken, like periconception maybe. So that is a way forward. Thank you so much. Thank you.
Regarding the timing of starting fortification, it has to be given the perinatal period. So one of the practices which I follow and I find it very useful is that I advise both mother and father to take folic acid. Otherwise, what happens is that the family starts blaming the mother for the problem. So I ask both of them to take this folic acid right after the first child is born. For the pregnancy, they start immediately afterwards.
I think, sir, that is all recommended if already you have a child with neural tube defect. The next pregnancy, if you already have a child with neural tube defect, the next pregnancy, both the mother and father are supposed to take periconception. I think that is a recommendation. Double dose. I think it's normal is 400 micrograms. It's, I think, 1 milligram or like it's... 4 milligrams. 4 milligrams? Yeah. 10 times more, sir. Yeah, right. Thank you.
Thank you, ma'am. Also to all our delegates, that was quite an insightful question and answer session. Now I would like to invite Professor Anil Kumar Gupta, sir, for presenting the role of PMR in management of neural tube defects. Sir is a professor and HOD, Department of Physical Medicine and Rehabilitation at KGMU, UP Lucknow. Sir has also received a state-level award from Government of UP for his empowerment of persons with special abilities. Sir has also received Dr. V.G. Ramarao Travel Fellowship from IAPMR in the year 2011. He has multiple publications and book chapters to his name. Thank you, sir.
Good afternoon, respected Professor Tandon, sir, Professor J.D. Rawat, sir, and Team Pediatric Surgery and other delegates. I have come here to speak role of physical medicine and rehabilitation in neural tube defect. First, I was called by Professor J.D. Rawat to speak about role of physiotherapy. I told role of physiotherapy is very little bit. If I will be allowed to speak role of comprehensive rehabilitation, it will be a better. So I am thankful to Professor J.D. Rawat, sir. So our works to enhance and optimize functioning and quality of life of people with disability and physical impairment. So it is important understanding how to improve the function. Start with understanding how to class the function. If we go for international classification of functioning, disability and health, we have body function and structure. If it is intact, we are able to do activity. And if we are able to do certain activity, we are able to do participation. And if there is some gap between body function and structure, and we are not able to do activity, we are being called disabled. And if because of limited activity, we are not able to participate in normal participation, which is a normal human being is allowed to, it is called a handicap. So what we have to identify the in the institution-based rehabilitation practices, we have to identify what the patient has physical impairment. We have to block the cycle at this level so that he will not be enter into disability and handicap. So physical impairment in neural tube defect, we deal with 6 problems. Apart from surgical management is being done by either by pediatric surgeon or neurosurgeons. So hip dysplasia, sensory deficit, motor dysfunction, sexual dysfunction of the patient, neurogenic bowel and bladder. So hip dysplasia is being discussed, I think, Professor Ajay Singh sir, and sexual dysfunction, neurogenic bowel and neurogenic bladder will be discussed by some eminent speakers. So I will limit my talk to sensory deficits and motor dysfunction in the neural tube defects. So sensory deficits and its sequelae, physical impairment is sensory loss, results in neuropathic foot and pressure ulcers, patient activity limitation, inability to sit for long times, inability to walk in uneven terrains, and patient has limitation to social participation like difficulty in sitting in classroom, performing desk job, or performing farming or construction jobs. So most of the patient which has who has sensory loss develop neuropathic ulcers, particularly in the lower limb. So most of the first and the foremost treatment is debridement and infection control. And the second target is promoting regeneration by optimal wound dressing, maintaining adequate wound condition, and offloading. So there are various offloading methods, internal as well as external. If patient has deformities, so like equinus deformity of the foot, we can do percutaneous tendo-Achilles landing by different method, triple ME section, VY plasty of gastrocnemius, following by total casting. And for external, complete bed rest is ideal offloading. But nowadays we don't advise complete bed rest because there is loss of muscle mass if we allow to do prolonged bed rest. So we give several type of orthosis, patellar tendon bearing orthosis, various type of shoes, half shoes, healing hand sandals, depth inlaid shoes, scotch cast shoes. We can give ambulatory assistive device like walking stick. It can lead to 25% decrease of the weight on the affected limb. Walkers, auxiliary crutches. Then total contact cast to increase the surface area of the foot. Removable cast walker and total contact cast with walking heels. So this is a case scenario. A 15-year-old boy, post-operated meningomyelocele, presenting with recurrent heel ulcer. He was managed with ischial weight relieving knee ankle foot orthosis and patellar tendon bearing orthosis for offloading. So other offloading devices are PTB orthosis, different kind of sandals and total contact sandals are there. So another is 11-year-old boy, post-operated meningomyelocele T11 to L2, presented with persistent ulcer on lateral border of foot because of deformity of the foot. So patient had cavovarus deformity which caused uneven weight bearing, and because of sensory loss there was persistent ulcer. So he was internally rotated with deformity corrective surgery. Triple arthrodesis was done. Foot was make in neutral position, and later on orthosis was given. So third patient, 9-year-old post-operated MMC of the lumbar region, presented with non-healing ulcer of heel managed with platelet-rich plasma fibrin dressing. So another is the motor deficit and the sequelae. So in motor deficit, there will be weakness, spasticity, muscle balance, and deformities. And because of this, patient can lead to difficulty in ambulation and difficulty in sitting and transfers. And limitation to social participation is inability to carry out activity of daily living, inability to learn, work, and earn. So the very pertinent question asked by the parents, will my child walk? It depends on actually lesion level. What the level of spina bifida is, what is the cognition and motivation of the parents as well as of the child, and obesity. So these are chart. If there is lower thoracic level T12, 11 and T12 lesion, so patient will be some abdominal, paraspinal and quadratus lumborum function will be there, no lower limb motor function, lack of iliopsoas function, In childhood, we can start therapeutic standing, but most of the time patient will be complete wheelchair dependence for the mobility. In high lumbar lesion, patient has some iliopsoas function. So patient will be limited household ambulation, but in adulthood, it will be mostly wheelchair ambulation with, may have non-functional ambulation in the home with the help of caliper and crutches. If there is mid-lumbar level L3, L4, patient has strong knee extension, mobility in childhood, household ambulation with limited wheelchair ambulation. In adulthood, 50% wheelchair, usually maintain household ambulation with forearm crutches. Low lumbar level and sacral lesion, they can be community ambulator with the help of specialized orthosis with soft inner lining in all the shoes to prevent pressure ulcers. So other impairment, because of spasticity, positioning is done to reduce the spasticity, exercise program, stretching and strengthening of the overactive muscles, sensory motor integration program, orthosis for prolonged stretching, and there are certain orthosis for tone inhibiting orthosis, different plaster casting, pharmacological management like baclofen, and then neurolysis by alcohol, phenol, or Botox, balance training with balance ball, balance boards, biodex, balance apparatus. And for soft tissue contracture, we can give tractions, wedge plaster casting, surgical releases of soft tissue, and can maintain in by orthotic management. And for bony deformities, usually surgical corrections are required with appropriate indications. The conclusion is the integration of rehabilitation into management of neural tube defect not only enhance functional outcomes, but also improves the quality of life for the patient across all age groups. The multifaceted approach is essential in managing complex health issues, providing a comprehensive care model that extends beyond curative treatment. Thank you. If there is any question, I can answer.
Thank you, sir, for comprehensive coverage of the topic. Just have one question. Should, in all cases, should we do muscle charting to prognosticate and also then compare it with the post-op outcomes? Like, is it really helpful or not required?
Definitely, in each and every case, you should do muscle charting. Otherwise, you will not be able to find when the tethered curve syndrome will be appeared. Because when you are treating surgically neural tube defect in the childhood, maybe you may be shifted to another hospital, you may not be able to recall. Or after 5 to 10 years, you may not be able to recall actually what the muscle power was. If we have good muscle power documentation, and ideally it should be done by yourself also. You can take help of your physiotherapist, but physiotherapist is not super specialized. You are also do manual muscle charting you can do. It is taught in MBBS actually. So it should be documented. Otherwise you will not be able to follow the patient. Because patient कहता है आके जिसका पैर टेढ़ा है कि साहब कुछ हो नहीं रहा, weakness बढ़ रही है. So how can you will identify until unless it is not documented. So each and everything when we see the patient, because patient comes to us around 6 to 7 years of age. Every time we document the muscle power and sensory loss so that we can detect the whether tethered cord syndrome is appearing or not, and we can send to the patient to either pediatric surgeon or neurosurgeon.
Yeah. So I think very important for trainees and our residents to learn muscle charting and document it properly, spend time.
Yeah, it is very important.
In the OPD and then plan for surgery, etc.
Definitely, because it is a recurring problem. because patient has another things like lipomyelin, sometimes surgically we are not able to remove that. And it increase with the time, and patient says we have another bout of neurological deficit. So it is very important to.
Absolutely.
Yeah.
Any?
Yes, sir.
Yes.
Yes, sir. Neuromuscular sclerosis correction is actually very difficult. It should be done only with the exercise and orthosis. I don't have any experience in surgical management of scoliosis actually. But it should be started as soon as possible. You detect the scoliosis, you should try with the braces, underarm braces, and proper standing and stretching exercise of the affected part. And maintain that bracing protocol is very strict one, and particularly in the neural tube defect, sometimes it is problematic because patient has sensory loss. Ideally, in any case of scoliosis, brace should be run about 20 years per hour in a day.
20 hours per
It is practically to prescribe, it is very easy for us. But जो उसको पहनता है उसको मालूम है या पेरेंट्स को मालूम है. तो अभी सर का एक जो क्वेश्चन था कि न्यूरल ट्यूब डिफेक्ट में जो सबसे बड़ा टीम मेंबर कौन है. तो मैं बोलता हूँ रिहैब में सीपी के भी पेशेंट आते हैं, सबसे बड़ा जो टीम मेंबर है उसके पेरेंट्स हैं, मदर एंड फादर. बिकॉज वो बचपन से हमारे पास बच्चे को लेके आते हैं और जब तक वो एडल्टहुड में होगा या लाइफ में जब तक वो जिंदा रहेगा उसकी प्रॉब्लम्स रहेंगी, उसको सपोर्ट करना है. तो वेदर इट इज़ ए सेरिब्रल पाल्सी और न्यूरल डिफेक्ट, जो उसका फिजिशियन है, पेशेंट और पेशेंट के अटेंडेंट खुद हैं, हम लोग सिर्फ गाइड करते हैं. Thank you.
Thank you. Thank you so much, sir.
Thank you so much, sir, for such an informative lecture. Now, I would like to request our chairperson, Dr. Ankur Mandelia, sir, Dr. Ganesh Yadav, sir, and Dr. Ajay Kumar Verma, sir, to please felicitate our speaker, Professor Anil Kumar Gupta, sir. Miss Neha Sawant, ma'am. Now I would like to invite Professor Anand Pandey on stage to please felicitate our chairperson of this session. Dr. Ankur Mandelia, sir, kindly come on the stage. Dr. Ganesh Yadav, sir. Dr. Ajay Kumar Verma, sir. Thank you so much, sir. Proceeding further, I would like to invite on stage Professor Apul Goyal, sir, Professor Manoj Kumar, sir, and Dr. Gaurav Shandilya, sir, on stage to please chair the following two sessions. we would like to invite on stage Professor Tanveer Roshan Khan sir to please give a talk on the topic post-operative evaluation of bladder bowel function in patients with neural tube defect. Sir is professor and head of Department of Pediatric Surgery at Dr. Ram Manohar Lohia Institute of Medical Sciences, Lucknow. He is Secretary UP Chapter of Indian Association of Pediatric Surgeons and awarded Fellowship of American Colleges of Surgeons in 2016. Sir has around 40 publications with 5 book chapters. Welcome, sir.
Respected chairpersons, respected Tandon sir, Kuril sir, Rawat sir, Dr. Archika, and all my dear colleagues of KGMU. It's indeed a great opportunity to talk here on a very pertinent topic what we are seeing daily in OPD. So the topic that has been allotted was post-operative evaluation of bladder and bowel function in neural tube defects. So actually, it is not the post-operative, it's a pre-operative evaluation actually. The things should start in pre-operative period because majority of these patients, they come with incontinence and bowel involvement right in the OPD. So it's always better to see them right from the beginning. We all know what neural tube defects are and what are their classifications, how they going to affect the bowel and bladder. So this is obviously, this is incorporated with the disease itself. So as we have, our learned speakers have already discussed, there are certain in utero procedures, they have promised some better results in these cases, but neurogenic impact is there and that involves the bladder as well as the bowel. So why evaluate bladder and bowel function post-surgery? Because there is always involvement of bladder. That is maybe further detailed, we can know about the detrusor function and the risk it carries after involvement of neurogenic bladder. So that is why we want to know and evaluate the bladder as well as the bowel. Because the sphincter is impaired in most of these cases and the prevalence reaches around 80%. So what are the goals of evaluation? The goals is to assess the surgical outcome, prevent further complications, and obviously enhance the quality of life through the various managements. So what is the timing? For everyone to know that we should start as early as possible the evaluation of neurogenic in the post-operative period. Usually when the patient is returning after discharge, we should know how and ask about the bladder and bowel function. But for in all select cases, we can go for 3 to 6 months post-surgery to allow neurological stabilization so that we can further evaluate them. Urgent in certain cases where it was very clear that there was no involvement, but post-operative something happened, so we can do it. And obviously long-term involvement needs the monitoring and for retethering and deterioration in the further course. So rationale is to early detection of the dysfunction, and we have various intervention that may be involved after early detection. And obviously higher lesions have to have deal with the worse outcome. So challenges are there and they are variable in various setups, and we still don't have that elaborate data for pediatric age group. So how do we start? We start with the clinical assessment. So we start with the history, and that is very important to know the symptoms of the patient involved, especially the daytime and nighttime incontinence, urgency, dribbling, weak stream, obviously UTI, voiding diarrhea has to be asked in all cases, and it should be collaborated with the physical examination, that is the palpation of bladder or any abdominal finding, perineal sensation, and reflex testing in cases of lax sphincters, and obviously surgical scar. Patient quality can be reported by various patient incontinence quality scores, so that can be measured. Now, the key to all this post-operative management lies in the proper evaluation, especially by the urodynamics. So proper urodynamics has to be in the mind of all the surgeons since the beginning of the problems. So a urodynamic assessment is the assessment that provides the condition of the bladder in the post-operative period. We all know that if somebody is doing the urodynamics, they know how the various findings are there. So bladder compliance, detrusor activity, sphincter function, and obviously the PVR we check in all these cases of neurogenic bladders. So this is further classified on the findings of the detrusor activity and the bladder activity. So that can be done by, as we all do, is cystometry and EMG studies. So they can be started 3 to 6 months in the post-operative period and repeated annually or if symptomatic. So some findings are being written. So normal it is more than 10 ml, low compliance risk the renal damage. So that's why it is important. See, the point is to evaluate the child on the basis of the presentation. If it is dribbling and how the bladder is palpable, so that decides your functions. So further delving, we can do the VUDS. That is still the gold standard for all these cases to evaluate the post-MMC. Now, after saying all this, the problem is that we don't get cases who are really that old so that we can do all these cases. So that is really a problem. But what exactly we are going to deal with? So we are going to assess the bladder dynamics, evaluate the sphincter functions, identifying various risk factors that are associated with UDS, and they guide us to manage them properly. So that is a detailed things that have been written here to identify problems as early as possible, and we can initiate the treatment. So what are the key parameters we are going to assess? That is bladder compliance, detrusor activity, sphincter function, leak point pressures, obviously PVR, bladder capacity, and seeing any VOR. Now, as I'm saying these things, they are really difficult to do in our setup because we don't have a grown-up child who can be compliant. But obviously, this is one measure which can actually tell you how the bladder is going to behave after the surgery. So VUDS identify the patterns and the criticals for risk stratification. So what are the high-risk patients? Those who are having detrusor leak point pressures, they are 40 centimeters. So they are the cases where they have chances of scarring and all that. So it is to be known as early as possible so that you can initiate the medical or the surgical management. So other things what we can do is the imaging. Imaging is obviously the first line treatment that is being prescribed, that shows the wall thickness post-operatively and the PVR. That is very important in all follow-up in cases of you can get culture done to show the infections associated, and obviously a KFT or a renal function is very important. So the frequency you do in all cases where you can carry on the post-operative evaluation and follow-up, it has to be done at least in 6-month period. So that's a summary of things you can do. So I keep it VUDS as very important to know the status of the bladder. Then you can go for the ultrasound and VCUG and scintigraphy in later cases. And why they are important? Because they can tell you the situation by how the bladder is behaving, and the frequency which we can use them is written so that it can be done on a regular intervals. Now coming to bowel, that is also important. So history is very important. You ask the mother how the bowel is, and what we see in our OPD, most of them, they are constipated, they don't pass stool daily. So you take history, how the stool, what is the frequency, what is the consistency, how is the made of that stool. So physical examination, very important. Assess the child in the post-operative period in OPD, see especially if there are any fecalomas, and obviously see the sphincters as you have done already, and you know that this could be a loss of perineal sensation. So various tools are available. You can use them to assess the dysfunction, bowel dysfunction scoring. So some neurogenic bowel dysfunction scoring we can utilize, and that divides into various. You can go for X-ray that we all do in our OPDs. We see how the feculomas and how the fecal loading is there. So in select cases, you can go for anorectal manometry and transit times if it is available and needed. So post-operative outcomes in bladder is obviously related to the continence rate. It is very important to see because they are normally not there in most of the cases. So 20 to 40% achieve partial continence without interventions. So long-term needs are needed to manage the bladder and bowel function. So this is again, for bladder, we know the complications are UTIs and the VUR. And for, I'm sorry, it's going back actually. So for bowel, we know chronic constipation and psychosocial impact is very important, and you have to long-term follow them. So what are the management strategies we are having? For bladder, we are having conservative with CIC and medication. Surgical in later cases where that is not improving, we have various surgical procedures to improve them. And obviously they all need monitoring. Bowel management, that can be done by bowel management programs. We have all dietitians. They can give the specific diet for these children, and obviously supported by the laxatives and other dietary changes. And obviously in chronic cases or delayed presentation, we have all surgical procedures in the form of ACE and MACE procedures. So again, a summary of things we can do in post-operative bowel management, bowel function is evaluation is the symptom scoring, anorectal manometry, transit, metabolic cage or fecal analysis, and obviously in very rare cases we can go for certain tissue morphology or immunohistochemistry. So now the key aspects of bladder management in post-operative period is CIC. As we all know, we have been doing this. CIC is very important, and we should not hesitate in starting teaching the parents for the same. So we have medications and the surgical options. They are available in chronic cases. Same is happening with the bowel management. We start with bowel management program. We chart the diet. We tell them parents. We ask them to identify the certain diets which can create problems. They are supported by medications, and very rarely can be provided with some assisted devices or lifestyle modifications in later part of age group. So what is important in all these children is a multidisciplinary care approach. We as a pediatric urologist, neurosurgeon, pediatric surgeon, they all come as a team to manage them and properly follow them with a proper psychiatric or psychosocial support, because that is going to be there for a long time. So still we have challenges, and that is because we don't have data in children, especially with, as I said, urodynamics and video urodynamics. In our center, we have started doing it. Maybe next year I'll come up with data of VUDS in cases of MMCs, because most of the patients whom we are operating, they are infants and neonates. So maybe 1 or 2 years will come with this. So, but still we have, brighter prospect for these children, because multidisciplinary approaches are there. And for us, we have divided our data, and that is around 370 patients, and we have seen continence in only 40% of cases. So, and that too is a partial continence. So, a lot of work has to be done in post-operative evaluation and in the management. So, long-term is obviously we stick with CIC in all those cases so that bladder remains empty, supported by certain medications or Botulinum in certain cases, regular follow-up. And I say to to the parents that you have to be with us till 18 years of age. So the attachment to the follow-up is very important, so that everything goes well. So, to conclude, I would say comprehensive post-operative evaluation is essential in neural tube defects, multimodal assessment, and multidisciplinary approach. And there are certain ongoing research, especially in long-term long-term management and evaluation. Thank you so much, sir. Thank you.
Thank you, Dr. Tanveer, for a very comprehensive talk. And I'll invite any questions from the audience. Yes.
Excellent talk, sir. For the benefit of young faculties and the resident, I have a question. As you said, most of these patients are operated in the neonatal period. So, I just want to know your protocol for follow-up of these children in terms of investigations. When do you get the ultrasound done? When do you get the VCUG done? Do you get it done in all the patients? When do you get the UDS done? Do you get it done in all the patients? Specific finding on ultrasound or VCUG, you will get it done.
See, in follow-up, I say in most of the patients we had problems related to bladder and bowel. So one thing which we are doing, maybe everyone, we advise X-ray in all cases, especially those who are having constipation and distension of abdomen. So that is one, X-ray in follow-up, and ultrasound in most of the patients who are having dribbling of urine or having or needing CIC in that. So before starting CIC, we go for ultrasound to check for PVR, so that we compare in later ultrasound, and obviously get a culture done and train the parents for the CIC. So X-ray, ultrasound, VCUG is still we are not doing much, because still that CIC is doing things for us. I mean, they have improved a lot after doing CIC. But we have done VCUG in certain cases who are being delayed, and they have presented very late to us, because we are also a nodal center for RBSK. So I would like to share this, that because of RBSK, we are now getting a case, a child, a girl came of 16 years of age with meningomyelocele. She wasn't given any treatment. So she came for that just because of RBSK. So we found that, and in those cases, I would go for VCUG and all that. So yes, we are doing X-ray, ultrasound in all cases of follow-up, and VCUG. Recently, for last 6 months or 1 year, we are doing VUDS or UDS in cases which are more than 3 years. So that's how we are doing.
Yeah. Sir.
So, okay. Basant.
Yeah, I fully agree with Dr. Tanveer. That X-ray and ultrasound is mandatory for every visit, 3 monthly or 6 monthly. Urine culture, if he is on CIC, regular urine culture. And VCUG, definitely it was done after ultrasound if there is dilated ureter is there.
Yes.
Correct.
Then,
yes.
then
Yes.
you go for VCUG. It's not the age, it is the ultrasound sonic finding when you find that.
So yes, so I think the biggest takeaway were the aim of treatment is to preserve the upper tracts and to keep the patient dry, and the backbone of treatment, or the most important treatment, remains CIC and maybe adding anticholinergics. VCUG, we advise if there's dilatation of the upper tracts, or as you said, if the patient comes late, because you want to see whether there are any changes in the bladder that has happened.
Right away,
Maybe
yeah.
a furt reappearance or a large capacity bladder or something. Otherwise, the basic workup is ultrasound only, because as you pointed out again and again, doing urodynamics in a young child is a big challenge.
Correct.
So typically we don't do it. We rely only on ultrasound. CIC is the basic
Correct.
treatment that we offer.
Thank you, sir, for an excellent talk. We are following the same protocol at AIIMS Patna also. Just thing to add, sir, that we follow the protocol of teaching CIC to the parents at just before discharge, after operating MMC, and ensuring in every follow-up that they are following CIC. And we are adding one baseline DMSA scan, so that we can have an idea of scars if the patient is in follow-up for a long period of time. And we do maybe yearly scans, DMSA scans, and if at all the scars are changing on DMSA, then we only go for VCOG. We are also a bit conservative about using VCOG very frequently. Thank you, sir.
That's a good idea. Yes, we'll do that. Thank you so much.
Thank you, sir, for such an insightful lecture. Now I would like to invite our next speaker, Dr. Ashutosh Pandey sir, on stage to give a presentation on the topic of management of bladder and bowel after neural tube defect repairs. Sir is a consultant pediatric surgeon at Health City Vistar, Lucknow, and has established the pediatric surgery department at Vivekanand Polyclinic, Lucknow. Sir has developed pediatric laparoscopy as a pioneer from the year 1998. Welcome, sir.
Thank you for the nice introduction. After all the aspects which have been covered about the neural tube defects, we come to the very important aspect, which is the bladder and bowel dysfunction. I thank Tanvi to partly covering my topic. He has already started talking about the management aspect, so I have very little to add, but we'll go into some specifics about the management aspect, and also I'll share my results. So, up to 98% of children with spina bifida have neurogenic bladder in some of the studies. So the incidence is very high. And as previously it was reported that the incidence in India is up to 3.9 to 5 per 1,000 live births. So we have many thousands of children born with neural tube defects, and you can imagine the amount of patients with this urological burden coming to the clinicians. And bladder continence in long term occurs in less than half of the patients with spina bifida patient. Incidence of neurogenic bladder bowel is about 60 to 70%. Symptoms we all know. So very important thing about the symptoms is emotional and the social aspect. So especially the continence issue, it gives rise to a lot of anxiety, negative self-image, and integration into society of these children becomes very difficult. So emotional and social aspect has to be very meticulously taken care of, apart from the medical treatment which we provide. The goals of management are early assessment and starting treatment as early as possible, because that gives better long-term results. Recognition of high-risk patients, symptom control, preventing complications, and improving total quality of life. Just to recapitulate about the micturition reflux and the normal anatomy, this is a very complex interplay of sympathetic, parasympathetic, and the motor pathways, and all of these are affected in patients with neural tube defects. So the treatment, the medical treatment aims at correcting some of these problems if possible. So in summary, before this, I would like to say that as far as theory is concerned, urodynamic study is the most important aspect of the investigation protocol, because based on that only we devise our management strategies. So, but unfortunately, urodynamic study, good quality urodynamic study is not feasible in small children, especially in infants. So we have to go with empirical and radiological based investigations to treat our children. But ideally it should be done, and the treatment protocol should be decided accordingly. So in summary, you can have 4 types of things on urodynamic study: overactive sphincter and underactive bladder, which is type 1, and this presents with urinary retention. Then overactive sphincter and bladder, this presents with increased intravesical pressure and urinary incontinence and pain. Underactive sphincter and underactive bladder, and underactive sphincter and overactive bladder. So these are the basic 4 types of things which we will find on the urodynamic study. So based on this, we will have different treatment strategies. When sphincter is overactive and detrusor is underactive, then these patients can be very easily managed on CIC alone. So they are dry, and CIC will drain the bladders, and these patients will not have major problems of urinary tract later on. If sphincter and detrusor both are hyperactive, then these patients require anticholinergics. So these patients will be dry and somewhat safe with oxybutynin plus CIC. And it will depend upon the detrusor overactivity whether only oxybutynin will work or you'll have to do something else later on. If sphincter and detrusor both are underactive, so these patients they do not have upper tract damage because of low intravesical pressure, but they are leaking. So they can be dry with CIC combined with outlet surgery, like lifting the bladder neck and providing continence to the bladder. Then if sphincter is underactive and bladder detrusor muscles are overactive, so these patients are leaking and they have high intravesical pressure, so they are unsafe for the upper tract. So they will be managed with CIC plus oxybutynin plus outlet surgery if required. Then the principles are obviously multidisciplinary. Management is done, pediatric urologist, gastroenterologist, neurologist, like this is for the overall management, but we are basically here concerned with the urology aspect, so we will deal with that only. For urinary continence, initially we start with conservative and lifestyle management like time voiding, fluid management, restricting fluid to the absolute necessity, and restricting nighttime fluid intake, then pelvic floor exercises and dietary adjustments like avoiding certain dietary things which increase the bladder activity. Then medications, the most important medications are anticholinergics like oxybutynin, tolterodine and others, but they have side effects and they can be very problematic in some patients. Then beta 3 agonists, alpha blockers are also sometimes used, but they have got very doubtful role in patients with neural tube defects. Then botulinum toxin directly inside the bladder and intramuscular injection. And alternative methods of antimuscarinic or the drug instillations are intravesical or transdermal. These methods have relatively fewer side effects and they are better tolerated. So if higher dose are required, so then intravesical oxybutynin can be given. Again, this is, I don't know whether it is available in India or not, because we only have tablets and then oral medications available. But some people have tried tablets by crushing them and then instilling into the urinary bladder, but that has got doubtful role. And transdermal administration of antimuscarinics in higher doses can be given with lesser side effects. And the other important aspect of treatment is catheterization. So catheterization can be indwelling, clean, intermittent, or combination of both, and it can be either prograde or antigrade. And indwelling catheter has got a very limited role. It can be used temporarily, or if it can be combined with the clean intermittent catheterization to provide nighttime dry intervals. Clean intermittent catheterization is the most important. It's the mainstay of treatment of these patients. It can be administered initially in smaller children, and later on as the child grows, he can learn very easily to do self-catheterization. Then catheterization can be either through the urethra or it can be antigrade. Urethral catheterization has got problems. It is not very well tolerated, but initially it can be tried, and especially in smaller children and in girls. So there it has got better compliance. And if it is not working, then we can do an antigrade Mitrofanoff type of a procedure to provide a catheterizable channel. So the treatment, the protocol for CIC is that you have to train these the parent or the children properly, then establish a protocol. You have to have a proper time interval, proper size catheter, which can be single use or reusable, then of all these things, and you have to ensure complete emptying, which is the most important aspect, because if urine is left behind, then recurrent UTIs will occur. Then coming to the surgical treatment part. Then here we have Metrophenol for antegrade catheterizable channel for CIC with augmentation cystoplasty in some cases. Sometimes urinary diversion may be required. Then there are certain neuromodulation techniques like implantation of devices in the sacral area to provide nerve impulse. I don't know if anybody is doing here in India or not, but again, it is mentioned and people have tried this to have a better bladder contraction and sphincter control. Then for lax urinary sphincter, you have sphincter tightening, bladder neck suspension and artificial sphincter. Metrophenol is a very important surgical technique for these children, and it is one of the most frequently used surgeries for these children, and it results in very high compliance and very good continence. It can either be open, laparoscopic or robotic. Then the abdominal stoma can be positioned either in the umbilicus or in the right iliac fossa. Then the tube most commonly used is appendix. If it is not available, then cecal tube, ileal Monti tube, or if appendix is small, then appendix plus cecal flap, and so many other options. Any structure which can be tubularized or which is already a tube and which can be implanted in a continent manner inside the bladder for a catheterizable channel, it can be used, theoretically at least. But all of these have been used. Then as far as augmentation is concerned, there are various options. You can have ileocystoplasty, cecocystoplasty, and so on. And ureterocystoplasty can also be used if we have megaureter with non-functioning kidney, and it results in a urothelium line bladder or augmented bladder, which gives a better long-term results. Then for anti-reflux surgeries, we have got injection therapy, laparoscopic, robotic, and then open. But anti-reflux surgery is usually not required in most of these children unless the child has got very severe reflux and is having persistent recurrent UTI and the chances of upper tract damage. And coming to neurogenic bowel, symptoms by which these children present are chronic constipation, fecal incontinence, and overflow diarrhea. So the management initially is conservative, along with lifestyle measures like high fiber diet with adequate amount of water, then scheduled bowel routine. We can have these children, the parents are advised to take these children at a set time after meal to go for bowel evacuation, and a lot of these children, they learn to evacuate bowel just by changing the lifestyle. Then abdominal massage and positioning, etc. also works. Bowel management, diet regulation, laxatives, enema, bowel management programs, antegrade enemas. If prograde enemas do not work or if they are cumbersome, then antegrade enemas, for that we can have a mace type of a procedure. Then in totally recalcitrant patients, non-compliant patients, we can have permanent diversion. For enema, we have got various protocols. It can be rectal or antegrade. Initially, small enemas can also be tried for evacuation, then total colonic irrigation. Then volume of water, initially we start with small volumes, and it gradually is increased to achieve complete colon emptying and daytime dryness. It can be self-administered or with the help of someone. Frequency is twice a day, or initially, or later on it can be once a day or alternate day after the child grows. Now, a lot of these children will have both bladder and bowel problems. So combined surgical options are required for achieving total continence for bladder and bowel both. So for those children, we can use split appendix for Metrophenol as well as mace procedure, or appendix with Monti tube, or appendix with cecal button, or if ureter is available, then appendix with ureter, or any of the tube like previously mentioned. The complication for Mitrofenov and MACE are significant, but they can be easily managed, and that is a good thing. The long-term survival is after treatment is 75 to 94% up to 18 years of adulthood. Then in resource-limited countries like ours, the survival is around 55%. Incidence and all these in the Indian scenario, incidence as we have already talked about, and long-term survival may reach only up to 30 to 35%. So a multidisciplinary approach, early start to treatment, meticulous follow-up, tailored management protocols, and dedicated team are required for best possible outcomes. So in my personal experience of meningomyelocele patients treated, I have a series of 265 patients, but only 63 were available for regular follow-up. So this is a very major problem. So we do not have all of the children of meningo. In spite of asking them to come repeatedly, they only come when the problems are there. Otherwise, they don't come. So, and even when they have problems, even then they do not report because of so many reasons. So here the role of the social workers and all it comes, and it is very important because those children should be asked to report for regular follow-ups for better outcome. So out of those 63, 50 are controlled on medication alone, then 13 have undergone Mitrofenov, and 4 have undergone MACE plus Mitrofenov, and 4 have undergone augmentation with Mitrofenov. And again, results question mark, because you cannot assess, all of the patients are not available for regular follow-up, so we cannot say exactly what is happening in most of these patients. So out of those who have undergone treatment, 20 to 25% return for regular follow-ups. And out of these patients who are regular, they can achieve a reasonable degree of continence and integration in society with minimal psychological problems. So like this is a patient who had undergone both MACE and Mitrofenov, is on regular follow-up, doing very well. This is a small mucosal prolapse in a Mitrofenov umbilical stoma. Then coming to long-term management, again a regular follow-up schedule is required, and transition to adulthood requires teaching self-management, self-catheterization, then taking care of the body, managing the diet, managing the habits and everything, and for that also social support is required. And the goal is to provide children with the tools to live healthy, active and fulfilling lives, minimizing complications and maximizing independence. So the take-home message is early and proactive management is crucial for preventing long-term complications, and with dedicated team, regular follow-ups, timely interventions, compassionate approach, it is possible to achieve long-term continence free of complications and subsequent social integration of these children in society. This was a laparoscopic Mitrofenov. I think I'll just skip it. Thank you.
Thank you, sir, for an elaborate message. 265 in a private setting is a very huge number, and I am very happy to be a part of few of them while working with you for a brief period of time at Vivekanand. Sir, we were talking about neuromodulation. Actually, pre-tibial neuromodulation we were doing up during my fellowship at SGPGI during Pediatric. They were doing it for PUV patients, long-term follow-up patients, as well as for the spina bifida patients also. And it has a role in both of them. And they had a quite good number and quite good year of follow-up. So maybe we will start sometime at our place.
Yeah, so these institutions have to take the lead, so so that we can follow. Yes. They've got the required infrastructure and the patient load where all these things can be tried.
Sir, it is actually under the process of procurement at the new institute.
Yeah.
So urodynamics and all this biofeedback machines and all these are under the process of procurement. We will start soon enough.
Good, good.
Thank you,
Any questions from the audience? Yes, sir.
Yeah, good comprehensive talk, covered most of the things. Just two quick questions. One, when do you say that you have achieved successful social continence? What is your criteria? How do you define? And when do you say that, oh, I have succeeded in managing this child as far as his continence is concerned? Of course, kidneys, preserving kidneys.
So in these children, if they are free of diapers, so that is during the daytime, and during the night time, if they are not leaking, so I would be happy. So that is the time, and I would say.
So, or would you measure the dry interval?
Dry interval, so initially I don't know, we can achieve a dry interval of a couple of hours, but ideally it should be more. So, and especially in school-going children, it should be at least 3-4 hours of dry interval. Only then we can.
Absolutely. So I think the criteria should be the dry interval, and in the West, they are happy with a 1.5-2 hour dry interval, which I feel is not enough. I mean, a 3 to 4 hour dry interval is what you should try to achieve, and then you could probably say it's a successfully managed continence case.
Yes.
And because they are happy with 1.5-2 hours, they say surgery is not required. We can just do with early intervention, CIC, anticholinergics. But only CIC and anticholinergics will not give a dry interval of more than 2 hours. So I have debated this in the West, and so that's one question. Secondly, you have a good large number, excellent, but you have not mentioned any bladder neck tightening procedures.
Yeah, I have done.
Ashutosh, can you take the mic, please?
Yeah. Bladder neck tightening I have done in 3 patients only.
Yeah. Because apart from increasing the capacity of the reservoir, you also need to make an effort to tighten the tap, which is leaking.
Yes, exactly.
So if you just increase the reservoir, but don't always bladder neck may not succeed.
Yes.
But it's usually good to combine both.
Yeah, but I am really scared about closing the bladder neck totally, because sometimes if you have augmented the bladder and they do not empty properly, or if they fail to catheterize in a timely manner, you can have disastrous problems.
Actually, no. I mean, the method that we are now using is anterior rectus fascia slings.
Yes, yeah.
A nice 360-degree wrap, and they don't close the bladder.
Yes, exactly. I have also used the same thing. Yeah, I have also used the same thing. Yeah. Yes, sir.
Thank you.
Thank you, sir. Thank you so much.
Sir, you mentioned about the dry period, and typically, as you rightly mentioned, it's not more than 2 hours. You give anticholinergics, you tell the patient to do CIC, and you don't achieve, dryness for more than 2 hours. So what do you do for that?
So that's why I feel that surgery in this cohort of spina bifida neurogenic bladder is a much underperformed thing, and you will not achieve more than 2 hours just with CIC and anticholinergics in more than 15 to 20% patients. If you have to get 3 hours, 4 hours, then you would have to do these augments, bladder neck tightening in maybe 60-70% of the cases with neurogenic bladder, which abroad they don't do, maybe because they're not trained.
No, that is not the reason. Bowel is not a good substitute, actually. The problem is long-term complications. See, if you do it in a child, the child is going to live with a bowel in the bladder for maybe 40 years, 30 years.
Right.
So the complications are there. The problem is the complications, not the surgery. Surgery is not technically difficult.
I have follow-up of children who have got these surgeries done at the age of 5, 6, 7, and they are now above 30 years and no issues at all. And this malignancy hype, I think also is overhyped. Till date, I have not seen, we have not done biopsies in every case yet. We may do, but we have a good follow-up of cases, more than maybe 200, who are now into their adulthood and who had a mace and mitrophenol when they're less than 10 years of age.
So,
I think and with no ruptures, no leaks, I mean, surprising.
so the problem, excuse me, the problem is not malignancy or anything in the long run. The problem is more of mucus production when we add bowel. And metabolic also, but mucus is very difficult to manage.
Sorry to disagree, but these are complications in books. Okay, in books.
Yes.
I have had some problems of stones.
Yes.
Because they have not given too much washout, probably well, or neglected washouts. Mucus remains, but you can wash it out. So they have had stones, maybe in a cohort of 150 cases, about 3 to 4 stones. But no metabolic disturbances, no electrolyte disturbances. And I'm talking of children who have their own children now. Okay. No metabolic disturbances. So I mean, I can't wait till they become grandchildren, grandfathers, unfortunately.
Sir, one question, one suggestion. This Mira background, no sir, not for you sir, for everyone. This Mira background, that is the beta-3 agonist, has not been studied in child population. And the safer anticholinergics for these children are oxybutynin and the tolterodine in a half dose. So I think this should be clear. Actually, sir has mentioned all the anticholinergics. These are only 2 which are safe in children. Any questions?
Thank you. Thank you.
Thank you.
I would like to thank our speakers for their wonderful talk. I would like to request our chairpersons, Professor Apul Goyal, Professor Manoj Kumar, and Dr. Gaurav Chandelier to felicitate our speakers. Dr. Ashutosh Pandey, sir. Professor Tanveer Roshan Khan. I would like to call upon the stage Professor Nitin Pant to felicitate our chairpersons for the session. Professor Apul Goyal. Professor Manoj Kumar. Dr. Gaurav Chandelier. Now I would like to request the chairpersons for the next 2 speakers to come up on the stage. Dr. Saurabh Srivastav, Colonel Naveen Chandra, sir, Dr. Rohit Kapoor, Our next speaker is Professor Basant Kumar. Sir will be talking about a very important topic, that is parents' concerns and difficulties in neural tube defects. Sir is professor and head of the Department of Pediatric Surgery at SGPGI, Lucknow. He has authored numerous chapters in books and he has over 100 articles in national and international journals to his name.
Thank you. Thank you, Chairperson. Before I start, I want to promise you I will finish early. Very thankful to Rawat sir, J.D. Rawat sir. Thank you for considering me as a alumni of this prestigious department of KGMU. Today my talk is parents and guardian concerns and difficulties in neural tube defect. Its emotional, medical, social and financial perspectives. I think in guest lecture, Professor Karmakar and Dr. Sneha already told what I am going to tell you. I don't know what I am going to teach new in this lecture. So coming to this slide, I am at SGPGI and there is Department of Maternal Health here. They routinely send us patients for antenatal counseling. I think every person nowadays receiving in his OPDs. So this is the case scenario. Suppose, yeah, and this is true case scenario. I have faced it. 36 year, there was 2 miscarriages. She got pregnancy after 14 years. In between 2 miscarriages is there. At 18th week of ultrasound, child was detected to have lumbosacral meningomyelocele, big meningomyelocele, and gynecologist counseled her and sent to us to take opinion for possible termination. But mother is so desperate to continue this surgery. Other case is 30-year-old, well literate, I think teacher, she was teacher, primary gravida, 20th weeker, only complaint in ultrasound is club foot. But there was no any evidence of meningomyelocele and she was asking for MTP, actively asking for MTP. And third case, as usual, a child with operated case of lumbosacral meningomyelocele with club fit, bladder bowel involvement, hydrocephalus, multiple problems are there. So what you think? What are the probable questions they will ask? They may ask same question or not. Level of stress will be the same or not. Ritual, religious belief and personal values has any role in counseling? Does parental education matters? Yeah, definitely. And does parental financial and social status matter? Yes. And there are lot of questions. I'm not going to discuss in detail, but neural tube defect is a severe birth defect of central nervous system during embryogenesis and devastating brain defect leading to fetal wastage, infant mortality and lifelong disability. Important in this slide is that there is risk of second child with neural tube defect is approaching up to 1 to 3%. What Dr. Sunita and Professor Santosh was saying. So antenatal diagnosis is most detected antenatally by ultrasound and serum alpha fetoprotein. Counseling is very critical. It usually detected mid-trimester. Early and accurate diagnosis is very essential for counseling, and it allows consideration of fetal surgeries and decision of continuation or termination of pregnancy. Fetal surgery, as we all know in mom's trial, it was says fetal surgery did not show the late complications, but definitely if you operate intrauterine level, chances of hydrocephalus is reduces. So decision time add emotional and pressure over the mothers. So goal of antenatal counsel to provide clear, accurate and unbiased medical information, support maternal emotional well-being with empathy, outline possible options or continuation, termination or intervention. But during counsel, it should be options only. It should not be choice. You cannot tell choice is this one. You have to give options. And respect is prime important. Respect culture, religion, personal values, family's values, all these things. The role of healthcare provider is to communicate empathetically, provide written and visual educational material, offer genetic counseling and psychosocial support, and introduce perinatal palliative care team by himself or herself if prognosis is very poor. So there is challenge in parental decision for making final decision, because termination or continuation is very agonizing decision. Uncertainty about severity complicates the decision. Nobody can tell what will happen in future if child has lumbosacral meningomyelocele. And there is also constraint of time, that is limited time due to gestational restriction is another one. It pushes parents to take decision early, and also the conflicting or inadequate medical advice added extra stress. So continuation versus termination is influenced by cultural, religious and legal factors. Prenatal surgery for spina bifida offers hope but carries risk. It so sensitive, non-directive counseling is very important. Mother is the prime victim, not only by this disease, by family, by husband, by society. She feels shock, and initially she has denial. She didn't accept his baby is deformed, and grief. No doubt there is grief. There is she blame, persistent guilt and self-blame, as Sneha has told. High risk, there is fear of child survival. मेरा बच्चा बचेगा कि नहीं बचेगा, एंड क्वालिटी ऑफ लाइफ. बचेगा तो कैसा रहेगा, चल सकता है, बैठ सकता है, नहीं क्या करेगा. And other is, and these high risk of antenatal anxiety creates antenatal anxiety and depression. So not only mother emotional problem, there is physical and social issues. That physical stress is that ki mother feel ki he is carrying a abnormal child in her womb. Frequently there will be frequently hospital visit and interventions, possible cesarean delivery. Every person is not ready for surgery to deliver a child. So possible cesarean delivery for fetal protection. There is lot of social stigma, blame and isolation because of discrimination. It is quite common in our society. So not only mother, father is the second person who suffered, not emotionally, but financial stress is more. Extended family may have extra pressurize parents to take decision early. Sometimes there is conflict in marital status, some get divorced. Also there is challenge of siblings. If mother has other siblings, they feel neglected, and overall family dynamics influences the maternal coping about the situation. So emotional and psychosocial impact includes shock and grief similar to bereavement. They feel like someone died in family. There is recurring chronic sorrow at missed milestone. When child didn't smile, don't make eye contact, don't sit, they feel grief and sorry. Guilt and self-blame, especially among mothers, high rate of depression and anxiety in parent and of affected child. So medical challenges, I think everyone already knows. Immediately hospitalization, it was in large structure intervention, surgery often required. Hydrocephalus and search surgery was quite common. Later bowel and bladder incompetence create problems. Bony deformity, limb paralysis that needs daily demand of catheterization, therapy, braces, monitoring, etc., etc. And it consumes time, finances, loss of job, isolation, frustration, agony, mental trauma. Apart from that, there is social and cultural challenges, stigma, superstition and blame in many societies, isolation due to discrimination. Sibling may feel neglected, though often resilient. Community education is prime important to release these stigmas. There is a lot of financial or logistic burden, as there is no Indian data. Even if this is from Western country, I think it is US data, $250,000. High income medical cost, lost parental income due to caregiving duties. They left out their jobs, especially females. And there is a lot of hidden cost like transport, cost per transport, adaptive equipment, home modification, medication, all these things. And it's a greater barrier in low resource setting, just like us. And there is a lot of communication gap and counseling gap. Diagnosis sometimes delivered in rushed. Child in India especially, there is less doctors. They don't have time to explain each and every aspect of their during the counseling. And also problem with technical language. A person from south cannot explain the whole things. A person who is living at Uttar Pradesh. Outdated or inadequate written information is another problem. Parents often seek answer online. These are educated person's problem when they are leading anxiety by seeing Google's, looking the, see there are need of psychosocial referral and peer support group, and definitely lack of supports in our settings. The role of healthcare system and support, definitely multidisciplinary spina bifida clinics is required, as already told in previous lectures. Parent training boosts confidence and child outcome. Psycho-social services like counseling, support group, respite group, they are required. And in public health, at PSC and CSC level, folic acid supplementation is required to reduce the incidence of neural tube defects. I could not find much literature about on this topic. This is a recent review article from Egypt, published in 2025, same year. And they have some instructional guideline, what Professor Karmakar was saying. If we follow the instructional guidelines, some guideline at our center, satisfaction before surgery and after surgery will be better. And this is the probably last slide of my presentation. That is this data from MOMS trial. MOMS trial has taken family impact on treatment, overall family impact on treatment, and there is stress level of parents' stress. And he found that either they were treated before birth, antenatally treatment, and after treatment only significance value, p-value found is family and social impact. That was, I don't think I can show here. Can I see? It is quite busy slide. I don't think I can. So you can see my, yeah, yes. This is the only family and social impact is clinically significant if you operate antenatally, while parental stress, there is no significant difference. You operate antenatally or not. So in conclusion, in neural tube defect, parents faces emotional trauma, financial hardship, and caregiving strain. Antenatal diagnosis offers option but poses dilemma. A healthcare system must provide empathetic counseling and integrated support. With comprehensive care, family can find resilience and children can thrive. Thank you.
Thank you, Vasant. You completed the topic. I have one submission. I am from armed forces. My whole of the population dependent on me is fully covered for healthcare, for rehabilitation, everything. Even then, when some parents kid is suffering from the disease, which they need to come everyday hospital. They need to come everyday hospital. They are deprived. They deprived from the work. Even they are fully financially supported by the armed forces. They every day, alternate day, they are coming from for the treatment, sequel or complication of the disease or physiotherapy. They lose the opportunity to interact with the peer group. They avoid meeting peoples, and even the unit system where they're working, they feel that this fellow is useless for the unit. He's not contributing in the unit function, unit day-to-day life, unit day-to-day work. So his promotions are suffered. The whole family is so stressed. They even full support by the hospital, full support by the unit. They don't want next child. If the first child is suffering, they don't want next child. So when we counsel about the disease, we should sense what the actually parent want, and we should counsel about the child disease at the age of birth, at the age of 5 years, and when the child goes to adolescent, when the child is gaining weight of 80 kg, and the parents are about 60 years of age, it's very difficult to carry this kid 80 kg, and the parents become disabled at the age of 60. It's very difficult in India. We are not fully supported by the healthcare system. So
Yes.
while we are counseling the patient, we should also understand the problem of our country, our healthcare system, and the parents' attitude towards the children. If the very precious child, yes, we have to support everything. But if they say what happened to this, what happened to that, then we have to tell the real story. What is happening in India? What will happen after 20 years when the child gain weight? Because inactive child will gain weight like anything. He will be 80, 85, or sometimes they are 100 kgs.
Yes, boss. Yeah, I want to share two experience. One is my one teacher was used to say, if I told them ki sir there is a large lumbosacral meningomyelocele ruptured, he has bowel bladder involvement, there is no limb movement, what need to do? So he was used to say, take a bucket and put water in it and put the child there. So at that time, but as Karmakar sir, when he was asking, most of the surgeon they raise hand to operate the child with give a better survival. Other question was asked during interview, my promotional interview, that was they have asked it is only 50,000 or 1 lakh incidence per year meningomyelocele in India, I think. Western country 1,50,000. And if 1,50,000 person in India is there and more than 100 crore person in India, what harm if every child of MMC don't treat him and terminate it? I have no answer at that time. And then they again further extend that question. Only 2% or 3% is major congenital defect in pediatric patient. So, and so much population, so let them die. Why pediatric surgeons are here in the country? So these are my, but every person need to live, as Karmakar sir told, and we must operate if we can give a little bit hope to parent.
Thank you for the excellent and crisp talk, sir. And the diagnosis of neural tube defect antenatally or postnatally is obviously devastating for any parent. Being a parent myself, I can understand, and you told the aspects that a parent feels and how to deal with it very nicely in your talk. And also, we all study there are 7 stages of grief. The first stage is denial. The parents are often in denial. They will ask you questions, and I have seen you having the opportunity to work under you. I have seen how you deal with that phase very patiently. So that is very important, I think, for all the our senior residents and our PGs also to deal with that phase. They will ask you questions that have no real answers. They will ask you whether my child will be all right or not. This is the most common question that you get. And you have to answer patiently and keep them to the ground. You don't give them false hope. At the same time, don't take away all the hope from them. Otherwise, they will simply stop coming to you. That's the message I want to convey. Thank you, sir. Any questions from the audience?
Thank you.
Thank you, sir. Thank you, sir.
Thank you, sir, for sharing your knowledge and insight with us. Now I would like to call our next speaker, Dr. Sunita Singh, who will be talking about a very important topic, birth to parenthood, managing spina bifida, ensuring transition, and preventing recurrence. Ma'am is currently head and professor in the Department of Pediatric Surgery at AIIMS Raebareli.
So since morning a lot has been discussed, and I will skip few slides because these slides are discussed already in detail. And from where the 2 pointer? नेक्स्ट बटन इसमें कौन सा है? नेक्स्ट बटन this is the one. Next slide. Okay. So my motto is to sensitize you all about the spina bifida management from birth to parenthood, ensuring smooth transition. So we all know that survival of spina bifida has increased, and so our focus nowadays is shifted to the improving the quality of life, independence, autonomy, and social participation. So first question comes in our mind, how is the intellectual development after VP for hydrocephalus, especially in the adolescent and adult age group? So sir has clearly discussed that these patients have actually the normal IQ. They should not be treated as a special child. They should have the right to study in a normal school. Few points here I want to discuss for the PGs, that did the surgical factors affect the IQ? So in the various studies, the summary is that if we treat the sequentially, that is hydrocephalus followed by meningomyelocele repair, their IQ is more compared to those patients operated in the single stage. And surprisingly, those patients who need multiple revisions of surgeries, it is a false belief that their IQ is low, but it has been shown the fall in IQ is only 3 points on long term of follow-up. And this multiple revisions actually increases their non-verbal communication skills and performance skill after revision surgery. So this is again not a factor to decide the IQ. If there is an infection and if the hydrocephalus is associated with the MMC, then these factors decreases the IQ. Prenatal repair definitely increases the IQ of the baby, and in the long-term studies, the IQ of this patient in the adult is 100. So single Swedish study is that follow patient up to the 35 years of age. They found the IQ is comparable to the general population. Second is the continence outcome. As we know that continence is key to determine the independence and the quality of life in this patient. So the continence achieved with our best measures can reach up to 80% by the conservative measures, and then they are affording best available surgeries. So this again is not a hindrance in the management further. The main concern is the risk for CKD, and this CKD development is also depend on the status of various factors, like caudal regression syndromes may have a single kidney that adds to the CKD. Then if there is VUR or the neurogenic bladder, then there is chances of CKD development. As a surgeon, we usually aim to achieve the dry interval of more than 4 hours that discussed shortly before. But for the transition care, our main management aim is to prevention of the CKD on the long-term basis. So the lot of surgical options are available to decrease the bladder pressure and do the diversion. And still, a study published in 2011 shows that the incidence of CKD in the patients of having spina bifida is increasing. And they proposed in their paper in 2011 that this reason is actually the shifting the focus of surgeons from the bladder augmentation to the drug therapy, means that is one anticholinergics start from lower dose, go to the maximum dose, can give 2 anticholinergics, can give intravesical anticholinergics, dash. So most of the surgeons in the foreign still now saying that there is almost no need for bladder augmentation. And this topic will be discussed in the this transitional care chapter in the SPU con also. So it is the spina bifida that is causing the CKD or the delay in the surgical management or avoidance of surgery? No, there are a lot of factors, because now there is a well-defined criteria to define the how end-stage renal diseases. There is defined calculation formula for the determination of GFR and the patient awareness also. So more of these people are coming to the clinics for their follow-up, so the incidence is increasing. And a lot of factors like a neurogenic bladder, then associated infection in the hydrocephalus shunt infection, or the infection in the bed source, that increases the indirectly affect the infection in the kidney, that affects the outcome of kidney. Then sedentary lifestyle, limited mobility, obesity, metabolic syndrome, hypertension, insulin resistance accelerate the CKD progression. Recurrent UTI, that is also the cause of resistant organisms to emerge in this patient, is a cause of difficult to treat UTI in these patients. And then the psychosocial factor, that is non-adherence to the catheterization, is a reason for the increasing incidence of CKD. So we need the lifelong surveillance for the hypertension, renal function and stoma integrity in this patient to prevent the renal replacement therapy, means surgeries, in this patient in future. The reproductive outcome in this patient, like a potency, fertility, conception, delivery and marriage. So these patients are actually the main problem is the erectile dysfunction, that is a major barrier. Otherwise there is no role for hypogonadism or erectile or the paternity related issue like a sperm production or low sperm count. This is not an issue. The female conceives, and this female, however, has the increased risk of maternal complication, infant complication, and there is a higher chances of cesarean delivery in this patient. And anesthetist should be aware regarding the features of T-third cord during anesthesia. But despite of this, a UK cohort shows that only 15% of these patients went for the marriage, and then there is a majority prefer to live single only. And there is also a sex gap. The women married compared to the males. These patients need genetic counseling regarding the risk of recurrence and the counseling for the folic acid. So we know the folic acid prevents the spina bifida defect, but the National Birth Defect Prevention Network that operate all over the world now come with clear message that the studies proven, systemic review, meta-analysis, all proven that there are definitely 6 benefits. So our criteria for sensitization and awareness should be modified, that they decreases definitely the blood pressure during the pregnancy in the mother, and they decreases the risk of preterm birth in the baby. Spontaneous conception rate is higher. Recurrent abortion or the spontaneous miscarriages rate decreases drastically. And not only the spina bifida, structural heart defect and the cleft lip and palate is also shown to be improved with this drug. Further, these drugs improve the mental outcome in the offsprings, and they increases the cognitive function of these babies. Those who consumed folic acid in the pre-conception period and the conception, during the conception. Then these patients must underwent for health literacy, that is the main focus for the TOC, that is they must know the drug name, dose, timing, oxybutynin, anti-epileptics, what are their side effects like constipation, drowsiness, nausea, vomiting. They should set alarm like madam set in her mobile for some pills, that not to forget the drugs, because the non-compliance is the main reason for the long-term outcome. Then pill organizers, and they should be motivated in the transition phase to do the appointment independently by themselves. They should know the signs of shunt infection, shunt malfunction, the signs of recurrent UTI, the fever that is not unexplained, that they should know the pressure source and how to care themselves. and then some symptoms related to the tethering of the cord, that is worsening of the neurological symptoms. So disability management and vocational planning is further done for these patients, as these patients actually have worsening of whatever disability they have during the puberty. When they have the growth of the spine, they develop the scoliosis, hip dislocations, and the contracture, and the long-term obesity, fatigue, or arthritis, osteoporosis, hypertension, spontaneous fracture, etc. So the patient should be self-directed for the self-care. This is the main role for the of the transitional care. And recently, this story in 2000 for the NEET 2025, there is a story about the girl Mahi, who has actually 90% disability according to the medical board, and NEET allow only 70% disability to be appear for the examination, and she filed the petition in the court, and then the court allowed her to appear in the NEET examination. So there are a lot of enthusiasm and the desire to be independent in these patients, and we should take care of it. There is need for vocational relevance centers, and there is very much requirement of the CMEs like this. Those are sensitizing about this. A lot of population, not only the medical fraternity, but the outsider in the media, sir has done a lot of coverage that make aware that these diseases can be treatable, and the facility is available at this center. Then the government is also doing their role by giving the RPWD Act. They give the reservation of 4% in the government jobs and 5% in the higher education. They have equal right in education, employment, healthcare, and public services. And there is mandatory barrier-free access in the public building transport according to government rule for these patients. Then UDID cards are available. These cards give them access to benefits related to the disability. Then financial support under state social welfare schemes are running. Then scholarships, travel concession, income tax deduction, and under 80U and 80DD is also there. And ADIP scheme is there that give the free cost of for the appliances. So despite of all these measures by the healthcare facilities and the government, there are still challenges because the adolescent face identity and the and self-esteem issue, and we need the support of the peer group for building to reduce isolation and building resilience in these patients. So the transitional healthcare can give a significant role in this area, because this TOC concept is actually well followed in the Western countries. In the UK and Europe, they are following this TOC clinic. These are the special clinics where both the adult and pediatric surgeons used to sit together for once in a week. They have to sit for the gradual transition of the patient, not only the patient related document, but make the patient also comfortable that he is transferred in a safe and in a proper way, and he is not apprehensive that the person who is treating me since the birth has left me in between. So it is again a multidisciplinary clinic that used to do holistic management, and there is a smooth handover between the services. It started from the 12 to 14 years of age, where there is a gradual preparation rather than a sudden transfer of to the adult care team with a proper psychological preparedness. A lot of clinician, physiotherapists, psychologists, psychiatrists, social rehabilitation center, vocational support coordinators are working together to empower patient and family with education and the skill. And this diagram actually I framed from the ChatGPT regarding the multidisciplinary management of spina bifida, but I saw that the pediatric surgeons are missing in this diagram. So I added them, and this CME is actually very much sensitizing that this the pediatric surgeon are the best who can deal with the neurological as well as bladder and bowel function dysfunction together as at a one point of care. Otherwise, the neurosurgeon sometimes operate and send to the urology clinic, and then urologist or patient used to tick tock, and then sometimes lost the hope, and there is a lost of follow-up, or the patient is non-compliant with the disease. So this type of CME must be organized by all the pediatric surgeons, and the reason I found that might be the ChatGPT is that the publication from the pediatric surgeon sites are lacking. I think this is the only reason that he is not able to analyze. So we must focus for the research and publication on this topic from our side also. So there is a gradual transition occurs in the patient with the surveillance for retethering of the cord, scoliosis, bladder dysfunction, bladder bowel dysfunction, then mobility, related aids. All these has been discussed in the previous slides, so I am just skipping that. The importance is that these all are given in a smooth transition way. A checklist is there where the patient is assessed whether he is able to manage himself or not. So he is able to manage the medication, he is able to manage appointment by himself or not, he is able to track the healthcare issue related for himself or not. So if he accordingly he was asked many times, and then when he reached the state, yes, I always do this, and when I need to, that is the last column, then this patient is ready for the transition for the next clinic.
Professor Sunita, please.
Yes, this is the last slide. So this is a well-planned sheets, and these sheets has to be managed by the primary treating physician, and that incorporates all the aspect, means their education aspect, their bowel management program, their personal health related issue, their self dependency, like they are able to cook themselves or not, or they are able to learn medications, and then we set the goals like current status, what is the patient has and what action we can do for these patients, and then the target. So these sheets has to be made, and slowly the target should be achieved. Recently, the telemedicine, technology-based education and virtual video conferencing has helped a lot in this patient for the transition of care if they have the issue with the transportation or the financial constraints. So to conclude, transition requires structure, holistic care focused on independence, dignity and lifelong support on a large scale multidisciplinary clinic. Thank you.
Thank you, Professor Sunita. Very well, topic is very well covered. Topic is open for discussion. Short clips, 1 or 2 questions, please. If there is no question, thank you very much.
Thank you so much.
Thank you, ma'am. That was quite an insightful lecture. Now I would like to call upon ma'am, Dr. Sunita ma'am, and ask our chairpersons to felicitate ma'am for the lecture. I'll also would like to invite Professor Basant sir. I would like to invite Professor Sudhir sir to kindly felicitate our chairpersons for the event. Saurabh. Dr. Saurabh Srivastav, sir. And Dr. Rohit Kapoor, sir. Thank you, sir. Now we will start our paper presentation for this evening. I would like to invite Dr. Digambar Chaube, sir, Dr. Sarvesh Kumar, sir, and Dr. Akhilesh Kumar, sir, to please chair the event and give scores to the paper presentations. The presenters will have 5 minutes time to present. The first presentation will be by Dr. Kriti Patel, sir.
A very good evening to all delegates and chairperson and my faculties and seniors. Challenges in management of giant occipital encephalocele. The encephalocele condition characterized by the protrusion of intracranial content through the bony defect of the skull. The incidence of encephalocele is 1 per 5,000 live birth. The common presentation of encephalocele is a occipital encephalocele. The size of encephalocele may vary from large to small sizes. The giant occipital encephalocele term used when the size of the occipital encephalocele is equal or greater than the size of the head. This series comprises patients of the giant occipital encephaloceles managed at our center over time. Emphasis on practical problem faces in the management of giant occipital encephalocele were assessed. This is the clinical picture of giant occipital encephalocele, where the size of encephalocele much more larger than compared to head. Material method, it is a retrospective study. All patients of giant occipital encephalocele were included in the study. This study period is 10 years. Sample size is 30%. Male to female ratio is 6:5. Age of the patient less than 1 year of age. The patient were evaluated for the age of the presentation, sex and head size. The requirement of ventricular peritoneal shunt was also assessed. Any associated neural tube defect are also looked for. Radiological examination allowed like CT scan, MRI or both for associated brain anomalies and to plan the surgical procedure. After evaluation, careful intubation was done in hanging or lateral position. Patient underwent excision of the encephalocele. The operative procedure include dissection of the pedicle, careful drainage of the CSF, excision of glytic brain tissue and closure of the defect. Care was taken for hypothermia, blood loss, CSF loss or vital monitors. On follow-up at 1 month interval of first 6 months, early if there was evidence of any problem by the attendants and telephonic conversation in case of defaulters. 26 patients underwent for surgery, excision and repair of giant occipital encephalocele was performed in 18 patients. On these 18 patients, 10 patients underwent VP shunt placement after excision due to RAGE ICT. VP shunt was placed as initially surgery 8 patients, where was followed by the excision and repair after 2 months. The content of the sac was only CSF in 15 patients, CSF with glytic brain tissues in 11 patients. The attendant of 4 patients did not give consent for surgery and leaving medical advice. On outcome, 14 patients was uneventful. On post-operative ventilator support needed in 8 patients, expired 4 patients. On long-term follow-up, normal life is in 8 patients, mental retardation with delayed milestone in 12 patients, expired 2 patients. This is a clinical picture of giant occipital encephalocele with presented pressure sore over the encephalocele. This is the microcephaly with giant occipital with leaking CSF. This is CT scan of brain showing the bony defect of a skull. On CT or MRI, associated on long-term finding, cherry malformation type 2, corpus callosum agenesis, cyanotic heart disease in 8 patients. On long-term follow-up, expired after 4 to 6 months due to pneumonitis. Microcephaly and hydrocephalus in 2 patients. Among 2 patients, expired within 30 days due to pneumonitis and meningitis. Cherry malformation type 2, corpus callosum agenesis in 12 patients. That patient in long-term follow-up mostly delayed milestone with mental retardation. Hydrocephalus with skin necrosis in 5 patients. On long-term follow-up, they're doing well. Management algorithm of the giant occipital encephalocele. Non-communicating or communicating. If non-communicating, do for CT or MRI. On MRI, if there is severe hydrocephalus, moderate hydrocephalus or mild. If in case of severe hydrocephalus, first do VP shunt, followed by excision and repair. In case of mild or moderate hydrocephalus, first do excision and repair of encephalocele, followed by, if need, to do ventricular peritoneal shunt. Take home message. The prenatal diagnosis is important for proper perinatal care, especially during labor. In developing countries, any deformity that can be externally poses a social stigma for family member. Careful transportation is needed for these patients. Care during positioning and intubation. In giant occipital encephalocele patient, there is 2 positions needed, lateral position or hanging position. Early surgery is very important to prevent the complication and improve outcome. Careful selection and involvement by the team of expert doctor, including the anesthetist, pediatrician, and surgeon. Giant occipital encephalocele is an uncommon entity with limited information about management. Careful evaluation, proper imaging of the patient, care during the intraoperative and postoperative period emphasis factor determining the prognosis may provide satisfactory result. Thank you.
Thank you, Dr. Kirti. So what was your pre-operative challenges in these patients?
Intubation is very difficult in this type of patient. We will not do supine position normally. So in this type of patient, we do lateral or hanging. Difficulty doing intubation by anesthetist.
Difficult intubation.
Intubation. Yes,
anesthetist should be acquainted with
lateral or hanging positions.
Okay. Thank you.
Okay, thanks, sir.
About the post-operative surgical wound dehiscence, was there any wound infection or surgical site dehiscence or any blockage of VP shunt?
Yes, sir. In some patient was blockage of shunt was there,
You
but
not mentioned in this.
sir, in our study, not that type of patient was presented with blockage of
That
shunt.
was not the part of your study, the data.
Yes, sir. Yes, sir.
But that is the important thing.
Okay, sir.
Do you operate in every giant encephalocele or you decide on the basis of glial tissue also as a component in the encephalocele?
Yes, sir.
You get the point?
Is
On basis of a glial tissue component,
Yes,
you
sir.
decide to operate or not to operate?
No, sir. On the basis of herniation of content, no any determination.
Thank you, Dr.
Thank you, sir.
Thank you, sir. Now I would like to invite Dr. Manish Malik, SR in Department of Pediatric Surgery, SGPGI. RML Lucknow.
A very good evening to respected chairperson and faculties and my fellow colleagues. I'm Dr. Manish Malik, MCH resident in Department of Pediatric Surgery in RML Hospital. So the topic of my paper presentation is implementing RBSK to manage neural tube defects in the underserved population. As we have already discussed about the neural tube defects, I would like to discuss about the Rashtriya Bal Swasthya Karyakram, that is the main pillar of our study. Now, it's a national health program launched by the government of India under the National Health Mission, launched in February 2013. It includes provision of child health screening and intervention services through early detection and management of 4 Ds: the defects at birth, diseases, deficiencies, developmental delays, and disabilities. The program implementation includes the newborn screening at the public health facilities, community-based screening at home through ASHAs for newborn till 6 weeks of age during the home visits. From 6 weeks to 6 years, Anganwadi center-based screening by dedicated mobile health teams, and for children from 6 years to 18 years, government-aided school-based screening. The first level of screening is done at all delivery points through the existing medical officers, staff, and the A&M. Once the child is screened and referred from these points of identification, they're sent to the tertiary care center for treatment or intervention. Treatment is delivered free of cost. The admission could be emergency or elective planned admission. Nursing assessment is conducted to evaluate the patient's condition. A thorough medical history and physical examination is done. Treatment plan is developed. Surgical intervention to improve the outcome or manage the complication is done. Nursing care is provided during the post-operative period, and the discharge planning is done with the follow-up care and the rehabilitation. The aim of my study is to identify and facilitate early treatment of children with neural tube defects in the underserved population through RBSK. Objectives include to screen and identify neural tube defect cases using RBSK protocols, to ensure timely surgical intervention for diagnosed cases, to evaluate post-operative outcomes and complication, and to assess the efficacy of RBSK in improving the access to care. It is a prospective interventional study carried for a duration of 30 months in RML Hospital, Lucknow, including children aged from 1 month to 20 years, admitted and operated for neural tube defects. A total of 370 patients were operated, which included 100 cases of hydrocephalus, 54 cases of meningomyelocele with hydrocephalus, and 216 patients of meningomyelocele alone. Mean age of 8 months, and the gender distribution, 55% were male and 45% were female. 70% of the patients were admitted through RBSK screening, and 30% patients were admitted through direct admission. Mean time to surgery was 15 days, mean hospital stay of 12 days, and the mean follow-up of 6 months. Total of 424 procedures across 370 patients. The ventriculoperitoneal shunt placement was done in 154 patients, with meningomyelocele repair done in 270 cases. VP shunt was performed using the standard programmable shunt. Multi-layer closure with dural and skin reconstruction was done for MMC repair, with the mean surgical duration of 1 hour, and all the patients were operated under general anesthesia. The complications were VP shunt malformation, VP shunt malfunction, which included migration, infection, protrusion, and blockages. Also, the complications also include the post-operative leaks, followed by the MMC repair, wound infections, and meningitis noted in 2 patients. This is the case. This is the post-operative case with the wound dehiscence, and another case with the oral protrusion of the VP shunt. And on the other side is the gross hydrocephalus, which was treated, and this is the post-operative picture after the VP shunt. The key observations made during the study are the complication rates in the VP shunt procedure are higher as compared to the MMC repair. RBSK referral reduced the mean time to surgery by 20% compared to the direct admission. Male patients had a slightly higher incidence of complication. 70% of the cases identified through RBSK screening, demonstrating its effectiveness in the underserved areas. All cases received timely intervention, but complications indicate the area for improvement. The challenges faced during the study were high shunt malfunction rates, suggest the need for better shunt technology, and the department is heading towards the ETV to reduce complications. Post-operative infection and leaks highlight the importance of sterile techniques and wound care. The limitation of our study is single center study, long-term outcome beyond 24 months not assessed. RBSK significantly enhanced early detection and referral in the underserved population. Surgical intervention was successfully performed in all cases with a mean time of surgery of 14 days. Complication underscored the need for advanced shunt design to reduce malfunction, improved post-operative protocols, and enhanced follow-up mechanism. Future direction include multi-center studies, longer follow-up, and integration of advanced imaging for preoperative planning. Recommendations are strengthen RBSK screening with mobile health units for remote areas, develop standardized post-operative protocols to minimize infection and leak, establish a national NTD registry to track outcomes and improve care coordination, and RBSK must include other congenital anomalies in the program. Thank you.
Thank you, Dr. Malik. I think RBSK is not for only particular society. It includes all the patients with congenital anomalies. And the age range it's cover is 0 to 18 years.
Yes, sir.
So you mentioned that you covered 20 years of the age. How did you do that?
So there was a female patient we had operated, and she was 19 years, 19 turning 20. So we operated that patient. She had already.
You operated
yes, sir.
that
So actually, the patient already had the RBSK scheme, but she was neglected for a very long time.
So that's good. So how much duration it takes to enroll a patient of neural tube defect in RBSK? Suppose a one-day unit come with meningomyelocele. You can directly enroll under your hospital in RBSK. You send him to his village or district hospital for the enrollment.
So a lot of patients, they already come from the RBSK, like the screening has been done, and the workup has been done by the ASHA or the Zilla district from wherever they are. So in that cases, we admit the patient. But if the patient comes via the direct admission from our OPD, then there is a procedure and there is a protocol that we follow, and then patients are later admitted under RBSK once they get enrolled in it.
Okay, good number of data. Thank you.
Thank you, sir.
Any questions from the audience? Thank you.
Thank you.
Thank you. Now I would like to request Dr. Akanksha Gupta, Resident, Department of Anesthesiology, KGMU, to present her topic.
स्लाइड चेंज करने के लिए ये है तो मैं घूर नेक्स्ट से बैक से लेजर पॉइंटर
Good evening, respected faculty members, chairperson. Myself, Dr. Akanksha, from Department of Anesthesia, here to present you the topic of ultrasound-guided erector spiny plane block in pediatric patient undergoing meningomyelocele surgery, a prospective randomized controlled study. Meningomyelocele, also known as open spina bifida, is a severe congenital malformation of the central nervous system. As we all know, surgical intervention is frequently necessary to reduce the risk of infection and other complications. Optimal post-operative pain management is crucial for the pediatric patient as it enhances the patient comfort and potentially reduces the risk of post-operative complications. There are multiple analgesic options available for the post-operative pain in the pediatric patients, including opioids, NSAIDs, and acetaminophen. Erector spiny plane block is a regional anesthesia technique that has gained recognition as an effective method for providing post-operative analgesia and variety of the surgical procedures. First, erector spiny plane block has been used by Ferrero et al. In 1960 for chronic neuropathic pain. And my aims and objectives for the study are to evaluate the analgesic effect of ultrasound-guided erector spiny plane block in pediatric patient undergoing meningomyelocele surgery. Primary objective of the study is to assess the quality of the analgesia using the FLAC scale. It is a behavioral scale through which we assess the scores at 0, 1, 2, 4, 6, 12, and 24 hours after extubation. Secondary objectives of the study are to compare the total consumption of the fentanyl intraoperatively, to compare the time to first rescue analgesia, to compare the intraoperative heart rate, systolic blood pressure, diastolic blood pressure, and oxygen saturation, any adverse event during the intraoperative and post-operative period. Inclusion criteria For the study are the pediatric patient of pediatric age group from 2 months to 36 months, pediatric patient which are undergoing elective meningomyelocele surgery. Exclusion criteria are the parents not giving written informed consent, patient having local infection at the puncture site, patient with deranged coagulation profile, patient allergic to the bupivacaine, patient with any neurological deficit and the lower limb weakness. After obtaining the ethical clearance and informed consent, studies includes a total 70 cases in, which are divided into the 2 groups, 35 in each group. Group B includes the patient which received the general anesthesia plus ultrasound guided electrospinal plane block of, and group C include the patient which only received the general anesthesia alone without any regional block. After securing the definitive airway, we apply the erectospinal plane block in prone position after obtaining aseptic condition. The block was administered at the level of the lower thoracic T10 vertebrae. The skin over the target area was first sterilized to prevent infection using a high-frequency linear ultrasound probe in a sagittal or paramedian orientation. The transverse process at T10 level identified. Then a 22 gauge needle was then introduced in an in-plane approach from caudal to cranial or cranial to caudal direction. The needle was advanced until it made contact with the tip of the transverse process. After confirming the negative aspiration, which ensures that needle was not in the blood vessel, a dose of bupivacaine of strength 0.25% at 0.5 ml per kg was injected into the facial plane beneath the erectospinal plane muscle, between the transverse process and the erectospinal plane muscles. This is the ultrasonographic image of block. We instill the drug between the transverse process and the erectospinal plane, erectospinal muscle. On observation and results, we found quality of analgesia according to the FLAC scale, which is better in the group B, which received the block and the general anesthesia, as compared to the group C children. There is also significant improvement in the as a rescue analgesia. We obtain in group C, we require it at 2 hours, while as compared to the group B, we require it at 6 hours to 8 hours. Also, there is intraoperative fentanyl consumption comparison. In group B, there is a intraoperative fentanyl consumption requirement is lower as compared to the group C. Our study provides evidence supporting the effectiveness of the ultrasound erectospinal plane block in managing the post-operative pain in pediatric patients with meningomyelocele surgery. This is demonstrated by the omission of the need for additional fentanyl intraoperatively and the low post-operative FLAC scores over 24-hour period following surgery. As a conclusion, the results of this case study demonstrated that a single shot preoperative erectospinal plane block reduces the consumption of the opioids for the perioperative analgesia in pediatric patient undergoing meningomyelocele surgery via the lower FLAC score. Improved patient outcome with the post-operative pain management. Erectospinal plane block provide hemodynamic stability and prolonged analgesic effects, highlights its potential as a valuable addition to the perioperative management in the complex pediatric surgery in order to prevent any post-operative complications. Thank you.
Thank you, Kansha.
Thank you, sir.
A good surgery requires good anesthesia plane. Okay, my question is, why you excluded neonates from your study?
Sir, actually, patients...
Come closer to the mic, please. You are not talking.
Sir, we have to counsel the patient attendant before giving block, and we have to take consent. So most of the parents does not give consent for the neonatal block. That is why that was for the main reason.
Okay. Any other questions from the audience?
The effect of weekend is around 4 hours, na?
Sir, actually block, it varies according to the patient to patient. Most effective block duration is 6 to 8 hours. in our study, we have noticed that 6 to 8 hours effect is optimal.
You take the score for 24 hours.
Yes, I monitor the patient for 24 hours.
Have you given any clear-cut instructions on the treatment card of the patients so that no analgesia is given?
Before giving
TCM
block,
or
before giving block, I have taken the consent from the parents.
no, you have to say to the residents and the nurses.
Yes, sir. Yes, sir. For the monitoring ke liye, sir.
Oh, nice presentation.
Thank you, sir. Thank you.
Thank you to all our presenters and our chairpersons. I would like to request our chairpersons to present the certificates to our presenters. Dr. Kriti Patel, Dr. Mehnish and Dr. Akanksha, if you could please come up to the stage. Dr. Kriti Patel. Dr. Mehnish Malik. Dr. Akanksha Gupta. I would like to request Dr. Piyush sir and Dr. Rahul sir to come up to the stage and felicitate our chairpersons. Dr. Digambar Chaube. Dr. Sarvesh Kumar Gupta. Dr. Akhilesh Kumar. Thank you, sir. As we are nearing the end of our ceremony, the one thing we have all realized today is that spina bifida needs a multidisciplinary team to treat it. It requires people from numerous departments, including pediatric surgery, neurosurgery, plastic surgery, OBGY, and even physical rehabilitation to help take care of these patients. In a similar manner, a CME such as this cannot be organized without the help of numerous people. So as we come to the valedictory function, we would like to thank all these people, seen and unseen, who made this CME a success. So on behalf of the entire organizing committee, I would like to call the following people and present them with appreciation certificates. Dr. Rawat, sir. Dr. Karmakar, sir, if you could please come up to the stage. We have our senior nursing in charge, Neha Gulati and Sudha Singh on the stage. Ms. Neha Gulati. Sudha Singh. We have the following people to thank for the beautiful rangoli made outside. Shivani Rathore, Arpita Maurya, and Ragini Sahu. We had 3 BSc nursing students today who performed a beautiful Saraswati Vandana. Miss Anugya, Miss Babli Das, and Miss Monica. From the organizing team members, we would like to call Dr. Vivek Kumar, Dr. Shivesh Anand, Dr. Megha Yadav. Dr. Amol Agarwal, Dr. Geetika Malhotra,
Dr. Kritika Singh, Dr. Kriti Patel, Dr. Manish Rajput, Dr. Preeti Kumari ma'am, Dr. Shobha ma'am, Dr. Rahul Rai sir,
Dr. Piyush Kumar, Dr. Gurmeet Singh, Professor Nitin Pant, Professor Sudhir Singh, Professor Anand Pandey, Professor Archika Gupta, Professor J.D. Rawat, the backbone of this entire CME. It would not have been possible without your guidance, sir. So we would also like to request you to award the prize certificates for the paper presentation. First prize goes to Dr. Kriti Patel. Second prize goes to Dr. Mehnish Malik. Third prize goes to Dr. Akanksha Gupta. Congratulations to all the winners. I would like to request the entire organizing team to come up to the stage for a group photograph. Can everyone please come up for the group photograph? Can everyone please come up to the stage?
मैं तो लंबा हूँ, मैं तो कहीं भी खड़ा हो जाऊँ। आइए चलिए।
आज का तो जो शाम का प्रोग्राम था यहीं ख़त्म होता है, लेकिन मैं कुछ कहना चाहूँगा कि ये जो प्रोग्राम सफल हुआ है इसके लिए मैं विभाग के सभी कंसल्टेंट, रेजिडेंट, एम्प्लॉई, नर्सिंग स्टाफ को तहे दिल से शुक्रिया करता हूँ, क्योंकि इन लोगों के सहयोग से ये काम हो पाया है। और मैं कुछ स्पेशल नाम दूंगा जिन्होंने काफ़ी मेहनत किया है। डॉक्टर अर्चिका गुप्ता एंड डॉक्टर गुरमीत, डॉक्टर राहुल, ये 3 हमारे मेन पिलर रहे हैं, बाकी सबने सपोर्ट किया है। और साथ में हमारे जो जितने भी रेजिडेंट हैं सबने बहुत मेहनत किया है, तो मैं सबको धन्यवाद देता हूं। और शाम का जो हमारा प्रोग्राम है, जो आज का प्रेजेंटेशन है, उसके लिए आमंत्रित करता हूं। धन्यवाद सभी लोगों को। this and we started.